Ladies and gentlemen, up next we have the first part of the Cardio Fellows debate. The debate topics are as follows. First is colchicine for acute coronary syndrome. Second is TAVR for low-risk AS. Third is echocardiography as pre-participation cardiovascular screening for young competitive athletes. Assessing the debate are our judges. Dr. Ryan Mambulao, Associate Professor at the RTRMF College of Medicine, Secretary of the PHA Eastern Visayas Chapter and Leyte Medical Society, past President of the PCP Eastern Visayas Chapter. Dr. Harold C. Sunga, President of the Philippine Heart Association Central Luzon Chapter, Head of the CCU, Angeles University Foundation Medical Center, and Chairman of the Department of Internal Medicine, Pampanga Premier Medical Center. Dr. Lottie A. Uy, Fellowship in Pediatric Cardiology at the Philippine General Hospital, President of the PHA Zampen Chapter, Consultant at the Zamboanga City Medical Center. The debate is moderated by Dr. Helen Ong Garcia, Vice President, Quality and Patient Safety of St. Luke's Medical Center, Head of the Cardiac Rehabilitation Unit, SLMC-QC and Chinese General Hospital, Section Chief of SLMC Stress Laboratory in BGC, past President of the Cardiac Rehabilitation Society of the Philippines. Debaters are given 6 minutes to debate and 2 minutes for the question and answer.
Good morning, everyone. Welcome to the Philippine Heart Association Debate 2021. And today, we're going to have the Battle of the Brains. We know very well that every year we have a theme. This year's theme is Cardiology Dialectics. It signifies an exchange of stands, statements, and stakes over hotly contested and controversial issues based on the past and the most recent pieces of evidences, which is very relevant now. Dialectics is arguing in the most professional manner your point versus your opponent, points in order to attain the truth of the matter. The mechanics have been given. There will be 11 issues for debate. Each issue will have two sides, the proposition or the affirmation or the opposition, and one issue is a tripartite. Each team comprises of members from each year level, and there will be a main debater per team. Now, the team may provide support information to the spokesperson. Now, for training institutions which are relatively young, who don't have third-year level yet, a second-year fellow will be allowed to become the main debater. Each debater is allotted 6 minutes to make a stand. The proposition will start it, followed by the opposition. The decision of the judges are final. All presentations are pre-recorded as is the norm now. The order of the presentation will be as follows. The first speaker is the proposition for 6 minutes. The opposition will take it as 6 minutes too. For both speakers, only one judge will eventually ask the debaters for clarification or elaboration regarding their stand during the Q&A. And after which, this will be the same also for the opposition. The speakers for the rest of the issue will follow in the same order and format. The responsibilities of the judge will be to choose the top 3 best debate team. Subsequently, we'll rank them accordingly. They will choose the winner per topic and the best debater. The decisions of the judges will not depend on biases or personal preferences, but on those who provide the most convincing and compelling stand on the debate issue. The judges already given their scores to the Google form. Therefore, this presentation is the final nail that will actually mark who will be the winner. These are the criteria. Logic for 30%, quality of references at 25%, the grasp of the debate topic at 15%, audiovisual materials 10%, ability to depend at 10%, deliver at 10%, totaling 100%. And of course, prices are at stake. The first prize will be 25,000 pesos, followed by 20,000 pesos and 15,000 pesos. The best debater will get 10,000 pesos, followed by the first runner-up at 7,000 and the second runner-up at 5,000. And of course, we actually have a very busy day today because we have a lot of topics to talk about. So we decided to give equal importance to each topic. Therefore, they're divided into 3 parts. We're going to conduct first part now. The Board of Judges. Of course, we have Dr. Ryan Mambulao, Associate Professor for RTRMF College of Medicine, Secretary of the PHA Eastern Visayas Chapter and Leyte Medical Society, past President of the PCP Eastern Visayas Chapter. Dr. Harold Suna, President of the Philippine Heart Association Central Luzon Chapter, the head of CCU Angeles University Foundation Medical Center, chairman for the Department of Internal Medicine, Pampanga Premier Medical Center. Last but not the least, Dr. Lottie Uy, a fellowship in pediatric cardiology in the Philippine General Hospital, president of the PHA Sampan Subchapter, consultant of the Zamboanga City Medical Center. Let the battle begin.
The inflammatory hypothesis posits that inflammation is a core process for the pathogenesis of atherosclerotic plaque, its changing dynamics and rupture. Systematic review of Ridker on the lipid trial showed that even after giving high-intensity statin alone or in combination with ezetimibe or PCSK9 inhibitors, high-risk patients who have achieved target or near-target LDL-C still have residual risks for atherosclerosis, and that the residual inflammatory risk remain much higher than the residual cholesterol risk. The contribution of inflammation and atherogenesis simply could not be denied. Moving beyond basic preventive efforts by providing proof of principle for the inflammation hypothesis of atherothrombosis, Cantos laid a foundation of therapeutic targeting of the residual inflammation. Cantos has proven that at least by targeting interleukin-1 beta with a monoclonal antibody canakinumab, it significantly reduces cardiovascular event rates in proportion to the magnitude of hsCRP reduction. Cantos provided a proof of principle that targeting inflammation is atheroprotective. However, non-cost effectiveness and high rates of fatal infection issues limit canakinumab's widespread use. Recent research is now highlighting the capability of a drug known since antiquity in reducing inflammation in patients with chronic CAD as well as in acute coronary syndromes. The results of colchicine RCTs in ACS, however, are mixed. Thus, the role of colchicine in this CAD variant has been the subject of debate. And today, we will be presenting our arguments in favor of colchicine use. The atheroprotective properties of colchicine are myriad and are thought to be mainly related to its effect on tubulin polymerization, enabling a broad range of effect on multiple atherosclerotic plaque cell types and cellular processes. But at the helm of the atherogenesis is the activation of your NLRP3 inflammasome by cholesterol crystals and oxidized LDL. The activation of NLRP3 inflammasome is further amplified during ACS, leading to the secretion of active pro-inflammatory cytokines, which facilitates the expression of procoagulant factors. Colchicine, by inhibiting the NLRP3 inflammasome activation, decreases the downstream release of these inflammatory cytokines. Martinez et al. Has showed the mechanistic proof of these NLRP3 inflammasome ACS colchicine link. ACS patients have the highest transcoronary arterial gradients of interleukin-1 beta, interleukin-18, and interleukin-6 compared to those with stable CAD or no CAD. Their study also demonstrated that colchicine use significantly reduced these gradients by 40 to 88%. In another study, colchicine significantly reduced low attenuation plaque volume, which is a marker of plaque instability in coronary CT angiography, and lowered hsCRP as well. In those patients with STEMI who have undergone PCI, both a smaller infarct size by cardiac MRI and lower CKMB levels were demonstrated in the colchicine arm. The prevailing question is whether colchicine in ACS will translate into improved patient outcomes in clinical practice. Because colchicine trials in ACS have mixed results, we have made a meta-analysis of the 3 ACS-dedicated colchicine RCTs to answer this question whether colchicine is effective in reducing MACE, all-cause death, cardiovascular death, urgent revascularization, and stroke. Compared to placebo, the addition of colchicine to standard care in ACS significantly reduced the risk of MACE by 27% with low level of heterogeneity. The funnel plot suggests no significant publication bias. Colchicine's efficacy in reducing MACE in ACS is our second pro argument. The Colcott trial, the number needed to treat of 61, the ACC computed the mean overall per patient cost to be reduced by as much as 47% during the in-trial period and down to 69% in the lifetime period. This brings us to the third pro-argument, that colchicine is cost-effective. The GI adverse events were not statistically different from placebo, but there is an ARR of negative 0.5% for developing pneumonia. Note that the infection and septic shock rate did not reach statistical significance. This is important because high fatal infection rates were reported in the CANTOS trial. Therefore, a low-dose colchicine is generally well tolerated. After listening to the pro-arguments, the question is, will you then prescribe colchicine to your ACS patients? The answer is, of course, yes. And here is why. First, there is a mechanistic proof that it lowers cytokine release, decreases infarct size, lowers attenuated plaque volumes, and decreases hsCRP. This implies potential for targeted inflammation intervention. Second, low-dose colchicine is effective in reducing MACE as compared to placebo. This is a proof of principle that addressing residual inflammation is atheroprotective. Thirdly, this is a cheap, affordable drug that provides a favorable cost-benefit ratio, particularly when administered on top of current guideline-directed medical therapy. And lastly, it is generally well tolerated, at least in study populations specified in the RCTs. While we are cognizant that this is not a drug for all, it should not be withheld because of fear of adverse event, but rather be given when indicated with responsible monitoring. We are in current time witnessing the serendipitous evolution of a gout drug from antiquity into an anti-inflammatory and anti-ischemic drug. Thank you.
Colchicine has been a well-established drug for treatment of gout and pericarditis, owing to its anti-inflammatory property. It is a broad action targeting not only inflammasome, but it can also disrupt microtubules as well. Thus, it would not be surprising that this anti-inflammatory drug would be experimented on more emergent, if not urgent, conditions involving inflammation in its pathogenesis, like that of acute coronary syndrome. The effect of colchicine in reducing cardiovascular outcomes after myocardial infarction or MI was explored by many researchers, and among these, three trials stood out: the Colcott, Lodoco, and Lodoco 2 trials. Each of the trials agreed that colchicine decreased risk for having cardiovascular event among patients who had MI. However, certain issues need to be addressed. In the Colcott done in 2019, there were 4,661 patients included. The primary outcome was a composite of cardiovascular death, resuscitated cardiac arrest, MI, stroke, or urgent hospitalization for angina requiring revascularization. They concluded that early initiation of low-dose colchicine at 0.5 mg daily after MI will greatly reduce risk for ischemic CV events. They even recommended it to use it as adjunct therapy during hospitalization. However, if such is the case, then why did it take an average of 13.5 days from the time of index MI to randomization and subsequent allocation of the patients to the colchicine and placebo groups? Would it be better if the early initiation of low-dose colchicine will begin immediately after the index MI? Because in that 13.5 days, the patient may have already benefited from revascularization or medical therapy given to them. Furthermore, if colchicine is said to reduce the inflammation due to MI, then why was colchicine used as low dose? In the Lodoco trial done in 2013, 532 patients were randomly assigned to colchicine and placebo arms and were followed for a median of 3 years to detect composite incidence of acute coronary syndrome, out-of-hospital cardiac arrest, and non-cardioembolic ischemic stroke. Again, colchicine at 0.5 mg daily was only used. In the placebo arm, primary outcome occurred in 40 patients, while in the colchicine arm, only 15 patients reached primary outcome. However, it was noted that among patients who had ACS as their primary outcome, there were 17% who were stent related. And further analysis of the Lodoco researchers confirmed that patients randomized to treatment were less likely to present ACS unrelated to stent disease. So does this mean that colchicine has an effect in instant restenosis? Furthermore, the significance of this study is uncertain because of it being an open single-blinded study. Lodoco trial was followed by Lodoco 2 trial in 2020. This was a randomized controlled trial involving 5,522 patients who had chronic coronary disease. The primary endpoint in this study was a composite of cardiovascular death, MI, ischemic stroke, and ischemia-driven coronary revascularization. Results showed that there was only 6.8% in the colchicine group who had the primary outcome, while there was 9.6% in the placebo group who reached primary outcome. This trial had larger number of recruited patients and longer follow-up rate than that of the Colcott, which may have been more convincing to advocate colchicine as adjunct therapy to ACS management. However, it was notable that incidence of non-cardiovascular death occurred more in the colchicine group than that in the placebo group, which was quite alarming. In November of 2020, a multi-center randomized double-blind trial involving 17 hospitals concluded that the addition of colchicine to standard medical therapy in ACS did not alter cardiovascular outcomes at 12 months and was in fact associated with a higher rate of mortality. This was the Australian COPS randomized clinical trial. Also, the fallout among patients assigned in the colchicine group was also higher at 15% compared to that of the placebo group at 8%, primarily owing to gastrointestinal intolerance. Thus, this shows that safety and adverse effect profiles of each drug before instituting in our patients should be looked into and prioritized before administration. There is a reason why colchicine is not included in the Class 1 recommendations in managing acute coronary syndrome. In fact, it was mentioned as having only a Class 2 indication for patients having pericarditis after STEMI and not for patients with ACS alone. More data, more researchers must be done before advocating colchicine as adjunct therapy for our ACS patients.
Thank you very much, our debaters. That was colchicine for acute coronary syndrome. As was mentioned a while ago, only one judge gets the privilege of asking for clarifications and queries. For our affirmative team, may I now call on Dr. Harold Sunga to present his clarificatory notes. Dr. Sunga, please.
Good morning, everyone. For the components, my question, no, on the Colcott trial, they mentioned by these by your opponents that colchicine was given 13.5 days after the MI. It will be better that colchicine will be given immediately after the myocardial infarction, and if colchicine have a beneficial effect on myocardial infarction, why we need to use low dose? Thank you.
So for the first question, there's study by Martinez et al. That the colchicine was given 4 hours to 24 hours prior to the contemplated PCI. And it showed that there is a mechanistic proof that there is a reduction of your cytokine regions, specifically your interleukin-1 beta, interleukin 6, and interleukin, that are really the cytokine that are involved in your atherosclerosis as well as your plaque rupture. So there is evidence and mechanistic proof that when the administration of colchicine will decrease the cytokine, which are the cytokines that are part or is the focus of the plaque rupture. For the second question, as you know, colchicine reduce colchicine binds the tubulin affecting mitosis and various additional functions of microtubules. While at lower concentration, colchicine prevents microtubule polymerization. But at a higher dose, it promotes microtubule polymerization. That is why it is given in low dose. And also, in low dose, as what is presented in the photo, which has the highest population, both the colchicine arm and your control arm has um, the diarrhea and the gastric events is not statistically significant. So it is generally tolerable.
Dr. Suna, are we okay with that?
Yes, ma'am.
Okay, very good. Let's go to the next arm. Because, of course, if there's a proposition, there must be an opposition. And to make it a little bit colorful, we decided to call on another judge to ask the opposition team. Dr. Ryan Mambulao, your take, please.
Good morning, everyone. So, for the opposition, you pointed out that colchicine in the Australian COPS trial didn't show a robust decrease in major adverse cardiovascular events among patients with ACS, and this is in contrast to the findings in the COLCOT trial. What do you think is the reason behind why colchicine, which is an anti-inflammatory drug, didn't show a decrease in cardiovascular events in an ACS patient with a highly inflammatory event?
Doc, first, the major difference of the COPS, the Australian COPS trial, as compared to the other three trials mentioned, the Colcott, Lodoco, and Lodoco 2 trials, is that they tried to increase the dose of colchicine. They actually used 0.5 milligrams twice a day for a month, followed by once daily of 0.5 milligrams colchicine for 11 months. Because they would want to explore, since the colchicine was said to decrease the rate of recurrence of MI, or decrease the cardiovascular events occurring post MI due to its anti-inflammatory effects. They would like to use the 0.5 milligrams BID, which was actually the initial dose that we use for its anti-inflammation in gout. In other diseases involving inflammatory, as well as in pericarditis, we don't actually use a 0.5 milligrams once a day. And so, well, it's one of the major differences in the COPS trial. Also, in the COPS trial, the data came from it was a double-blind, randomized, multi-center, placebo-controlled trial. Unlike, for example, in the Lodoco, it's just an open-labeled, single-blinded study. The three trials, the Lodoco 2 and the Colcott have actually varying research designs to begin with, and also different population. Um, that's why I think it contributed to the different outcomes obtained in the Australian COPS randomized trial.
Thank you very much for that answer. Actually, I think, Dr. Ryan, I'm sorry, but our time is quite tight because we have a lot of things to talk about. So thank you very much for our debaters for the colchicine for acute coronary syndrome topic. Let us now go ahead and talk about the next topic that we're about to actually give. The next topic will actually be TAVR for low-risk aortic stenosis patients. Let us now call on our debaters to let the battle begin renewed. Thank you, our judges, and see you later.
Plato once said that necessity is the mother of invention. We recognize cardiology as an ever dynamic field where each discovery is forwarded with the intent of giving patients better options and ultimately better outcomes. With this in mind, we shall persuade you on why transcutaneous aortic valve replacement, or TAVR, should continue to be allowed in the low risk population with severe aortic stenosis. So severe AS is the most common valvular pathology in the developed nations, and the incidence of degenerative senile AS is expected to rise. TAVR was originally utilized as an effective treatment for patients with symptomatic severe AS with higher extreme surgical risk, and by 2016 expanded to include intermediate risk patients. The landmark trials, Partner 3 and Evolute Low Risk, comparing TAVR and SAVR in patients with low surgical risk, marked the end of a decade-long evidence-based journey that addressed the unmet clinical needs of over 500,000 AS patients globally previously considered unsuitable for treatment. So this was the basis for the fundamental paradigm shifts in our approach to AS management, where the status quo is TAVI being recognized as a safe and effective procedure for treatment of severe AS in all adults, regardless of estimated surgical risk, as per the 2020 ACC AHA guideline for the management of patients with valvular heart disease. With resulting Class 1A recommendations, with preferential recommendation of transfemoral TAVI to SAVR for symptomatic patients with severe AS for more than 80 years of age, or for younger patients with a life expectancy of less than 10 years and no anatomic contraindications. The same guideline states that a patient with low surgical risk is defined as having an STS predicted risk of death at less than 3% and no frailty and no cardiac or other major system compromise and no procedure-specific impediments. So this is the type of patient included in the landmark trials and the kind of patient that we will defend in our argumentation. We expect that the negative side will have to defend why TAVR should not be completely allowed in these low-risk patients, and that concession of any benefit of TAVR would be detrimental to their side. We, the affirmative, firmly believe that TAVR be allowed in low-risk patients, firstly because it provides an avenue to have better hard clinical endpoints at a lower cost. Let's talk about mortality and morbidity. With the Partner 3, including 950 patients, Evolut low-risk trial with 468 patients, and Notion 1 trial, the first all-comers trial up to 8 years, and the STS ACC TVT registry, and the meta-analysis in 2019, including 4 pivotal RCTs. We see primary endpoint outcomes showing TAVR superior to SAVR in the primary composite endpoint of death, stroke, and rehospitalization at 30 days and 1 year for Partner 3, and non-inferior at 24 months for Evolut low-risk trial. And at Notion 1 trial, there was no difference in rates of all-cause mortality, stroke, MI, or these combined, with our STS ACC TVT registry also showing a decreasing in-hospital and 30-day stroke. So for secondary outcomes, we also say that Partner 3 shows a lower rate significantly of new onset AF, as well as shorter index hospitalization and a lower risk of poor treatment outcome and decreasing life-threatening or major bleeding compared to SAVR, as consistent with the Evolut low-risk trial and the meta-analysis in 2019. Let's talk about quality of life. In the same RCTs, there were more rapid improvements in Partner 3 in a patient's NIHA class and 6-minute walk test, as well as those in the STS ACC TVT registry, showing the decreasing or improvement of NIHA class in patients over time, and a reported better or improved quality of life, which was a significant result in the meta-analysis in 2019. We expect that patients would have decreased hospital stay and reduced rehospitalization, further lowering the costs of TAVR by $8,000 to $10,000 and increasing quality-adjusted survival at the same time. So with these better endpoints in mind, we as clinicians are more equipped in empowering our patients to participate in a shared decision-making process by giving them more options other than giving them to SAVR right away. And indeed, these low-risk patients may prefer TAVR over SAVR after talking to them, and maybe for personal reasons that current guidelines and indications cannot encompass. Secondly, we acknowledge the exponential growth of TAVR in the past decade, highlighting the clinical advantages of transcatheter approaches over conventional open heart surgery. And thus, our second argument is that allowing TAVR in low-risk patients provides an avenue for continued growth in the field of cardiology. We acknowledge the knowledge gaps in younger lower-risk patients in terms of valve durability, hemodynamics, or paravalvular leakage, and pacemaker implantation. But with the past years, the challenge of getting better outcomes have led to the development of better valves and better technique as TAVR becomes more commonplace. With the Notion 8 years follow-up leading the results showing hemodynamic valve performance maintained to be superior after TAVI with core valve compared to SAVR. We also see that pacemaker implantation has decreased with increasing better experience of centers for TAVR. And we also see that in aortic valve hemodynamics, there were no results in functional class differences. And this was mainly driven by the use of early generation TAVR valves, which we expect to decrease with further developments in technology. We also see better aortic valve effective orifice areas and with decreasing prosthetic patient prosthetic mismatch in TAVR over SAVR. So all of these in support of TAVR for low-risk patients help provide a new, continuously evolving roadmap for all those involved in the assessment and management of patients with AS. In summary, we, the affirmative side, showed you effective matter and argumentation in why TAVR should be allowed for low-risk patients, since one, it again provides an avenue for better hard clinical endpoints at a lower cost, and two, pushes for the advancement of the field of cardiology, which would benefit all. So at the end of the day, we see a win-win situation for the future of cardiology. Thank you.
TAVR on low-risk patients. No. This is the 2020 ACC-AHA guideline for the management of patients with valvular heart disease. SAVR is indicated for low surgical risk patients, while TAVR is indicated for intermediate, high, and prohibitive surgical risk patients. According to the Journal of the American College of Cardiology, transcatheter versus surgical aortic valve replacement in low-risk patients, this study performed a meta-analysis of randomized controlled trials comparing TAVR versus SAVR in low-risk patients. In low-risk patients with severe aortic stenosis, there were no statistically significant differences between TAVR versus SAVR for stroke, with 3% versus 4.2%, RR of 0.68, 95% confidence interval of 0.43 to 1.07, as well as for myocardial infarction with 1.7% versus 2.1%, RR of 0.78, 95% confidence interval of 0.46 to 1.34. And for valve, heart failure hospitalization with 5.2 versus 7.9%, RR of 0.72, 95% confidence interval of 0.42 to 1.23. As shown in Table 1, few observational registries have attempted to report either actuarial or actual estimates of structural valve deterioration or bioprosthetic valve failure. Unfortunately, a reliable assessment of long-term transcatheter heart valve durability is almost impossible due to very high mortality rates. In addition, these data are typically self-reported with no external validation, which certainly limits their generalizability. The evaluation of other factors associated with structural valve deterioration in transcatheter heart valves has been limited by the relatively small number of patients with long-term follow-up. In conclusion, randomized controlled TAVR trials in patients with longer life expectancy, including patients younger than 75 years, and longer-term follow-up of these trials will be necessary to confirm the non-inferior durability of transcatheter heart valves as compared to their surgical counterparts. Let's talk about the issues on doing TAVR on low-risk patients. We have the durability, complications, cost, local applicability, and invasiveness of SAVR. Durability of surgical aortic bioprosthesis during the first decade showed encouraging data of more than 85% freedom from structural valve deterioration at 20 years. One of the major limitations of long-term transcatheter heart valve durability assessment is the high age and high-risk profile of the initial TAVR populations, conditioning a limited life expectancy and therefore a paucity of patients available at long-term follow-up. THV durability data beyond 8 years were not available until recently. Let's talk about the complications. At 2 years, outcome trends are better for TAVR in low-risk patients except for neurologic event, rehospitalization, myocardial infarction, new permanent pacemaker implantation, endocarditis, and aortic valve reintervention. However, outcome trends are better for SAVR in low-risk patients at 5 years, except for new atrial fibrillation and surgical aortic valve replacement. Issue about paravalvular leak, valve reintervention, and permanent pacemaker. SAVR has lower risk, while TAVR has higher risk. The mortality rate has been higher with TAVI by non-femoral access routes than with SAVR because of the higher comorbidity burden and risk in patients with vascular disease severe enough to preclude transfemoral access. According to the 5-year clinical and echocardiographic outcomes from the NOTION randomized clinical trial in patients at lower surgical risk, patients who underwent TAVR continued to have unchanged lower transprosthetic pressure gradient and larger prosthetic effective orifice area, but more paravalvular leakage compared to the SAVR group. More TAVR patients had moderate to severe total aortic regurgitation of 8.2% versus 0% with p-value of less than 0.001. Let's talk about the cost. SAVR is estimated around 700,000 pesos, while in TAVR it's estimated around 2 million pesos, almost 3 times the price. Let's talk about local applicability. SAVR, many hospitals are doing it for years, while in TAVR, only few hospitals have the capacity and only few doctors are trained to do it. Issue about invasiveness of SAVR on low-risk patients. We have the minimally invasive surgical versus transcatheter aortic valve replacement. In the overall population, TAVI patients had increased surgical risk with median Euroscore 2 of 3.3 versus 1.7% with p-value of less than or equal to 0.001, and 30-day mortality was higher with 1.5 and 2.8% in mini SAVR and TAVI respectively, with p-value of 0.048. TAVI patients had more permanent pacemaker insertion. The choice between TAVR and SAVR can be compared to a Volkswagen versus Humdinger. In SAVR, it is more affordable and has proven durability, while in TAVR, it costs 3 times more, and the durability is still questionable. In conclusion, SAVR is still recommended for low-risk patients with ESC and AHA Class 1 recommendation. As of now, known durability of TAVR is less than 10 years versus SAVR of 20 years. However, a reliable assessment of long-term THV durability is almost impossible due to very high mortality rates. TAVI has higher rates of vascular complications, paravalvular regurgitation, permanent pacemaker implantation, and valve intervention. We should also consider the cost and the local applicability of the procedure. We can choose minimally invasive SAVR as our alternative. Thank you.
Go. Sorry for that technical difficulty. You know, we're in the Philippines, so it's not surprising. So let's go back. Dr. Lotte, is it okay we just do a connecting? Dr. Lotte, your question, please.
Okay. This is for the TAVR proposition group. According to the opposition, TAVR durability is less than 10 years, while SAVR is up to 20 years. And the cost of TAVR is 3 times more expensive than SAVR. Do you think TAVR is cost effective, and would you still recommend it to your patients?
Yes, doctor. I think what the negative side hasn't seen yet is the NOTION 8 years follow-up, which is a recent publication of the first all-comers trial. It showed that hemodynamic valve performance was maintained to be superior after TAVI using core valve compared to SAVR. At the same time, they saw that structural valve deterioration and bioprosthetic valve failure was similar for both surgical and the TAVR arms. So there was actually less structural valve deterioration in TAVI at 14.1% versus SAVR at 28.5% with a p-value of 0.001. We also saw in our meta-analysis in 2019 that there was equivalence in valve hemodynamics over the duration of the study between TAVR and SAVR valves. we also saw in the partner 2 trial, the 2 follow-up of the partner 3 trial, that although procedural costs were initially higher with TAVR than SAVR, the cost differences for your index hospitalization were only $2,000 higher for TAVR. What this means is, even though the TAVR valve may be more expensive overall, this cost is offset by the reduced length of TAVR stay in the hospital, reduced incidences of rehospitalizations, and overall, there's also better quality of life. So with reduced follow-up costs with TAVR, we see that overall, it provides still a more cost-effective option than SAVR. We also
Thank
see
you
that
very, thank you very much. Thank you. Sorry
yes,
for that because we are in a time
yes,
frame,
yes, doctor. Thank
and
you.
of course the technical difficulties did not help us. Thank you very much for that. Now
Thank
let's
you,
go
doc.
now to our. Thank you for that answer and that question, Dr. Lotti. Now let's go now to the opposition. Dr. Shunga, are you ready to question the opposition for TAVR?
Yes, ma'am. Again, good morning. For the opposition, can you comment on this that cover provides a better outcome and provides also a good quality of life?
Sir, in terms of the quality of life, there was an improved outcome cover based on the Kansas City Quality Questionnaire. However, it is only from 0 to 30 days that there was a reduction in the improvement in quality of life. And after 1 year, the results of the scores disappeared, sir, in terms of the quality of life, sir.
Okay, I would encourage you to speak louder, though I think we heard them, right, Dr. Suma? Any more
Yeah.
questions for the opposition? Are we okay, Dr. Harold?
Yes, ma'am.
Okay, thank you very much. Thank you very much for our debater, for TAVR. Let us look what the future will hold based on what our young generations given us. Now for the last topic. Thank you very much, and our judges will see you again. Thank you very much, our debaters. Good luck. Now for next topic, let's talk about echocardiography as pre-participation cardiovascular screening for young competitive athletes. Very, very controversial. Let the battle again begin.
Echocardiography as pre-participation cardiovascular screening for young competitive athletes. Pro side, good day. On July 23, 2016, a Filipino PBA player by the name of Gilbert Bulawan was seen collapsing while practicing at the gym with his teammates. At the age of 29, he is the youngest player to die in PBA. And what was the cause of death? Sudden cardiac arrest. Sudden cardiac death in sports is tragic, but according to sports medicine experts, such an event is preventable. A competitive athlete is defined as an individual who participates in an organized team requiring a systematic, intense training. Habitual, vigorous exercise is potent stimulus for adaptive structural and functional cardiac remodeling. However, in athletes with underlying cardiovascular disease, this may be a potential stimulus trigger of adverse events, increasing the risk of sudden cardiac death. Several studies already established relationship between exercise training and cardiac change. This differ with respect to the amount of stress leading to exercise-induced cardiac remodeling. Study by Oxoboro clearly demonstrated algorithms delineating whether these changes are physiological adaptation or abnormalities. So what is the implication? The aim of echocardiography is to differentiate physiology from pathologic adaptation so that there is enhanced sensitivity to detect asymptomatic cardiovascular disorders and reduction in the rate of temporary disqualification that require future imaging for definitive clarifications. The reported incidence of sudden cardiac death in both US and Europe is quite variable. Elaborated by Radmilovic, the assessment of the precise frequency of sudden cardiac death is hindered by the retrospective nature of most analysis. Looking on each etiologies both in the US and Europe, majority are still attributed to heart disease, particularly HOCM and idiopathic LVH. Although in contemporary studies, sudden arrhythmogenic death syndrome or SADS predominates, structural heart diseases still comprise many sudden cardiac death cases in young athletic individuals, providing a substrate for malignant arrhythmias leading to cardiac arrest. To elaborate the benefits of echo in terms of diagnostic accuracy, some of the cardiac structural changes that are usually missed on PE or ECG can be easily detected by echo. Together with the previous probability, sensitivity, specificity, and computed positive likelihood ratio, Plotting on the normogram yields a very significant post-test probability that the patient has the condition after echocardiography. The AHA and ACC follows history and P as the mainstay of screening using 14-point questionnaire. However, a study concluded that this produces a higher number of false positive results with lower sensitivity and very low positive predictive value. In ESC, ECG is boarded in the screening. It has 70% sensitivity to detect the most frequent cause of sudden cardiac death. However, about a third of these athletes with structural diseases presents with normal ECG. Two-point justifications against our use of ECG alone is that it may produce false positive findings from history, P, and ECG, as mentioned in the studies by Malhotra and Funch. But the second issue, which is a false negative finding, is more concerning. Baggage and others showed a remarkable number of cardiac abnormalities detected through echo, but were missed by screening through history, P, and ECG. And another study by Rowan and others demonstrated the problem of false negative screening results. And so what is the current update? Today, as COVID-19 progresses, future concern for potential long-term complications in athletes arises. A study by Phelan showed that through echo, diminished RB performance appears to be the most common finding in COVID-19 patients, linking to lower RB longitudinal strain, which most accurately predicted a higher risk for mortality. It is not difficult to zero in that the reason not to submit young competitive athletes to echocardiography for pre-participation assessment is the fundamental economics attached to it. Amos Tversky and Daniel Kahneman are perhaps best known for the development of the prospect theory, which shows that decisions are not always optimal. It is influenced by the way in which choices are framed. But what if usual pre-participation choices were framed this way? 5,000 pesos added cost for echocardiography for pre-participation screening versus 15 million peso loss cost for potential loss of revenue from death or disability for misdiagnosis or death of an athlete's son or brother. Tversky and Kahneman's work shows that the responses are different if choices are framed as a gain or a loss. This happens because we dislike physical losses more than we like an equivalent gain. And giving something up is more painful than the pleasure we derive from receiving it. The principle of cause and benefit analysis of the British economist Alfred Marshall states that when confronted with a dilemma, positive or negative aspect must be expressed as bottom line. And when human life is encrypted in the equation, it becomes incalculable because it is priceless. When the power to prevent catastrophe is within your reach, let your conviction be the influence. After all, a life saved is a life shared. It is more than a figure because life is more than a statistic.
Good evening, everyone. We, as today's opposition, strongly believe that the topic of interest is unsuitable in our local setting. But before we proceed, we would like to define some important points. We believe that what the topic means is the mandatory or routine use of echocardiography as a screening technique in all young competitive athletes. We defined young athletes as athletes who are less than 35 years of age. Our team stands with the majority of cardiology societies who universally support pre-participation screening. The American Heart Association recommends only medical history and physical examination, and this has been ongoing for more than 3 decades. And the ESC includes the use of 12-lead ECG in pre-participation screening of these young athletes. In addition, approximately 97% of cardiac conditions can be detected with a thorough medical history and physical examination alone. The Europeans have advocated pre-participation screening without the use of echocardiography for more than 10 years, and they have been able to recognize the following cardiovascular abnormalities, such as rhythm and conduction abnormalities, hypertension, valvular heart diseases, and hypertrophic cardiomyopathy. A validated cardiovascular screening questions have already high yield in detecting conditions that may preclude a young adult to participate in athletic events as shown. With this, we can effectively say that obtaining echocardiogram should remain optional and not as first-line strategy in pre-participation screening. Again, before we move on on our next argument, we would like to emphasize that guideline-based management is the best option in treating our patients because they have been established through extensive research, randomized controlled trials, and expert consensus. Secondly, the use of routine echocardiogram is impractical and is not cost-effective. Most data showed that cardiovascular sudden death occurred approximately 1 in 80,000 to 1 in 200,000 participants per year. A 26-year period study by Maron et al. Showed that among almost 2 million sports participants, only 13 sudden deaths occurred related to physical exertion. And this is almost equivalent to 1 is to 341,000 sudden death rate and similar in frequency to that of a fatal lightning strike. Some may argue that cardiac structural diseases like cardiomyopathy, coronary artery disease, and arrhythmogenic right ventricular cardiomyopathy, etc., can be missed on physical examination in ECG, and that echocardiography is needed to detect these cases. However, pre-participation screening is enough. In a study by Rizzo et al., it was confirmed that PE and ECG have high sensitivity in raising clinical suspicion predisposing to sudden cardiac death. Echocardiography can be quite expensive with a price range of 2,000 to 8,000 pesos in our local setting. In Italy, echocardiogram remains to be a downstream testing and not a primary screening tool. A study done in Padova by Corrado et al. Showed that among 33,735 screened athletes, only 0.07% tested positive for hypertrophic cardiomyopathy. This equates to 90% screening specificity using clinical history, physical examination, and 12-lead ECG alone. In a study by Gragioli et al. In 2017, among 1,650 young athletes, the total combined cost of American Heart Association questionnaires and ECG is significantly lower than doing an additional echocardiogram. This may impose additional burden on the individual athlete or the governing sports body. High prevalence of left ventricular trabeculations in athletes are suggestive of cardiac adaptation. Extreme right ventricular remodeling cases in elite ultra-endurance athletes may be indistinguishable from arrhythmogenic right ventricular dysplasia. Likewise, in some athletes, left ventricular remodeling can be very extreme. In a study by Felicia et al., it showed that 10% of elite ultra-endurance athletes have left ventricular end diastolic diameter of more than 60 millimeters, which can be mistaken for hypertrophic cardiomyopathy. All these confounding factors could further subject them to further unnecessary workup, and this could create anxiety to the athlete and the athlete's family, and could be a potential for unjustified exclusion from competition. In summary, routine use of echocardiography in pre-participation screening is not guideline-directed. Evidence-based guidelines supported by numerous studies have already showed that there is still insufficient indication to recommend echocardiogram for routine screening. Its use is impractical and not cost-effective, especially in our local setting, and it may create false positive results, which can lead to further unnecessary costs, psychological and emotional repercussions, and unjustified exclusion of competitors.
Thank you very much. Dr. Mambula, are you ready to question them?
Yes, ma'am. Good morning, everyone. So my question to the speaker is, we are comparing to the echo versus ECG as a screen test, and sometimes both tests are complementary, not competitive. But what are findings that can be seen onto the echo, which cannot be shown on ECG?
The affirmative team, go ahead and answer.
Good morning, everyone.
First, before we answer, we would like to point out the topic on the justification against use of ECG alone for the study of Malhotra and Funch. It said that history and ECG produce false positive findings, as mentioned by this study. And the second issue is by Bagish, who said that the remarkable number of cardiac abnormalities detected through echo but were missed by screening through history. So in the echo, we can distinguish, we can identify findings in RVOT, in RV enlargement, which we could actually point out whether this is a physiologic or pathologic, and this helps us to determine whether this athlete has a concentric hypertrophy or eccentric hypertrophy. And further in echo, we can also be guided by TAPSE, by RV FACT, as well as RV lateral TDS. And of course, through this, it gives us a sensitivity whether this athlete, though he is asymptomatic, he could have cardiovascular disease, which could also prevent a sudden death in the future. Also, this echo can also guide us in making proper decisions whether this athlete can be disqualified initially, which could hinder his potential outcomes or being a super athlete or a champion in the future, because we haven't exhausted all the possible means to determine whether he's qualified or not. And more than that,
Thank you very much. Thank you very much. Sorry for that, because you know very well that we have a time frame, but thank you very much for that very comprehensive answer. Now for the opposition, Dr. Lottie, are you ready to question them?
Yes. So for the opposition, if we will only consider history and PE for the pre-participation screening for young athletes, do you think that would be enough to differentiate physiologic changes of an athlete's heart versus anatomic abnormality?
No, ma'am. If we're only going to consider the physical examination and history.
Yes.
Actually, based on the studies, that has low specificity and sensitivity. That's why they added the ECG as a tool to assess sport athletes for pre-participation screening, ma'am. But based on, yes, ma'am.
So how can you differentiate physiologic changes of an athlete's heart versus anatomic abnormality with the ECG alone?
It could be just as a screening tool, ma'am. So there are cases that ECG is abnormal up to 95% of patients with hypertrophic cardiomyopathy. We are presenting with LVH on ECG and
with use of ECG.
Sorry. So you go ahead.
I'd like to remind the debaters you have 20 seconds left. Could you please answer? Debaters?
Ma'am, with use of ECG, we can differentiate an adaptive physiology or cardiac exercise-induced cardiac remodeling, because in athletes who are on consistent endurance exercises, such as those who are on long distance running, cycling, or swimming, there is constant elevation of the cardiac output with normally reduced peripheral vascular resistance. Hence, this leads to more to stimulation or dilation of all cardiac chambers. However, for those cases, athletes who are on constant strength exercises, such as those who are on weightlifting or football athletes, due to their pulsatile increase in peripheral vascular resistance and minimal increase in cardiac output, there is persistent pressure challenge in the left ventricle. Hence, it will be reflected in the 12-lead ECG as isolated left ventricular hypertrophy alone.
Doctor, I'm sorry. I did mention that a while ago I did give a sign regarding the time, and we actually did a little bit of an extension for you for about 20 seconds, but we have to stick to the time. The time for you to answer is 2 minutes, for which I actually recorded in my iPhone. So I'm very sorry to say that probably the time to answer has already lapsed. And I think you've already, Dr. Alotti has listened to your concourse, and hopefully that she actually got there your answer already. Thank you very much, debaters. We have to stick to the rules, and of course, this is competition, so you have to understand. But thank you very much for everyone for a very very good discussion. We will take into account also the time frame that you actually answered your question, because as mentioned, this is the Philippine Heart Association. Everything is scientific, database, and objective. So with that, I'd like to thank all debaters for this morning, for everything that actually has transpired. Very congratulations, very good presentation. For our judges, thank you very much. We'll see you again this afternoon as we continue the debate 2021 for the Philippine Heart Association. Thank you very much.
Thank you, participants. The Cardio Fellows debate will resume later in the program. Ladies and gentlemen, we now move on to our Day 1 lunch symposium with a lecture on fixed dose combination therapy to improve hypertension treatment and control, presented by Dr. Reinhold Kreitz, President of the European Society of Hypertension, Director of the Department of Clinical Pharmacology and Toxicology at Charité Universitätsmedizin, Berlin, Germany, Professor of Hypertension and Clinical Pharmacology, alumni of the Howard Hughes Medical Institute in the USA, International Scientific Fellow of the American Heart Association, European Hypertension Specialist of the European Society of Hypertension, Associated Member of the Drug Commission of the German Medical Association, Member of the Scientific Council of the ESH and the European Society of Cardiology Council on Stroke. He has authored and co-authored over 250 papers in peer-reviewed journals. This symposium is brought to you by Sanofi and is moderated by Chairman Dr. Rodney M. Jimenez, PHA Director and Chair of the PHA Continuing Education Program Committee, Assistant Professor, College of Medicine, University of the East Ramon Magsaysay Memorial Medical Center, Incorporated, Training Officer, Adult Cardiology Fellowship Training at St. Luke's Medical Center in Global City, Training Officer for the Clinical Research Fellowship of the Cardiac Catheterization Laboratory of SLMC BGC and SLMC Quezon City.
Dear colleagues, good afternoon. Welcome to this session. My name is Reinhold Kreutz. I'm from Berlin, Germany, and I'm happy to discuss with you today the role of fixed-dose combination therapy to improve hypertension treatment and control. So let me first start with the core drug treatment strategy for uncomplicated hypertension as it has been recommended and published in our 2018 European ESC/ESH guidelines. It's important to note from the very beginning that from the start, we actually recommend to start with a dual combination therapy, preferably using a single pill approach by combining a RAS blocker, that could be either an ACE inhibitor or angiotensin receptor blocker, together with a calcium channel blocker or a thiazide or thiazide-like diuretic. To start with monotherapy is also possible, but most likely only in a few patients with low risk grade 1 hypertension or in the very old, frailer patients. But even in those patients, you might start with a dual combination using a RAS blocker as a backbone therapy using low dose dual combination. If blood pressure is not controlled, you can combine all three classes, a RAS blocker plus a calcium channel blocker plus a diuretic, using triple combinations, also possibly using single pill combinations. In patients that cannot be controlled with the triple combination, we use the term resistant hypertension to characterize these patients. And based on a very elegant and important study that tested the best drug lowering approach in the resistant hypertension situation, we recommend to use spironolactone in a low dose, 25 to 50 milligrams once daily. Alternatives are intensified diuretic treatment or use of an alpha blocker or a beta blocker. But spironolactone actually is the most efficacious drug in this situation. Patients that can still not be controlled, in these patients, we might consider to refer to a specialist center for further investigations. Even though beta blockers belong to the first-line blood pressure lowering drug classes, they are not recommended from the very beginning because beta blockers are somewhat inferior in terms of reducing the risk, particularly for stroke. However, they can be used at any treatment step when there's an indication, and I come back to this later for beta blockers. It's also important to know that this core drug treatment algorithm is also appropriate for most patients with hypertension-mediated organ damage, such as left ventricular hypertrophy or patients with microalbuminuria, and also in patients with cerebrovascular disease after stroke, diabetic patients, or patients with peripheral artery disease, and also, and very importantly, also the elderly. So this core drug treatment approach I mentioned to you applies to many patients, and it's important to note again that the backbone of therapy is the use of a RAS blocker because of their impact on these patients, not only for blood pressure control, but also for risk reduction. Obviously, this posed a problem in the context also, which I have to discuss in very brief, the COVID-19 pandemic, because the renin-angiotensin system, which is shown here, also exists in the lung, in the respiratory system, with its classical canonical pathway, the red pathway that leads not only to blood pressure control and cardiovascular remodeling and also kidney damage, but it's also involved in lung injury in patients with infections, with sepsis, with pneumonia. We know that. And we can block this pathway with ACE inhibitors or angiotensin receptor blockers, we know very well. There's also a counterbalancing protective arm in the renin-angiotensin system, which is actually activated by ACE2, which is an homologous enzyme to ACE, but it's not blocked by ACE inhibitors. ACE2 is very important, as we all know, because it represents the pivotal cell entry receptor for SARS-CoV-2 virus, and therefore for COVID-19, for cell entry in the host cells and also replication, therefore for initiating the COVID-19 disease infection. And there was a link, obviously, between the renin-angiotensin system and the ACE2 enzyme. And at the beginning of the pandemic, there was a suspicion that the use of RAS blockers might increase the infectivity for SARS-CoV-2 and for COVID-19 because there was a suspicion that the RAS blocker could upregulate, increase the level of ACE2 and thereby increase the infectivity, which was actually largely due to not convincing experimental data in animal models, and certainly that was not shown actually in the lung. We looked at this at the very beginning in the European Society of Hypertension COVID-19 task force because we wanted to counterbalance and respond to this suspicion that was brought forward at the beginning of the pandemic. And we concluded that there was actually no convincing evidence that RAS blockers could increase the infectivity for the COVID-19. Very early in March 14, we recommended, therefore, that in stable patients with COVID-19 infections or at risk for COVID-19 infections, treatment with ACE inhibitors or angiotensin receptor blockers should be executed according to the recommendations in our 2018 European guidelines. And we also stated that the currently available data on COVID-19 infections do not support the differential use of RAS blockers in COVID-19 patients. So basically, they should be used according to the guidelines. So in summary, during the last year, several studies have been looked into that, and it was really difficult to predict the role of RAS blockers in COVID-19 patients, particularly the expression of ACE2 in the lung. We can predict what happens with renin. It will go up, and the angiotensin peptides will be influenced by treatment, but it was unclear what happens actually in the lung and the respiratory system. But some studies have now been published, and I have to present here and summarize them. They are good news because in the pivotal organ for initiation of the disease for COVID-19, so these are the ciliated cells in the upper and lower respiratory tract, and also the in the alveolar epithelium, the pneumocytes that express ACE2 receptors. There's no evidence that RAS blockers, either ACE inhibitors or angiotensin receptor blockers, can actually upregulate per se in this tissue the ACE2 expression. What we know in patients with COVID-19 disease, so with the SARS-CoV-2 infection, that there's actually upregulation of ACE2 in the patients on the messenger RNA level, has not been shown on the receptor level, on the protein level. And this is due to activation by interferon because of the infection as part of the cytokine and immune response. But again, RAS blocker use or also hypertension per se does not affect the expression of ACE2, modify the expression of ACE2. So actually no increased risk for infectivity. So in summary, I also would like to briefly show what has been done in the terms of clinical studies. There are a lot of observational studies that analyze the use of RAS blockers and the risk of association with COVID-19. And one of the first robust and very important studies was the study reported in the New England Journal of Medicine at the 1st of May last year by Professor Mancia, our chair of the educational committee and former president of the European Society for Hypertension. And he conducted this study in Italy, in Milan, Lombardy region, which was heavily affected during the first wave with COVID-19 in Europe. They analyzed 6,272 patients with confirmed COVID-19 disease very early during the pandemic, matched them in the 1:5 ratios with more than 30,000 controls, matching for sex, age, and municipality of residence. And then they looked the association between RAS blocker use and the risk for COVID-19. And here you see the odds ratios for ACE inhibitors, angiotensin receptor blockers, and also mineralocorticoid receptor antagonists such as spironolactone. You see there is close to 1. There's no increased risk and no significant association. So basically absolutely no increased risk with the use of RAS blockers. And the same applies also when the investigators looked into the other first-line blood pressure lowering drugs, calcium channel blockers, beta blockers, and the thiazide-like diuretics. No increased risk for COVID-19. All these studies until the end of the last year, and it continues to be the same, have been meta-analyzed by Professor Franz Messerli and Professor Mancia together with other colleagues. Case control studies such as the study by Professor Mancia or cohort studies, altogether 31 cohort studies, almost 90,000 patients, looking into the question whether RAS blockers were associated with COVID-19. And as you can see in the forest plots, absolutely no increased risk, neutral results. So there was no effect on all-cause mortality, severe COVID-19, or also the risk to develop COVID-19 disease. So take-home message is that based on the available evidence, we can use and follow the core drug treatment strategies, most importantly using RAS blockers, but also the other first-line blood pressure lowering drugs during the COVID-19 pandemic. Now coming back to the details of the drug treatment approach, and particularly the important role of the RAS blockers. Obviously, the angiotensin receptor blockers and the ACE inhibitors are very potent and effective drugs, and this applies also to the angiotensin receptor blocker irbesartan. And it's appropriate to announce now that there's actually this year the 20-year anniversary for landmark studies in the field of hypertension and organ protection, when we look back into the famous studies that analyzed the role of irbesartan as an angiotensin receptor blocker to protect against the development of diabetic nephropathy in patients with type 2 diabetes in the famous IRMA study published in the New England Journal 20 years ago. And what you can see that the use of irbesartan in a dose-dependent manner reduced the risk to develop albuminuria and diabetic nephropathy, so the development of diabetic nephropathy in patients with type 2 diabetes, with a significant risk reduction in the higher dose using 300 milligram irbesartan, and that occurred on the background of similar blood pressure reduction between 300 and 150 milligrams. So the dose-dependent organ protective effect of the angiotensin receptor blocker irbesartan at a high dose. The other landmark study published in the same year was actually in patients with already developed diabetic nephropathy, whether the renal progression, the renal outcomes could be improved by treatment with the angiotensin receptor blocker irbesartan. And you see here also a significant risk reduction in the primary endpoint, renal endpoint, as compared to placebo, 20%, or as compared to amlodipine treatment with the use of the angiotensin receptor blockers. And it occurred on the background of similar blood pressure reduction. So again, highlighting the organ protective effect in this study, the nephroprotective effect of the angiotensin receptor blockers. Then this is one of the reasons why we recommend now RAS blocker therapy, and including angiotensin receptor blocker therapy as a backbone of treatment in hypertensive patients, not only in those with already organ damage, such as these type 2 diabetic patients. Now, in terms of combination therapy, to combine a RAS blocker such as irbesartan, the angiotensin receptor blocker, with the calcium channel blocker, amlodipine is very, very efficacious and in terms of blood pressure lowering. And that has been shown also in this study, a nice study, the iCombine study, for instance, which was a phase 3 prospective randomized open label with blinded endpoint evaluation study. So almost 300 patients with a mean age of 57 years with essential hypertension were first of all treated in a run-in phase with amlodipine 5 milligrams. And then those patients were randomized that had still under amlodipine 5 milligrams an office blood pressure systolic elevated over 145 millimeter mercury. And then they were randomized in a 1-to-1 ratio to either continue with amlodipine or a fixed dose dual combination therapy with irbesartan plus amlodipine. And the results are shown here. First of all, the primary endpoint was home blood pressure measurement, which is very important now for my presentation, but also these days, because we recommend out-of-office blood pressure measurement and monitoring, such as home blood pressure measurements in our patients, to use this as much as possible. And what you can see here is after early treatment, after 5 weeks, which was the primary endpoint in this analysis, the effect on home systolic and diastolic blood pressure. Those patients in gray that continued with amlodipine monotherapy, and those patients in blue that were randomized to the dual combination. You see the significant greater reduction in blood pressure with the dual combination therapy, 12.4 millimeter mercury systolic in home blood pressure reduction, additional home blood pressure reduction, and 5.6 millimeter mercury additional home blood pressure reduction as compared to the lower reduction in those patients who continued with monotherapy. When we look at the patient number of, or the frequency of patients that can actually be controlled in terms of systolic blood pressure levels lower than 135, which is the target for home blood pressure, and 85 millimeter mercury diastolic. And we see that with the combination therapy as compared to monotherapy, a significantly greater amount, almost half of the cohort could be controlled, achieved the target blood pressure for home blood pressure measurement. Now, importantly, in the study continued for another 5 weeks, and the patients were up-titrated with additional treatment with 5 milligram amlodipine. So both for the monotherapy as well as for the dual combination therapy. And what you can see with the uptitration of amlodipine, showing the potent blood pressure lowering effect of amlodipine again, you see already the increased frequency of patients that can be controlled, 44.3% with the monotherapy. But again, with the combination therapy, if we uptitrate the dual combination using amlodipine uptitration from 5 to 10, on the backbone again of 150 milligrams irbesartan, you see that almost two-thirds or more than two-thirds of the patients after 10 weeks can be controlled in home blood pressure monitoring with this potent dual combination therapy. So when we look into the potential contraindications for the first-line blood pressure lowering drugs, we can first of all acknowledge that the RAS blockers have limited problems, but clearly in patients with hyperkalemia or bilateral renal arterial stenosis and pregnancy, both ACE inhibitors or angiotensin receptor blockers are contraindicated, while they should be used with caution in women of childbearing potential without reliable contraception, because of the known effect during pregnancy, a teratogenic effect on the patients with pregnancy, on the fetus. However, if you look into the calcium channel blockers, there are almost no compelling contraindications. Only possible contraindications or cautious use is recommended in those patients with severe heart failure, HFrEF with reduced ejection fraction, and tachyarrhythmia, and potentially in patients with pre-existing severe leg edema. And that is the side effect which also applies to amlodipine, particularly if we increase the dose from 5 to 10 milligrams. Obviously, also the other drugs have compelling or possible contraindications. And also, as we know, particularly in the Asian populations, the limitation of ACE inhibitors is the lower tolerability because of the high frequency of cough in patients, particularly the Asian populations, and potentially a classical contraindication is previous angioneurotic edema, which does not apply to angiotensin receptor blockers because they are not associated with an increased risk for angioedema. Now, talking about the tolerability of amlodipine, it's largely very good. As I mentioned already, if we increase the dose, particularly from 5 to 10 milligrams, there's an increased risk for developing peripheral edema, particularly in women, also in summer in the hot phases in Europe, and maybe also obviously in your country and your region, it could be a problem. There was only a low number of patients that actually, in the previous study, in the irbesartan combined study, I showed you that developed during monotherapy angioedema, but as you can see, not angioedema, sorry, peripheral ankle edema, but as you can see in the combination therapy, which is very well known, there were no patients that actually developed severe peripheral edema that led to the discontinuation of treatment. So the combination of a calcium channel blocker with a RAS blocker such as irbesartan will protect actually or reduce the risk for developing peripheral edema. And this is based on the hemodynamic unique situations in the combination therapy, because we know when we use a calcium channel blocker, the potent vasodilation and blood pressure lowering effect, as you have seen, will develop, and therefore also there will be, because of this precapillary vasodilation in the capillary bed, this treatment will increase the blood flow and also the pressure, and therefore contribute to the development of edema, particularly peripheral edema in the lower extremities, such as the ankle edema. In this situation, angiotensin II may actually lead to post-capillary vasoconstriction of the venoles at the vascular capillary bed and increase the pressure in the capillary bed and the development of edema. But if we combine now a calcium channel blocker with a RAS blocker, the vasodilation here may be even enhanced, but also the outflow of the capillary from the capillary bed is increased and the pressure is reduced, and therefore the edema is reduced, because the RAS blocker preferentially will also induce a vasodilation, venous vasodilation here in the capillary bed, and that will contribute to the or explain the reduced risk in the combination of a RAS blocker with a calcium channel blocker with regard to the development of peripheral edema. Now, the irbesartan-ED study actually showed the other way around, tested the hypothesis how the addition of amlodipine to a backbone therapy with an angiotensin receptor blocker can improve the blood pressure lowering situation. Also, again, using the same protocol, home blood pressure measurement. And what you can see here in this randomized controlled phase 3 prospective study, 325 patients were initially treated with irbesartan 150 milligrams, and those that had still elevated office blood pressure were then randomized in the 1-to-1 ratio to continue with monotherapy irbesartan or to the fixed dose combination, again with irbesartan plus amlodipine. And the addition of amlodipine to irbesartan 300 milligram leads here after 10 weeks to a substantial blood pressure lowering effect, as you can see here, 18.7 millimeter mercury as compared to 9.9 with monotherapy, and 8.6 as compared to 3.9 in home blood pressure, systolic and diastolic blood pressure reduction in the fixed dose combination therapy. And when we look at the frequency of patients that could be controlled with the combination therapy after 10 weeks, more than half of the patients using the combination could be controlled as compared to 31.8% of the patients with monotherapy. So taken together, these are important results, and they are also kind of highlighted in the 2020 recommendations of the International Society of Hypertension, basically that use the same approach such as our European guidelines recommendation for the core drug treatment approach, but they emphasized some subtle differences, which are actually also highlighted in my presentation and in the studies using irbesartan and amlodipine combination therapy. First of all, they have a 4-step approach, and they divided the first step into 2 steps, which are of clinical relevance, and which is important to emphasize again that we can use obviously single pill combinations very effectively, and there are several advantages which I will discuss at the end of my presentation again, but there's also the possibility to explore the dose titration, up titration, using a fixed dose combination, as you have seen by, for instance, up titration starting with 5 milligrams amlodipine plus the angiotensin receptor blocker irbesartan, for instance. You can up titrate using the same combination from 5 to 10 milligrams amlodipine and the background of the angiotensin receptor blockers, and thereby increase the likelihood and the frequency of patients that can be controlled effectively. The other point, which is kind of interesting in the 2020 ISH recommendation, and which is different from the European recommendation, that they actually prefer the use of a calcium channel blocker over the use of a diuretic from the very beginning, because they claimed and suggested that calcium channel blockers are very effective, particularly amlodipine, which is the most widely studied calcium channel blocker, and also has no significant contraindications limitations as I summarized already in my previous slide. They also emphasized that, for instance, in special patient groups, particularly in Black patients, looking at the global level, calcium channel blockers may be also substituted or replaced primarily by a diuretic from the very beginning, because diuretics have been shown to be very efficacious also in blood pressure lowering in Black patients. So there's some ethnic differences in terms of response. And that was the reason to prefer for the majority of patients, however, in the ISH recommendations, calcium channel blockers, except the plaque patients. When we look into the clinical conditions or characteristics of patients in which we might use thiazide-like diuretics as compared to the calcium channel blockers. These are the plaque patients, as I indicated, but also other clinical situations, such as in the elderly, in obese patients, patients with diabetes, and patients with renal impairment. If the glomerular filtration rate is still above 45 or at least 30 milliliter per minute, if it's lower in patients with more severe chronic kidney disease, we have to switch to loop diuretics, which is a problem in terms of blood pressure control anyway, and also patients with heart failure. These are the conditions where thiazide-like diuretics may be used, but nevertheless, it's important to note that in these patients that are salt sensitive, and that's the reason why diuretics could be used, calcium channel blockers are also very effective in salt sensitive situations and can therefore also be used in plaque patients, in the elderly, in the obese patients, and also in the diabetic patients, and even also in the renal impaired patients. Calcium channel blockers are effective in terms of blood pressure lowering. Regarding the beta blockers, when should the beta blockers be used as an alternative to the core treatment approach? These are particularly the patients with heart failure, particularly HFrEF patients actually, which very often do not have that high blood pressures anymore. But heart failure is a classical and other cardiac indications situation where we should use the beta blockers at any treatment step if there's a cardiac indications such as heart failure, angina, post-myocardial infarction, and also for heart rate control in patients with atrial fibrillation. Clearly, they are very important, and also in younger women with pregnancy or planning pregnancy, because beta blockers are safe in pregnancy, while the RAS blockers are, as I mentioned, contraindicated in this situation. So let me now also talk a little bit about the importance of home blood pressure monitoring, which is particularly important now also during the COVID-19 situation and the lockdown that we experienced through the last years, but also in general and in the future. And that has been tested in these combination studies I mentioned to you, and you have seen that home blood pressure can be controlled with combination therapy using, for instance, irbesartan and amlodipine in a very efficacious way. So the COVID-19 pandemic had many issues that related to blood pressure control and hypertension, many challenges. And we summarized this in our European Society of Hypertension Task Force review, affecting individual risk factors, changing in the risk profile that might impair blood pressure control and lead to more hypertension and also more complicated hypertension. Also, environmental factors are affected actually in a positive as well as in a negative way, as shown in the green and in the red. But the lockdown obviously restricted the healthcare in general, but also the management of hypertension, particularly at the office, the physician's office, or at the clinic level, and therefore the need for home blood pressure monitoring has clearly been emphasized in the COVID-19 pandemic. Therefore, it was quite timely when we published on March this year our consensus document of the European Society of Hypertension for guidelines for office and out of office blood pressure measurement. And they are contributed not only the European authors of the European Society of Hypertension, but also 35 international collaborators from around the world on this document, which is freely available to be downloaded and will be translated now in different languages. I briefly would like to summarize the essentials of this consensus document in terms of how we should, how we recommend how we should measure blood pressure. First of all, the office blood pressure. So it's very important to have the patient seated in an appropriate way with a supported back And we clearly prefer the use of upper arm automatic blood pressure measurement. It is important that the patient should be at rest for at least 3 to 5 minutes without speaking, talking, etc., as you see in this infographic. We should use 3 blood pressure measurements at 1 minute intervals, at least 2 if the variability is low, and average the last 2 measurements. The validated electronic upper arm devices should be used, and there are many validated upper arm devices available around the world, including your regions, and you can look them up, the blood pressure devices you might use, in the Stride blood pressure webpage, which is a supported research project by the European Society of Hypertension, International Society of Hypertension, and the World Hypertension League, where you can look up the appropriate devices that are available for measurement for you. Also for home blood pressure monitoring, because the recommendations, the method how to measure blood pressure in the office actually applies also for home blood pressure monitoring. So in terms of schedule, what could be done for the patients at home, measurement at least for 7 days, ideally, or at least 3 days before each office visit or any physician contacts by, for instance, telephone call or remote contact possibilities. And the blood pressure measurement should be executed before drug intake, if treated, and before meals, once in the morning and once in the evening. 2 measurements on each occasion with 1 minute between them would be appropriate. For long-term follow-up, you should make duplicate measurements once or twice per week or per month, depending on the situation, which would be a minimum requirement. We prefer to use automated report and averaging of regions of the readings stored. They could be stored in device memories such as a mobile phone, etc. And at least 3 days with at least 12 readings, basically, then should be ideally combined before the office visit or before a physician consultation. Obviously, the target, as I mentioned already, is for home blood pressure measurement is 135 systolic over 85 millimeter diastolic. And that is very important. And actually, the 2 studies I presented to you, the I-Combine and the I-Add studies using the combination of amlodipine and irbesartan, use basically more or less a similar approach to monitor home blood pressure measurement. And we can clearly see that's an efficacious combination to control home blood pressure, but also the protocol using automated devices and according to the recommendation that we have now also summarized in our consensus paper is very feasible and appropriate. There are several advantages to use single pill combinations. One is clearly also related to a reduction in the pill burden, because we know that the number of prescribed antihypertensive medications from 1 to 6, as shown here in a very important study in the United Kingdom in gray and the Czech Republic in black, in a similar way, will increase the frequency of non-adherence, increasing age and also male sex. So males were more likely to be non-adherent as compared to females in this study. There's also a prognostic implication, because we know now with single pill combinations, as we have shown also in the combination with amlodipine irbesartan, for instance, we can control blood pressure more effectively and also more timely in a more rapid way. And that has already implications with regard to outcome. And the important study that showed that was the VALUE trial, that showed that reaching blood pressure control by 3 months already, and also by 6 months, as shown in this slide, independent of the drug type that was used in the study, which was an angiotensin receptor blocker and also a calcium channel blocker based treatment, and also diuretics and beta blocks in combination. But nevertheless, as you can see, the hazard ratio for cardiovascular outcomes events was significantly reduced in those patients that had already blood pressure controlled after half a year. And the same trend was already seen in patients after 3 months with a risk reduction. So it's important, particularly in high-risk patients, to achieve blood pressure control very early during the first 3, at least 6 months when we start treatment in those patients. When we compare the blood pressure lowering effect using fixed dose combinations or single pill combinations versus 3 combinations, looking into observation studies, we summarized in a recent paper the available studies, we clearly can see that the goal of attainment of blood pressure control versus baseline in those studies that used fixed combinations as compared to monotherapy is increased. Here you see the percentage increase in blood pressure control rates in different studies. Observation studies predominantly. With regard to randomized control studies, there are not so many studies that clearly showed a significant effect, but because there are only a few studies available that tested this, I have to admit, but nevertheless, you can see here when you compare single pill combinations, fixed dose combinations, or 3 combinations, a significant higher goal attainment in this study by Webster and also by Professor Mancha in these studies, and a trend or no different effect in another study shown here. But taken together, clearly the data support the use of fixed dose combinations with regard to as compared to 3 combinations, achieving better blood pressure control. Nevertheless, when we look in Europe and also in the United States, as Professor Mancha did in this review article about into the issue how many patients are actually are treated with combination therapy at all as compared to monotherapy at the start of treatment, we clearly have to admit that still the majority of patients are actually started on monotherapy, even though the guidelines now recommend to start with do a combination from the very beginning. I think that needs some time to be implemented in the clinical context and the clinical practice. And I hope that this type of educational events such as today will contribute to increased use of combination therapy from the very beginning in patients with hypertension. We recently summarized also again the advantages of using single pill combinations as compared to 3 combinations. First of all, when we combine 2 drugs and the authorities look at this, the combinations, obviously they need to be approved for market access and they need to be safe also from the pharmacokinetic point of view. And this clearly applies to all the single pill combinations. So they are inherently safe, the combinations. They will lead to better adherence with less pills, as I showed in the previous slides. More patients will achieve the target blood pressure. More patients will achieve the target blood pressure also early, within already 3 to 4 months, and that has already prognostic implications, as we know, as I discussed from the value trial. And this will lead also better long-term persistence if blood pressure is rapidly controlled, because if the patient realizes that I'm at goal and the blood pressure is lower and the tolerability is also increased by using good combinations, that will have a benefit. It also compensates for therapeutic inertia, which means the reluctance of physicians to modify treatment strategies when blood pressure is still elevated, which we have seen in clinical practice. So finally, but last but not least, it's also important to note that single pill combinations improves remote home care in hypertension. And this is particularly important in lockdown situations such as this one we have now faced during the COVID-19 pandemic. My final slide also summarized some of the issues that we highlighted in the guidelines also for the future. It's important to improve drug adherence in hypertension, because the best drugs do not work if patients does not take the best drugs. And therefore, the simplification of the drug treatment regimen is very important to improve adherence using single pill combinations. So a simple drug treatment approach starting with single pill combinations, many patients can already be controlled, and that will be very important. Reminder packaging is also very important to improve adherence. At the health system, supporting the development of monitoring systems, telephone follow-up, home visits and telemonitoring, and also home blood pressure monitoring, which is a key issue, I think, is very important. Also, financial support and collaboration between healthcare providers providing the patients with the drugs is very important, and to the improvement of the supporting developments. Reimbursement, obviously, of single pills combinations is sometimes an issue in different countries, while there is a reimbursement of free combinations. Some single pill combinations are not fully reimbursed, which is a limitation for implementation. And the development of national database, including prescription data available for physician pharmacists, will be very important also for future research projects. And obviously also the accessibility to drugs is very important. If you look globally around the world, including single pill combinations, and you are fortunate in your region that the single pill combinations are available to you. So with this, I would like to thank you very much for your attention and participating in this session today, and I'm looking forward for the any questions or comments you may have, and I hope I can address those in the Q&A session, which is following my presentation now. Thank you very much.
Thank you very much, Dr. Reinhold Cruz, and thank you, Sanofi, for this lunch symposium. There are some questions. Again, I'm Dr. Rodney Jimenez, and I'm going to ask questions for Dr. Reinhold. Let's start with the first question from the phone-in questions or the audience. What do you choose primarily between ACE inhibitor and ARB, since there's a presumed superiority of ACE inhibitor with regard to all-cause mortality and cardiac death, especially those patients who had MI. So what do you choose? How do you choose between ACE inhibitor and ARB?
Yes, that's an important question, and that's always being intensively discussed, in the hypertension, also the cardiovascular medicine field, whether there's a clear difference, whether is there any difference in terms of between the angiotensin receptor blockers and the ACE inhibitors. Actually, in our guidelines, we do not, we keep them at the equal level of recommendation. The question is whether some comorbidities and high-risk situations, we should prefer the ACE inhibitors or over the angiotensin receptor blocker or vice versa. And particularly, also, we have to acknowledge that the ACE inhibitors were there first. And they also the first evidence-based studies, for instance, in heart failure, were all done with ACE inhibitors, and therefore the ACE inhibitors are clearly also in the European heart failure recommendations and the international recommendations are the first drugs you might consider in heart failure because of this history, because the angiotensin receptor blockers came last. While there's no clear difference in, even though there's a controversial issue, I acknowledge, from my point of view, there's no clear difference in terms of risk reduction in patients with hypertension documented so far. Clearly, the difference is in terms of tolerability that you might anticipate, because tolerability is very important for adherence, again. And if we have patients that already developed side effects or are prone to develop side effects, then we clearly have the advantage of angiotensin receptor blockers with the better tolerability, particularly CAF, which is the key issue also in the Asian populations. And clearly, patients that developed angioedemas already are not patients that should be considered for angiotensin receptor blockers. So it's not clear. It's a controversial issue from my point of view. There's no clear proven benefit, prognostic benefit, clear difference between ACE inhibitors and angiotensin receptor blockers, with the exception of particularly the heart failure, which is due to the history because they were used first in the landmark trials.
Thank you very much, Dr. Reinhold. Another question. Given the guidelines you presented, personally, do you suggest that most of the patients be on a single pill combination the soonest possible?
Yes. I mean, we would need, I have to admit, we still would need to have more randomized controlled prospective trials. It's very difficult to test this in outcome trials, but the totality of data we have, observational and randomized controlled trials, indicate that the blood pressure control could be improved. And also, the pill burden can be improved and the adherence can be improved. And also the simplification is very important, just using a single pill combination from the very beginning. And they keep the patient on the same pill and still have the possibility to titrate up or even go back again low. So to modify, but with a single pill, and the simplified approach and the possibility to titrate is very important, very elegant, but also improves in terms of communication and care with the patient, the situation. That's the reason why, taken together, we recommend from the very beginning. The other important argument and rationale is that the target blood pressure, actually I did not mention that much emphasized, but it's an important question to be discussed during the session now, is that the target blood pressure for most patients is systolic in the range of 130 millimeter mercury. And to achieve the target blood pressure, we need, for the majority of patients anyway, 2 drugs. So therefore, it's important to use from the very beginning already the dual combination. And that's the reason, the rationale for our recommendation. Still, as I mentioned, monotherapy, if you have only really mild hypertension, low risk, and very elderly frail patients, you might consider monotherapy. Sometimes I also do that, but only in a very few patients. Sometimes the patients actually ask for it. Oh, doctor, I want to use only one drug, and you have to try to communicate in an appropriate way. But I, in my personal practice, I have only a minority of patients now when I start treatment with a monotherapy. Most importantly, those patients that they actually ask for it because they are concerned, about taking many drugs. If I cannot convince the patients to jump over this barrier, I almost use exclusively now dual combinations, start with a low dose from the very beginning.
Okay, so you emphasized that it's better to start in the combination therapy the soonest possible. There's another question here. It's a phone-in question for patients. In the Philippines, sometimes the generic form of the medication or the antihypertensive are cheaper in individual than giving the patient with combination. So there's a question here for patients who cannot afford combination therapy. Is taking same medications at the same time has similar effect as taking it in a combination tablet? For example, taking irbesartan 150 milligrams at 6 a.m. and amlodipine 5 milligrams at 6 a.m. also. Does it have the same?
Yeah, it's an important question. We have seen. First of all, it's a disadvantage, that we realize that the accessibility to the drugs, the reimbursement for the single pill is sometimes, is a barrier because, the free combinations are cheaper or they're available. And there are some countries around the world, there are actually only or no single pill combinations available at all, which is a deficit. But as you have seen, it's interesting that some studies indicate actually that if you use the single pill, also I mentioned that the single pill is more effective taken at the same time as free combination in real life, in clinical practice, even though we have no clear pharmacokinetic rationale for this. But maybe it could be a non-adherence, it could be the taking the drugs at the same time, which is clearly established when you use a single pill combination. And we would need more research on this. But coming back to also the point of your situation, for me, it's important that the blood pressure is controlled. And if the single pill combination is not available, it's important, even to take also the free combinations and combine them. Ideally, I would combine them to make it simplified at the same time, for instance, in the morning, at the same time, take the drugs together rather than, taking them apart, or one in the evening or one in the morning and one in the evening, because we know the adherence is lower. So if you're simplified, if the single pill combination is not available for you, take the drugs regularly, particularly, for instance, in the morning in a regular way with breakfast or before breakfast, how we like, and take them at the same time. And the most important is that you take them every day and that you adhere to the treatment, even though when the single pill combination is not available to you. So blood pressure control per se is very important. At the very end, it's the blood pressure control, the level of blood pressure control that we can achieve is more important than the choice of the drugs, the selection of the drugs. That we know from the studies overall, with the exception of beta blockers, which are a little bit inferior in terms of risk reduction as compared to the other first-line blood pressure lowering drugs. But the blood pressure level control is the most important.
Okay, thank you very much. And another question here. If a patient's hypertension is controlled, is it recommended to decrease the dose or switch back to monotherapy? I guess the one who asked this question is referring to a BP like 110, and since the goal is just 140 or below, what do you recommend?
So, that's important to talk about. Maybe also briefly summarize the goal again. So the goal for diastolic blood pressure, which is generally not so problematic in clinical practice, is lower than 80 millimeter mercury for all patients. So this is very well established from the trials. The goal for diastolic should be below 80. For systolic, if the patient is younger than 65 years, we recommend a systolic blood pressure goal of 130. Even a little bit lower could be. And if the elderly, something between 140 and 130. But in terms of lower levels, it's also, in our guidelines, we are quite confident that lower levels, they are safety margins, lower levels, and they are at systolic 120 and diastolic 70. So the blood pressure should not be lowered in hypertensive patients below 120 systolic or below 70 diastolic. It could happen, because something changed with the patient, seasonal changes, or other conditions, other drugs he or she is taking, that the blood pressure is too low during treatment. And then we can de-escalate, reduce the dose or take even one dose. If we have triple combination, we can go back to dual, or again, if we have a single pill combinations, we can titrate within the single pill combination. So the safety margins are 120 systolic, 70 diastolic, and we should not go lower with active blood pressure treatment.
Yeah, because there's a certain J curve, right?
Yes, the J curve, even though maybe you should not be confused. There's a Lancet paper just published 3 weeks ago that is stating that you can lower blood pressure, whatever you can do at every level, even starting at 120, which is a meta-analysis and a mathematical kind of approach. And we are not actually convinced by this paper that has been published. Maybe you have seen it, or it will be also discussed now in public. So we should not be confused. So therefore, we are convinced that the J-curve you mentioned is there, particularly in high-risk patients. Active lowering of blood pressure should be limited, and we should not go below 120/70. And there's actually, as the colleague was asking, therefore blood pressure monitoring is very important. Home blood pressure monitoring is important. And then we could reduce the intensity of treatment in these patients.
Okay. Okay, I think I only have one last question. Okay, this is again with regard to combining the ARB or ACE inhibitors to a calcium channel blocker or a diuretic. How do you choose, or when do you choose this between these two? What do you choose actually, or how do you choose preferably?
I don't understand the question. What is the question?
If you're combining an ARB here, in ARB or in irbesartan in particular, to a calcium channel blocker or a diuretic, what would you choose?
Yeah. Okay. The question is whether to use a calcium channel blocker as a combination partner or a diuretic. Yeah. I prefer to start with calcium channel blocker in almost all patients. And the question is, in which patients? I mean, European patients, I have predominantly, and German patients, but we have also now from different people from different parts of the world in our country as well. But patients with edema, patients with heart failure, I mean, these are particularly HFpEF patients with preserved ejection fraction and have already congestion problems. At the beginning, these are the patients I would prefer the use of a diuretic rather than a calcium channel blocker. So in the majority of patients, also from the metabolic profile, calcium channel blockers, and also because they are very efficacious in a wide spectrum of patients, I prefer to start with the calcium channel blockers. If the patient has heart failure, edema, I would consider using a diuretic. Also, even again in these patients, if I have a problem, for instance, with potassium, low potassium, etc., other problems, metabolic problems, I again would prefer calcium channel blockers. So not so many patients. The other patients which is also controversial, are with chronic kidney disease because they need very often also diuretics. They are salt sensitive. So if you have already an EGFR clearly below 50 milliliter per minute, then in hypertension, you could also prefer the use of a diuretic with an angiotensin receptor blocker. So the heart failure, chronic kidney disease situation, and edema patients.
Okay. So I guess there's no more question. Thank you very much, to our illustrious speaker for today's lunch symposium, care of the Sanofi Aventis. Thank you very much, Dr. Reinhold Krutz, for gracing this convention of ours. The Filipino cardiologists are grateful having you. Thank you very much. Thank you again, everyone. This is Dr. Rodney Jimenez, your moderator for today.
Thank you, Dr. Reinhold Kreutz and Chairman Dr. Rodney M. Jimenez. We now resume with the second part of the Cardio Fellows debate. Our debate topics are: first, DOACs in the first 3 months of bioprosthetic valve surgery in patients with high bleeding risk. Second is FFR-guided versus angiography-guided approach of complete revascularization for ST segment elevation myocardial infraction. Lastly, coronary CT angiogram versus stress imaging in intermediate risk symptomatic patients with suspected coronary artery disease, CT, and stress imaging. Once again, debaters are given 6 minutes to debate and 2 minutes for the question and answer.
Welcome back, everyone, to the discourse, arena of discourse of the Philippine Heart Association. We had our first battle this morning. We're about to continue this afternoon. As mentioned, three topics are at hand that we are going to be hearing from the different contenders for the best debater of the Philippine Heart Association. First topic will be DOACs in the first 3 months of bioprosthetic valve surgery in patients with high bleeding risk. The affirmative versus the opposition, followed by FFR guided and angiography guided approach of complete revascularization for ST segment elevation, myocardial infarction. Then finally, the last topic for this afternoon before the last of part two, by the way, is coronary CT angiogram versus stress imaging in intermediate risk symptomatic patients with suspected coronary artery disease. The proposition and opposition. Let the battle continue.
Good day. Our team affirms the use of DOACs in the first 3 months of bioprosthetic valve surgery in patients with high bleeding risk, in this case, the elderly population. ACCHA recommends patient-centered decision-making, which emphasizes the importance of multidisciplinary team-based care delivery and shared decision-making. Ultimately, it is the patient that has the final decision in his or her management. Anticoagulation early after valve implantation is intended to decrease the risk of thromboembolism until the prosthetic valve is fully endothelialized. In the latest 2020 ACCHA guidelines for the management of patients with valvular heart disease, for patients with bioprosthetic surgical aortic valve replacement or mitral valve replacement who are at low risk of bleeding, anticoagulation with vitamin K antagonist is reasonable for at least 3 to 6 months, with level of evidence B. However, evidence supports among those patients with low risk of bleeding and the use of BKA. There are no present clinical practice guidelines recommending the use of DOACs in the first 3 months after the bioprosthetic valve implantation. So our team supports and believes the use of DOACs in the first 3 months after bioprosthetic valve surgery with the following points of argument. We believe that the risk and sequelae of thromboembolic complication is greater than the bleeding complication. We believe that the remedy for thromboembolic complications are more difficult to manage than the remedy for bleeding complications, and that there is no significant difference between DOAC and VKA regarding thromboembolic complications, major bleeding events, and readmission based on recent observational studies. Here in the studies, we can see that there is high risk of thromboemboli early after bioprosthetic cardiac valve placement, and in this study, most of their populations are the elderly. We can see that the first episodes of thromboemboli occurred 12% of those with aortic valve replacement and 17% of those with mitral valve replacement. Most of the thromboemboli occurred in the cerebral site, with full recovery achieved on only half of those patients, and the other having either permanent defect or even death. And we can noticeably see that warfarin or anticoagulation with warfarin is only as low as 8% in the first episode of event with thromboemboli among those with aortic valve replacement, and as low as 44% for those who had mitral valve replacement. Aside from thromboemboli, thrombosis of prosthetic heart valve management is also difficult when it occurs, which either we use fibrinolysis, which can further lead to bleeding, or even the need for surgery. In this study, comparing the efficacy and safety of DOAC and warfarin after bioprosthetic valve replacement by Stacy Pascuala, published in Switzerland 2020, we can see that they were able to recruit 238 patients who had valve replacement surgery receiving either DOAC or warfarin, and successfully included 197 patients. They excluded 41 patients because they had either mechanical valve replacement or discontinuation of anticoagulation before 6 months or switching of agents. Among the 197 patients, 86 had apixaban, 40 had rivaroxaban, 1 had the bigatran, and 70 had warfarin. And comparing the baseline characteristic between the two groups, you can see here in this table 2 that they are generally similar with mostly no significant difference between the two. There's only significantly more use of DOAC among patients who had AF prior or even post-surgery, and significantly more use of warfarin among patients who had CKD. In terms of the primary endpoint, this is table 3, summarizing the two primary endpoints, which is thromboembolic complication and major bleeding. Here you can see that 9 out of the 127 patients who had DOAC had major bleeding, and 2 out of the 70 warfarin patients had major bleeding. There were 3 thrombosis or stroke among patients who had DOAC, and there were no thrombosis or stroke among patients who had warfarin. But comparing between the two, there is no statistically significant difference in major bleeding or thrombosis and stroke between DOAC and warfarin. In Table 4, they show the summary of two primary endpoints broken down by drug, in which you can see that 2 major bleeding occurred in warfarin, 7 in apixaban, 2 in the rivaroxaban, and none in the bigatran. Thrombosis only occurred in the rivaroxaban group, which is 1, and stroke occurred 1 in apixaban and 1 in rivaroxaban. Table 5 summarizes the major bleeding events with patient-specific characteristics, and these are the profile of the patients who had major bleeding events. And you can see that most of the events occurred in the gastrointestinal tract and mostly had 2 units of transfusion with mostly with higher Hasbled risk. Now the good thing with DOAC is you can just reverse it, and this is taken from the ACCHA guidelines in the management of valvular heart disease. Immediate reversal of anticoagulation because of uncontrollable bleeding with treatment of either rituximab or adesanet alpha is reasonable. Thank you for listening.
Good day. Although bioprosthetic valves are less thrombogenic than their mechanical counterparts, there is an increased risk of stroke early after operation, particularly in the first 90 to 180 days after either bioprosthetic AVR or MVR. According to several studies, there were a rise in the incidence of valve thrombosis, even with the use of less thrombogenic bioprosthetic valve. According to the guidelines, anticoagulation early after valve implantation is intended to decrease the risk of thromboembolism until the prosthetic valve is fully endothelialized. The potential benefit of anticoagulation therapy must be weighed against the risk of bleeding. For the initial 3 to 6 months of both surgical bioprosthetic AVR or MVR and TAVI, antiplatelets or anticoagulation with vitamin K antagonists are recommended. The use of antiplatelet therapies was also recommended in the 2017 European Society Guidelines with a 2A and 2B recommendations. With the emerging studies on DOACs, can we use direct oral anticoagulants for prevention of thromboembolism in patients with bioprosthetic valves? We are against the use of it because according to the 2020 AHA guidelines with a Class 3 Level B recommendation for patients with bioprosthetic TAVI, treatment with low-dose rivaroxaban plus aspirin is contraindicated in the absence of other indications for oral anticoagulants. A study by Dangas et al., also known as the Galileo trial, the researchers investigated the role of anticoagulation with rivaroxaban as compared with an antiplatelet strategy in patients for anticoagulation after successful TAVR. They observed that the rivaroxaban group had higher rates of bleeding complications. The study was halted because the data showed that rivaroxaban was associated with greater risk of all-cause mortality, thromboembolic events, and bleeding in patients who undergone TAVR. How about for patients with indication for anticoagulation, such as atrial fibrillation? Until more data are available, the writing committee favors using vitamin K antagonists for patients with atrial fibrillation in the first 3 months after surgical or transcatheter bioprosthetic valve implantation to prevent thromboembolic events. Oral anticoagulation with vitamin K antagonist for the first 3 months is also recommended in the 2017 European Society of Cardiology guidelines with a Class 2A recommendation. Furthermore, despite the absence of data from the clinical trials, novel oral anticoagulants can be used in patients who have atrial fibrillation associated with a bioprosthesis after the third postoperative month. All these studies concluded that oral anticoagulants are non-inferior to warfarin when it comes to efficacy and safety in preventing thromboembolism among patients with atrial fibrillation and bioprosthetic valve. But can we apply the results of these studies to patients with high bleeding risk? In the sub-analysis of oral anticoagulant bifocal trials, both have important limitations, including small sample size and low number of events. To acknowledge that patients who undergone recent bioprosthetic valve implantation were excluded from both Aristotle and Engage AF TIMI 48 trials. A study done by Guimarães et al., also known as the RIVER trial, assessed the efficacy and safety of rivaroxaban as compared with warfarin in patients with atrial fibrillation and a bioprosthetic mitral valve. Out of 1,005 subjects, only 35.3% of them included elderly patients, and only 18.8% of them had mitral valve implantation of less than 3 months. If we will look closely at the clinical profile of these subjects, only a few of them have comorbidities and bleeding risk factors. For example, only 1.7% of them has CKD, which is a factor that increases bleeding risk among elderly patients. For race, Asians have higher bleeding risk compared to Caucasians, and only 1% are included in the study. The mean serum creatinine is within normal limits, and the creatinine clearance are relatively high. Moreover, patients have low to moderate Has-Blood score. The trial arrived with this conclusion. However, the study population were younger, lower risk group as seen in the baseline characteristics. Therefore, we can consider the results of this trial in our younger patients with low Has-Blood scores, but we cannot necessarily extrapolate these results to an older population and high bleeding risks. Considering the recommendations in both HA and ESC guidelines, in the management of valvular heart disease, and the outcomes of different studies presented, we arrive at the following conclusions. Individual studies on oral anticoagulants used in elderly patients are only subgroup analysis of larger trials and have relatively low number of subjects. There are not enough studies to support the use of oral anticoagulants in the first 3 months of bioprosthetic valve surgery in patients with high bleeding risk, particularly in elderly patients. In the absence of dedicated double-blinded trials confronting DOACs to VKA in terms of efficacy and safety, especially in high bleeding risk groups, there's little evidence of treatment with DOACs in clinical practice in patients with bioprosthetic valve. To date, the limited evidence about the safety and efficacy of DOACs in elderly patients with bioprosthetic valve make it difficult to define solid recommendations for the use in this population. Therefore, for patients with high bleeding risk who underwent bioprosthetic valve replacement for anticoagulation in the first 3 months of surgery, we go against the use of DOACs due to insufficient data in this population. Thank you.
We've heard the debaters and their points. It's about time now to hear what the judges have to say about this. Let's start with affirmative. Let us now call on our judge, Dr. Harold Suno, to interact with the affirmative group.
Good afternoon again for the proponents. This was mentioned by your opponents. Among the elderly patient with atrial fibrillation post bioprosthetic valve surgery, can you still recommend the DOACs, especially using the rivaroxaban?
So, hi, good afternoon to the members of the panel. It was mentioned that in a lot of their studies, particularly against anticoagulation, they want that there is high bleeding risk, particularly in the elderly population. One of the trials that they mentioned in particular is fairly recent, namely the Galileo trial. As such, it's important to note that this study that in this study there was one of the exclusion criteria that was mentioned in this study is that they excluded patients with atrial fibrillation or patients with other needs for anticoagulation. In addition to this, sir, it should also be noted that in this population, while they also express that there is a higher bleeding risk associated with rivaroxaban, the hazard ratio that was attributed to rivaroxaban was only 1.5 as opposed to the control arm. So likewise, in addition to this, it should also be noted that in the elderly population as well, these are the population that would be exposed to conditions that would be necessitating anticoagulation like atrial fibrillation. It should also be important to note that in our researches by Puri et al., that the prevalence of subvalvular thrombosis is 14% and dwarfs that of clinically overt na bioprosthetic thrombosis. And likewise, it should also be noted that we also did research on a 20-year study in Montreal Heart Institute, which indicated that 46% of patients who have bioprosthetic valve thrombosis can have complications. So likewise, it's important to note that they concluded with the following statement that the level of anticoagulation is the most significant factor to consider among these patients.
Thank you very much. Thank you very much for that answer. And actually, we have our out of time. So thank you. I hope Dr. Sunga actually appreciated your answer. Let's now go to Dr. Mambulao. Who are you convinced with the stand of our opposition? Present your question, please.
Okay, good afternoon, everyone. This is my to the opposition. You have pointed out that you are against the use of DUAX in patients with bioprosthetic valve because it's not in the guidelines. But we know that guidelines changes whenever there are landmark trials coming out. So what are other reasons why we should not use DOAX among patients with bioprosthetic valve aside from it not being in the guidelines?
Thank you, doctor, for that question. Well, besides it is not included in the guidelines, recent guidelines. Based on the review of literature, there is limited studies about the use of bioprosthetic of the DOAX in bioprosthetic valve surgery. In the first 3 months, there is small sample size and there is limited evidence from the from a larger randomized controlled clinical trials. Most of them are observational studies. So not until we have adequate or enough evidence for the use of DOAX in these high bleeding risk patients, then for now we go against the use of it. Thank you po.
Thank you very much. You still have time. You have 30 more seconds. Are you having any more questions, Dr. Mambulao?
I have no other question, ma'am.
Okay, thank you very much. Thank you very much, debaters. I think you have satisfied the curiosity of our judges. And thank you very much. And then thank you also, judges. We are now ready to go to the next topic. Maraming salamat po. Let me allow to talk Tagalog naman. Let's go to the next topic. It's quite long to read it. I'll just say FFR guided versus angiography guided. Watch and see the battle continues. Go.
Good afternoon. ST elevation myocardial infarction is a life-threatening emergency that can easily be recognized in EKG, which requires an urgent management in the form of reperfusion therapy. The ability of cardiologists to discriminate between lesions that can cause myocardial infarction and lesions that are physiologically insignificant based on coronary angiogram alone is limited. So hence, as the great Hippocrates immortalized the phrase, primum non nocere, or first do no harm. So we are here to give evidence that fractional flow reserve guided approach of complete revascularization is superior over percutaneous coronary intervention alone therapy. The complications of PCI have significant impact on patients' survival and healthcare. Here are some important and dreaded complications. Perforations. In a study made by Stankovic et al., states that the risk of perforations is around 1%, with an overall mortality rate of 5 to 10%. Contrast-induced nephropathy. Arrhythmia. Coronary artery aneurysm, in which have been a major indication for emergency coronary artery bypass graft surgery. The no reflow phenomenon, sudden cardiac death, among others. So in patients with coronary artery disease, it is critical that the hemodynamic relevance of a stenosis is assessed accurately. According to Braunwald, fractional flow reserve is considered as both diagnostic and prognostic gold standard, in which it represents the only method of ischemic evaluation which improves event-free survival over angiographic stenosis-guided revascularization. In the Dynametry Prime multi-study made by Engstrom et al., where they compare FFR-guided complete revascularization from infarct-related PCI alone, wherein the FFR group was noted to have less percentage of major adverse cardiovascular events, all-cause mortality, myocardial ischemia, ischemia-driven revascularization of non-infarct-related artery. In here, they concluded that complete revascularization prior to discharge using the FFR-guided multi-vessel PCR is superior than culprit infarct-related artery PCI only. Incomplete trials outcome by Wood et al., which revealed a 7.8% cardiovascular death, myocardial infarction at 3-year period in the FFR-guided complete revascularization as compared to that of the 10.5% at infarct-related PCI alone. Therefore, the authors concluded FFR is more superior than culprit-only revascularization. In the compared acute trial by Smith et al. Recorded a significant 12.7% difference in the incidence of all-cause death, myocardial infarction, revascularization event, cerebrovascular events, or any revascularization at 12-month period, favoring that of the FFR-guided group. Again, the authors concluded that FFR-guided revascularization was superior to infarct-only revascularization. In the study made by Entalis et al. States that FFR can reliably assess the severity of the non-corporate coronary artery stenosis during the acute phase of the acute coronary syndrome, and that it also allows better risk stratification. In another study made by Wood et al., which showed that FFR on the non-culprit vessel stenosis remains relatively stable over the subsequent 45 days, and is likely a valid measurement to guide delayed revascularization in patients with multi-vessel disease. In a meta-analysis made by Gupta et al. States that FFR-guided multi-vessel stenting in STEMI reduces not only the overall repeat revascularization, but the need to do a repeat urgent revascularization as well. In another meta-analysis by Neoptane et al., showed that the FFR-guided complete revascularization has less episodes of adverse outcomes. For the economic applicability of FFR-guided revascularization, a study made by William Firon, MD et al. States that FFR-guided PCI in patients with multi-vessel coronary disease not only improves outcome, but also saves resources. So in summary, FFR-guided revascularization can provide full assessment, functional and physiological significance, and resource efficiency of complete revascularization in ST elevation MI patients. Thank you.
Good day. In ST elevation myocardial infarction, the myocardial bed is initially impaired with reduced flow to variable degrees. We therefore need a reliable and cost-effective way to assess the need for revascularization. We believe that in these patients, an angiography-guided approach to complete revascularization is the best option. Why do we say this? The following points in terms of evidence, safety, and practicality should be considered. First, the evidence. Angiography-guided approach has been around for several years, much longer than FFR. In fact, these studies showed that this approach was associated with significant reduction in CV deaths, new MI, and revascularization. The complete trial, a landmark study, was associated with a 26% significant reduction in CV death and MI. Result of the PRAMI trial showed that the combined rate of cardiac death, non-fatal MI, or refractory angina was significantly reduced by 65%. The culprit trial revealed reduction in major adverse cardiac events. All these three trials gives credence to angiography-guided strategy. A meta-analysis report by Wald et al. In January 2020 showed that angiography visual inspection, or AVI, was significantly associated with a 64% reduction in cardiac death, 42% for all-cause death, 59% reduction in non-fatal MI, and 61% reduction in the combined endpoint. The results of the comparative analysis suggest that the use of FFR following a positive finding on AVI reduces the preventive effect by limiting the use of stents in unstable plaques that, whilst not causing ischemia, may become the cause of future MI and cardiac death. Evidence from this trial using AVI alone significantly reduces the risk of cardiac death and non-fatal MI by about 60%, and that much of this benefit is lost when FFR is used in this group of patients. Also, in May 2020, Bainey et al. Published the largest meta-analysis to date involving more than 7,000 patients. Angiography-guided strategy significantly reduced CV death or new MI by 39% with no evidence of heterogeneity. Results of meta-analysis by Galoni et al. In July 2020 showed that angiography-guided complete revascularization and not the physiology-guided significantly reduced the risk for recurrent MI. The three meta-analyses suggest superiority of the evidence for angiography. The other group will undoubtedly tout the FAME trial, but I would like to bring to your attention that the FAME patients, for the most part, had stable angina. FFR was validated in stable ischemic heart disease patients and not in STEMI patients. A STEMI patient is different from a stable angina patient or even an NSTEMI patient. There is more intense myocardial dysfunction, heightened inflammatory and prothrombotic state, and active myocardial compensatory responses in the non-infarct territories. Also, patients with AMI may have multiple ruptured plaques and thus target lesions may be underestimated using FFR. I have now proven to you the evidence in this favor of the tried and tested method, which now brings me to my second point, safety. Maximum hyperemia is required, which necessitates use of pharmacologic agents which can cause patient discomfort. In a patient with STEMI, it can cause or further aggravate hemodynamic instability. The ADAPT study showed that bradycardia, hypotension, and second-degree AV block were significantly more prevalent in the adenosine arm. Flow through the myocardial bed is critically important to obtaining an accurate FFR. In the acute STEMI vessel, FFR is not reliable for a minimum of 4 days because the myocardial bed supplied by the STEMI vessel is injured and infarcted. There is also a transient yet significantly reduced coronary and microvascular flow. In fact, the FEATURE study, a multi-center RCT, was stopped early due to increased mortality in the FFR arm. And now we see that angiography is the safer choice. Is it now practical? That will be my third point. In acute STEMI, the impaired flow may falsely elevate an FFR, making the angiographer miss the target lesion. In the local cath lab, additional procedures entail more costing, and for FFR alone, an extra 105,000 pesos. This will also increase procedure time, translating to increased radiation exposure to the angiographer, the staff, and the patient. More dye will be used, predisposing the patient to increased risk for contrast-induced nephropathy, and pharmacologic use will also predispose the patient to arrhythmia, hemodynamic instability, and discomfort. So, does this sound practical to you? In the background of safety concerns, increased procedure time, increased radiation exposure, and increased cost, there is just no clear benefit for FFR in STEMI patients. Now, why are we not in favor of the FFR-based approach? Because it was not validated among STEMI patients, has increased risks, and is basically impractical. In fact, a study suggested that FFR may be the cause of future MI and cardiac death, and that much of this benefit is lost in STEMI. In conclusion, among patients with STEMI, current evidence overwhelmingly favors angiography-guided approach to complete revascularization as a more practical, safer, and cost-effective option with lesser CV events. Thank you very much for your kind attention.
Now it's time for the question. Dr. Lottie, you have any questions or clarification for our FFAGAR guided team?
Yes, good afternoon. My question for the FFR guided group. What is your take with the opposition's argument that FFR guided approach is impractical considering the safety issues, increased procedure time, increased radiation exposure, and especially the additional cost?
Good afternoon. Thank you for the question, Doctor. In our study presented po in our argument, clearly po, FFR not only actually reduces time, reduces your patient's radiation exposure, reduces the contrast used to be in the patient, therefore reducing the contrast and the nephropathy in our patient. The safety-wise po, and the applicability of FFR, in Brownwall, it says that it's both diagnostic and prognostic. Therefore, it's a gold standard evaluating a patient to have stenosis lesions. So I think po, in these patients po, with using FFR, it's still useful and it's diagnostic for these patients. Therefore, it's not harmful and it is not, it decreases for the complications such as perforations, such as your convulsions nephropathy, and your aneurysm po, and dissections.
Thank you very much, Dr. Lottie. Any more questions? They have 30 seconds left.
No more additional question, Doctor.
Thank you very much. Thank you. I think Dr. Uy is already satisfied your question. Let's go then. Dr. Mambilao, you have any questions for the angiography guided group?
It's Dr. Harold, ma'am.
Oh, I'm sorry, Dr. Harold. I got a little bit confused. Dr. Harold, it's your turn.
Yeah, good afternoon. They mentioned among the proponents, among patient with ST elevation MI, FFR guided reduces not only the overall repeat revascularization, but also the urgent revascularization. Can you still not recommend the FFR?
Hi, Doctor. Good afternoon. Good afternoon, panels. And actually, we do want to highlight a very recent trial that has been given to us, blessed by us, by our friends, counterparts. And this is called the flow evaluation to guide revascularization in multivessel STEMI. And this is the Flower MI trial. This was just done, released last May 16, 2021. And this is the largest and only randomized trial that directly compares the FFR and the angiogram-guided revascularization. Now, regarding the question, is that their primary outcomes were significantly lower, and it proved that the FFR-guided was not superior in angiography-guided revascularization because in the FFR arm there was more incidence of death, MI, and urgent revascularizations, and even the non-fatal MI and hospitalizations were lower in our angiogram-guided revascularization. And furthermore, they also highlighted that in the median costing of our angiogram-guided PCI versus the FFR, there's a median decrease of 500 euros. That translates to 30,000 pesos discount in our patients. So overall, if us three would be the interventional cardiologists, we would want to have cheaper or a more cost-effective technique in PCI revascularization that would have lower incidence of major adverse cardiovascular events. So essentially, we would have a better long-term investment in the health of our patients, especially in our STEMI patients.
Thank you very much. I'm sorry, but your time is up. And then we're glad that you managed to transmit your message that time before I actually cut you. I'm actually listening to your answer too. Thank you very much, Dr. Sunga. Actually understood your reply. And congratulations and thank you for a very good presentation for our debaters for the FFR guided and angiography guided controversy in STEMI. So with that, I'd like to proceed therefore to the next topic. I'd like to thank you, and of course the judges will continue to work. Thank you, debaters. And let's go to the next topic now, which is coronary CT angiogram versus stress imaging in intermediate risk CAD. So, susunod na kabanata.
Good day, doctors.
Today, we will be detailing why coronary CT angiogram is the more superior first-line diagnostic test over stress imaging. As cardiologists, we are facing two challenges in the pandemic era. Firstly, ischemic heart disease is still the #1 disease killing Filipinos as of 2020. And more alarmingly, it has exceeded its average death rate in the last 5 years. Secondly, Filipino CAD patients requiring emergent and non-emergent care are adversely affected by community quarantine measures due to limited access to healthcare services. Pre-pandemic, the ESC guidelines for chronic coronary syndrome in 2019 recommend that CCTA, or non-invasive functional imaging for myocardial ischemia, such as stress echo, SPECT scan, and stress CMR as the initial test to diagnose CAD. However, among intermediate risk symptomatic patients, which one should we do first? We believe that an ideal diagnostic test should be first effective in that it follows visualization of coronary arteries without being too invasive and too expensive, allows visualization of high-risk plaques prompting initiation of early aggressive treatment, and should have studies that demonstrate improved patient outcomes. Second, it should be safe and suitable in this time of pandemic in that it is not aerosol generating. And third, it should be cost effective. CCTA meets all these as I will show you. Hence, it is a better initial diagnostic test to request for. First, clinical trials and guidelines from various cardiology societies support its use. With a sensitivity of 97% and specificity of 78%, CCTA is highly sensitive and is the most specific test as shown in this meta-analysis by NUTI, which formed the basis of the ESC 2019 recommendations. In addition, studies like CORT 320 and eVinci studies have shown that it has the highest diagnostic accuracy for angiographically significant stenosis. Meanwhile, Dr. Villanes from the ACC argued that although functional tests attempt to detect flow-limiting CAD, only CCTA can accurately quantify the presence, extent, angiographic severity, and composition of coronary atherosclerosis. These measures of CAD are proven to more accurately predict long-term cardiovascular outcomes and better identify patients most likely to benefit from aggressive preventive medications and lifestyle interventions. The Scott Hart trial found that CCTA with standard care in low to intermediate risk symptomatic patients resulted in a significantly lower rate of death from CAD or non-fatal MI at 5 years than standard care alone, due to subsequent changes in treatment, without resulting in a significantly higher risk rate of coronary angiography or revascularization. Meanwhile, the PROMISE trial showed that in symptomatic intermediate risk patients, initial CCTA is at least as effective as functional testing in improvement of clinical outcomes over a median follow-up of 2 years. One might argue that CCTA may increase unnecessary invasive coronary angiography, but the PROMISE trial has shown that it is associated with a lower incidence of invasive catheterization showing no obstructive CAD. Secondly, CCTA is more cost-effective than stress testing. A cost analysis in the UK forming the basis of the 2016 NICE guidelines analyzed diagnostic tests in 45% pre-test likelihood population. Shown here are the average proportion of correct diagnoses versus the average cost of each testing strategy. A first-line testing strategy using CCTA has the lowest cost per correct diagnosis of coronary artery disease. The cost-effectiveness frontier is represented by a line connecting no testing, CCTA, and invasive coronary angiography. All other testing strategies lie beneath this line and have fewer correct diagnoses at a higher cost. Applying the same concepts to our setting and factoring in additional COVID-related screening tests prior to doing these exams, such as chest x-rays or an RT-PCR test, still, CCTA could offer more diagnostic information at a lesser expense to the patient. Lastly, we believe that a suitable exam in the pandemic era should ensure patient and healthcare worker safety. The EACVI COVID-19 recommendations promote choosing an exam that can substantially change patient management and confer minimal medical staff exposure. The North American Cardiac Societies have recommended CCTA for all inpatients and symptomatic outpatients in areas with high incidence of COVID-19. Functional tests, meanwhile, should only be done if it alters short-term management. The University of Massachusetts Healthcare also recommends performing CCTA not only due to its sensitivity and specificity, but also due to minimal staff risk of COVID-19 exposure compared to other modalities. To conclude, based on the above-mentioned evidence, CT angiography is a sensitive and effective test in arriving at the correct CAD diagnosis. It is safe, suitable, especially in this time of pandemic, and cost-effective given the wealth of coronary artery anatomy information that it provides to cardiologists. It serves as a guide in crafting the best treatment and preventive strategies for the patient and thus improving outcomes and prognosis. Thank you, and we are now ready for your questions.
Good day. Our debate topic is CTA versus stress imaging in intermediate risk symptomatic patients with suspected CAD. We are in favor of stress imaging, and let me tell you why using 3 letters, PHA. Our position is that stress imaging is superior in terms of better performance as a diagnostic and prognostic tool, safety profile as a test, and applicability and cost effectiveness. To defend our stand, we did a systematic search with the following questions. In those with intermediate probability for CAD, what is the sensitivity and specificity of diagnostic tests to predict CAD? What is the association of stress imaging versus CTA with adverse outcomes? This is our concept map. For the performance measures, we will defend why stress imaging is highly specific, has good correlation with ischemia and adverse outcomes, and is much easier to perform. For the safety measures, it is associated with less risk and unnecessary harm. And in terms of applicability, it is more available and cost-effective. First point, stress imaging is highly specific for CAD. We summarize the accuracy of various techniques in diagnosing CAD. Of note, stress imaging has a higher specificity and acceptable sensitivity, while CTA is very sensitive but has a very low specificity. The PROMISE trial showed high sensitivity for CTA, but in patients with intermediate probability of CAD, do you really need a high sensitive test? Recall that in the Bayes theorem, sensitive tests are excellent screening tests in the population with low probability of disease, while specific tests are outstanding in diagnosing a disease in a higher probability group. Due to the high sensitivity of CTA, it is actually more useful for those with low probability of CAD. Due to its low specificity, applying this tool to the intermediate probability increases the false positivity rates, which exposes the patient to unnecessary workup. Therefore, stress imaging, because of its higher specificity, is preferred in the intermediate probability group. In fact, our very own local guidelines endorse it as a preferred test to establish CAD. Second point, stress imaging correlates with ischemia. Recall that the strength of CTA is on the anatomic aspect, which has been shown to open a Pandora's box of downstream diagnostic invasive testing due to high false positive rate. Stress imaging, on the other hand, focuses on the functional aspect. A meta-analysis comparing stress imaging and CTA to determine FFR significant CAD found that stress imaging has better correlation in the intermediate probability group patients as seen in this graph. Following this logic, our review showed that stress imaging correlates well with functional ischemia using FFR. And in the FAME and COURAGE trials, FFR guides decision-making and correlates well with adverse outcomes. That being said, a functional diagnosis is preferred because it better predicts outcomes rather than an anatomic diagnosis with CTA. This indicates that stress imaging also serves as a good prognostic tool. Point 3 and 4. Stress imaging is much simpler to perform with less adverse effects. The accuracy of CTA is affected by technique and patient-related factors, which decreases its accuracy. CTA risks include CIN, radiation, and anaphylaxis, while stress imaging is less affected by patient factors, and so it is less demanding. Complications are rare and is more particular to the high-risk group. Therefore, we say that stress imaging is a safer diagnostic tool. Point 5. Stress imaging is a gatekeeper against unnecessary invasive procedures. We appraised a meta-analysis comparing stress imaging and CTA and its association with adverse events. In the head-to-head comparison, there was no significant difference between the two in terms of death and hospitalization. Fewer MIs did occur in the CTA group, but this was likely driven by the increased prescription of aspirin and statins. However, in the same meta-analysis, CTA was associated with an increased downstream use of invasive angiogram and revascularization, but without mortality benefit. Our group feels that the higher revascular rate without clinical benefit is deemed to be harmful because of bleeding and stroke risk, added radiation, and stent thrombosis. With the data presented, we concluded that CTA may lead to a higher rate of invasive revascularization, some of which may be unnecessary and even harmful. Point 6. Recall that the specificity of a CTA is 42%, which gives false positive rate of 58%. This means that 58 in 100 patients without significant CAD will turn out to be positive in the CTA, some of whom may be subjected to unnecessary angiograms, where almost 100,000 pesos is wasted. Note that cost of stress imaging ranges only from 12 to 20,000. This claim is supported by a meta-analysis comparing CTA and stress imaging head-to-head. They found that stress imaging is more cost-effective in the intermediate probability group due to concerns of excessive use of revascularization in the CTA group. In summary, we have convincingly shown why stress imaging is superior based on the performance measures, safety measures, and applicability. In reality, CTA and stress imaging go hand in hand in the approach. But if we were to choose which test is better among intermediate probability patients, just remember PHA. Stress is best and functional is above anatomical. Thank you.
The room is getting hotter. The topics are getting more controversial and more up to date. Now let's talk. Let's talk and let our judges decide by having their query on what they want to still find out. Dr. Ryan Mambulam, do you agree? Do you have any query for the CT guided group?
Yes, thank you, ma'am. Good afternoon, everyone. For you have cited out that CT angiographies have good specificity and sensitivity. Actually, both tests are very good. One is anatomical, the other is functional. So my question, if we put the decision making to the patient, how can you convince the patient to choose CT angiography with exposure to radiation as compared to the other tests without radiation?
Good afternoon. So first off, with regards to the radiation risk, we have found some studies that have documented, other than Promise Trial, we have also found studies from Journal of Internal Medicine published in 2016. Both have documented that coronary CT has less radiation by 1.1 millisieverts. Now, if you want to convince the patient, we will talk to them and tell them that first off, CCTA is a sensitive and specific test which will yield so much anatomic information. So if the result is positive, as negative, we could therefore proceed to other diagnostic workup to rule out the chest pain of the patient and discount CAD. But if it's positive, first off, we could maximize medical management, even if, regardless if it's obstructive or non-obstructive CAD. Thereafter, it could aid in the appraisal of the patient of further diagnostic plans. The risk of radiation would therefore be would outweigh the necessity benefits that we could gain from CT angiogram, the diagnostic benefit, which we could further, which would then guide us for further patient management plans. Thank you.
Thank you. Thank you very much. I'd like to actually ask everyone to please lower your volume because we like to hear you, much as we like to hear echoes, but we like to hear you. Thank you very much, Dr. Ryan, for that question. Now let's go to Dr. Rauy. Dr. Rauy, are you convinced about stress imaging? Do you have any question for our stress imaging group?
Okay, good afternoon. My question is, the strength of stress imaging is functional diagnosis. However, can you manage the patient with CAD without clear anatomic diagnosis?
Yes, ma'am, we can still manage the patients without a clear anatomic diagnosis because for stress imaging, it can provide us inducible cardiac ischemia. Exercise testing also can provide us complementary information beyond ECG changes, such as exercise capacity, arrhythmias, hemodynamic response, and symptoms during exercise, which are considered clinically useful. Thank you. Do you have any other questions?
Dr. Do you have
No
any other
more.
questions?
No more,
Okay.
Doc.
Oh, no more. Thank you very much. Okay. I think that actually concludes our session for this afternoon. Thank you very much, everyone. Thank you, debaters. And I know this is your Miss Universe moment. It's not easy to answer a question that fast, but congratulations, you guys did well. And for all the effort that you put in, the PHA, including your judges, actually appreciate that. So we will await the final decision after everyone's presented. So have a good afternoon. Congratulations all. And we'll see everyone else later at 5 when we have the last leg of the 5 last topics that we're going to decide before we go to the Miss PHA and more Mr. PHA Debater 2021. So see you later, guys. Thank you very much.
Thank you, participants. The third part of the Cardio Fellows debate will resume later on in the program. Ladies and gentlemen, the time has come to meet the experts on CV Oncology with a lecture on the evaluation and management of the cardio-oncology patient, presented by Dr. Angela Apostol Alday, Training Officer, Department of Internal Medicine, Central Luzon Doctors Hospital, Tarlac City, member of the Training Committee, Section in Cardiology, Angeles University Foundation Hospital, Angeles, Pampanga. Hospital affiliations: Central Luzon Doctors Hospital, Tarlac City, Jackson's Medical Center, Tarlac City, and the Medical City, Clark, Pampanga. Fellow of the Philippine College of Physicians, the Philippine College of Cardiology, and the Philippine Society of Vascular Medicine. For this lecture, our panelists are: for coronary artery disease, Dr. Joland O. Lucero, Associate Professor, Southwestern University and MHAM College of Medicine, Cebu City. Completed Interventional Cardiology and Structural Heart and Vascular Diseases Fellowship at the St. Luke's Medical Center in Global City. Head of the Cardiac Catheterization Lab of VSMMC Cebu. Fellow of the Philippine College of Physicians and the Philippine College of Cardiology. Member of the Philippine Society of Cardiac Catheterization and Intervention. And Dr. Alma Reyes Calavera, completed residency in internal medicine at the UERM Memorial Hospital. Completed fellowship in hematology at the Philippine General Hospital. Trained in bone marrow transplantation at Changgong Medical Center, Taiwan. Founding member and member of the Board of Trustees of the Philippine Society for Blood and Marrow Transplantation. Assistant Professor at the UERM MMCI College of Medicine. Active Consultant at the UERM MMCI, the Medical City Ortigas, and Victor R. Potenciano Medical Center. For heart failure, Dr. Nathania Salazar Fajardo. Completed clinical research fellowship in cardiac rehabilitation at St. Luke's Medical Center, Global City. Received advanced heart failure, mechanical circulatory support and transplantation international training at Mayo Clinic, USA. Board of Directors of the Cardiac Rehabilitation Society of the Philippines. Heart Failure Program Director of St. Luke's Medical Center in Quezon City. Unit Head of Cardiac Rehabilitation at Capital Medical Center, and Fellow of the Philippine College of Physicians and the Philippine College of Cardiology. And Dr. Herdy Glorian C. Luna, completed internal medicine residency and medical oncology fellowship at the National Kidney and Transplant Institute. Head of the Section of Medical Oncology, National Kidney and Transplant Institute. Awarded the European Society for Medical Oncology's Leaders Generation Program in Asia from 2020 to 2021. Affiliated with Lung Center of the Philippines and St. Luke's Medical Center in Quezon City. Member of the European Society for Medical Oncology, the American Society of Clinical Oncology, and the Asian Oncology Society. For venous thromboembolism, joining Dr. Luna and Dr. Reyes Calavera is Dr. Alex T. Hunya, Associate Professor, Cebu Institute of Medicine, Cebu City. Vice President, Zone 2 of the Asian Pacific Society of Cardiology from 2017 to 2019. Past President of the Philippine Heart Association, Philippine College of Physicians Cebu Chapter, and the Philippine Society of Vascular Medicine PHA Cebu Chapter. This lecture is moderated by Chairman Dr. Angela Apostol Alday with Co-Chairman Dr. Joanne Ava K. Artiu, completed Adult Cardiology Fellowship and Clinical Research Fellowship in Echocardiography at St. Luke's Medical Center, Global City. Unit Head, Cardiovascular Oncology Unit of the Asian Hospital and Medical Center. Training Officer, Clinical Research Fellowship in Echocardiography, Perpetual Health Medical Center in Las Piñas City. Unit Head of the Intensive Care Unit of the Emilio Aguinaldo College Medical Center. And Unit Head of the Cardiovascular and Pulmonary Diagnostic Center, City of Imus Doctors Hospital. We would like to inform everyone that questions will be entertained when all lectures have been delivered. Kindly use the chat box to convey your questions and please indicate for which speaker your question is addressed to. Thank you.
Good afternoon, everyone, and welcome to the first Meet the Expert session of the Council of Cardio-Oncology. I'm Dr. Angela Apostol Alday, the chair and moderator of this session, and with me this afternoon is my co-chair and fellow moderator, Dr. Ava K. Chu. We also have 5 panelists or reactors who each will give us his or her take on the cases that will be presented today. So during this session, we will hear not only the perspective of fellow cardiologists, but also those of other specialists who play major roles in the management of cancer patients. Most of us here know firsthand that these patients usually present as management dilemmas when treatment for the primary problem gives rise to unwanted complications or when a pre-existing condition precludes successful treatment for the cancer. Hence, we aptly entitled this session as Striking the Right Balance because at the end of the day, we think that this is truly what the cardio-oncology patient needs. We will present 3 cases today, and at the end of each case, we will hear from our cardiologist and a hematologist or oncologist reactor based on a set of questions that we have prepared. So without further ado, I'd like to start with the first, which is a case of a patient with coronary artery disease who developed a hematologic malignancy. So this patient is an 86-year-old male post-coronary artery bypass about 15 years ago, also hypertensive and diabetic, who was recently diagnosed with chronic lymphocytic leukemia, stage 4, which initially presented as a neck mass. He was started on ibrutinib with a total dose of 420 milligrams daily. On the 6th day of the chemotherapy, he was noted to be drowsy and was difficult to awaken. When he was brought to the emergency room, he was stuporous, hypotensive, tachypnic, and with multiple ecchymosis and hematoma on the right posterior thigh. Hence, he was subsequently admitted and managed as a case of hypovolemic shock and acute kidney injury secondary to blood loss, as supported by findings of low hemoglobin, low platelet count, and an elevated creatinine. The values here on parentheses were his hemoglobin, platelet count, and creatinine levels prior to starting ibrutinib. He eventually improved with PAC-RBC replacement and fluid resuscitation, though the hospital stay was prolonged due to hospital-acquired pneumonia. However, on the 19th hospital day, he was noted to be dyspneic with distended neck veins and crackles from the mid to the lower lung fields, and his X-ray showed pulmonary congestion with cardiomegaly. The troponin I was mildly elevated but below 5 times the upper limit of the normal. A 2D echo was done. This is the Plaques view showing a dilated LV. The LV EDD measured here was 5.76 cm. The LV mass index was 149 grams per meter squared with relative wall thickness of 0.37, indicative of an eccentric LVH. The short axis view of the LV at the base shows global hypokinesia. The ejection fraction by Simpson's method was 37%. As you can see here, the LA is also dilated. The aortic root and even up to the ascending aorta was dilated. The aortic cusp and the mitral valve leaflets were thickened, and the mitral valve had a low flow configuration. The short axis views further down the mid-ventricle and to the apex also show global hypokinesia. On color Doppler, there is moderate AR and moderate MR. The RV inflow view shows a dilated RA and RV, and from another view, the RV was noted to have a TAPSE of 1.3 cm, which is decreased, and a fractional area change of 37%. The estimated pulmonary artery pressure for this patient was 46 millimeter mercury, which is consistent with mild pulmonary hypertension. So at this point, it cannot be really ascertained yet whether this was due to progression of coronary artery disease or a cardiotoxicity from the chemotherapy. The patient was offered angiography, but he refused. However, he agreed to a cardiac MRI. I'm sorry, we were not able to retrieve the images, but these are the results. The LV is dilated with a wall motion abnormalities and a severely reduced systolic function. There was early and late gadolinium enhancement with patchy distribution at the mid-wall of the IVS, and this may represent a residual of prior inflammation and or fibrosis. A focal LGE signifying a possible old infarct was also seen at the distal mid-segment of the inferior wall. The RV was normal with normal systolic function, and there were no scars or fibrosis. The LA was also dilated. There was no intracavitary clot or thrombus, but there's evidence of low flow or rheologic stasis. So with that, we'd like to ask our cardiologist reactor the following questions. If we were to do a pre-treatment cardiac evaluation of the patient in this case, how do we tailor it? Like, when do you need to do invasive imaging for these patients? Is there a role for the more advanced techniques in angiography, such as IVUS or OCT in these patients? For this particular case, would there have been an advantage of doing angiography in addition to cardiac MRI for further evaluation of the coronaries? And lastly, from your viewpoint, does the benefit of doing an invasive intervention for cancer patients with coronary artery disease outweigh the risk and their prognosis?
Survival of patients with cancer has improved with advances in treatment, but also an increased morbidity has been noticed due to treatment side effects. Cardiovascular disease are one of the most frequent side effects, which lead to premature morbidity and death among cancer survivors. The cardiotoxicity seen can be due to the direct effects of cancer treatment on heart function and structure, or may be due to accelerated atherosclerosis. Cardiovascular complications can be divided in 9 main categories: myocardial dysfunction and heart failure, valvular disease, arrhythmias, arterial hypertension, thromboembolic disease, peripheral vascular disease and stroke, pulmonary hypertension, pericardial disease, and coronary artery disease, which we'll be discussing today. This is our case. We have an 86-year-old male who came in stuporous and hypotensive with the following profile. Over the last 40 years, it has been shown that cardiovascular disease and cancer has been intertwined in a conundrum, and there is growing evidence indicating that cardiovascular disease and cancer share common risk factors and biological mechanism. Cardiovascular disease that predicts cancer diagnosis, or a cardiovascular disease that develops after cancer diagnosis due to cardiovascular risk factors, or it could be due to cardiotoxicity of cancer therapies. There are many risk factors shared between cancer and coronary artery disease. Inflammation and oxidative stress are common underlying pathogenesis in both disorders, and cancer therapy can result in endothelial injury, spasm, and coagulation, thereby increasing the risk for coronary artery disease. The mechanism of myocardial ischemia involves vasospastic effect due to endothelial injury, acute arterial thrombosis, long-term changes in lipid metabolism and consequent premature atherosclerosis, or a previous mediastinal radiotherapy may accelerate drug-related coronary damage. These are the following cancer therapies that have been shown to have coronary artery disease correlates. One is your fluoropyrimidines. Its mechanism is multifactorial, it's associated with coronary vasospasm and endothelial injury. Chest pain and ischemic ECG changes typically occur at rest and within days of drug administration and sometimes persist even after treatment cessation. A recent study showed that up to 18% manifest myocardial ischemia, up to 7 to 10% showed silent myocardial ischemia, while those treated with 5-FU showed silent ischemia of 6 to 7% using stress tests. Cisplatin, which involves arterial thrombosis with subsequent myocardial and cerebrovascular ischemia, is seen in 2% of patients. The pathophysiology is multifactorial, including procoagulant and direct endothelial toxic effects. Cisplatin-treated survivors have a higher incidence of coronary artery disease up to 8% over 20 years. Those who have been given with immune and targeted therapies, such as our case, ibrutinib, the vascular endothelial growth factor or VEGF signaling is important for endothelial cell survival, and inhibition can induce endothelial injury and thereby leading to coronary artery disease. Treatment with monoclonal VEGF antibody bevacizumab and anti-VEGF small molecule tyrosine kinase inhibitor cause an increased incidence of arterial thrombosis. For those who receive radiotherapy as treatment, it is frequent that they may have ostial coronary lesion. The most exposed coronaries are your left anterior descending artery leading to breast irritation, and the left main, left circumflex, and the right coronary artery during treatment for Hodgkin's lymphoma. A higher prevalence of stress test abnormalities have been found among women irradiated for left breast cancer compared with right-sided cancer. Radiation-related cardiac disease in patients with lymphoma typically manifests 15 to 20 years after initial treatment, and younger patients are more susceptible. Screen regularly for cardiac disease in patients who receive radiation therapy starting 10 to 15 years after the initial cancer treatment and continue lifelong. Incidence and onset of coronary artery disease after radiotherapy is dose dependent, specifically if the thoracic dose of more than 30 gray were considered to cause vascular disease. Silent ischemia is higher, possibly because of concomitant neurotoxicity of radiotherapy and chemotherapy. To react on our case, risk stratification of patients with cancer is needed to evaluate short and long-term effects of different cancer treatments. Pre-cancer therapy risk stratification allow us to obtain a baseline of cardiovascular disease for further decision-making strategies. These should include good history and physical exam, a baseline ECG and echocardiography, and this patient should be on guideline-directed medical therapy to reduce cardiotoxicity, to control hypertension and dyslipidemia. There should be an initial coronary artery anatomy assessment, either angiography or CT angiography, including a physiologic assessment, FFR or IFR, or coronary imaging, either IVUS or OCT. These modalities will be an appropriate tool to complete a thorough evaluation, especially in patients presenting with ambiguous and intermediate lesions. In terms of fractional flow reserve, it shows that less than 0.8 indicates hemodynamic significant stenosis with an accuracy of 90%. In the FAME2 trial, comparing FFR-guided PCI with OMT versus OMT alone, it showed lower rates of urgent revascularization and decreased risk of death and MI when compared to OMT alone. The COURAGE trial showed the importance of FFR-guided PCI when demonstrated in the treatment of ischemic coronary disease and can guide help coronary revascularization. In Nascimento's meta-analysis, it suggests safety of deferral of patients with normal FFR and those receiving intervention with abnormal FFR. Coronary imaging such as IVUS, because of its higher spatial resolution and imaging of vascular wall, allows a better characterization of luminal processes. It allows early detection of procedure-related complication and suboptimal stent expansion. While optimal coherence tomography or OCT is capable of characterizing the morphological features of a vulnerable plaque and allows identification of stents considered low risk and high risk for thrombosis according to strut endothelialization, underexpansion, and residual stenosis. To summary, assessment of coronary artery disease should be based on history, age, gender of the patient, considering the use of chemotherapy drugs as a risk factor for coronary artery disease. Clinical evaluation and, when necessary, testing for detection of myocardial ischemia is key to identify patients with latent pre-existing coronary artery disease. Patients treated with pyrimidine analogs should be closely monitored for myocardial ischemia using regular ECGs, and chemotherapy should be withheld if myocardial ischemia is noted. Drug rechallenge after vasospasm should be reserved for when no other alternative exists and only under prophylaxis and close monitoring of the patient. Pretreatment with nitrates and calcium channel blockers may be considered in this setting. Long-term follow-up may be useful to identify patients who develop long-term complications of chemotherapy and radiotherapy.
Thank you, Dr. Lucero. After hearing our invasive cardiologist's point of view, we'd like to ask our hematologist the following questions. Since this patient exhibited toxicity to ibrutinib, what are the alternative treatment regimens for this patient that will be effective for his malignancy, but at the same time less cardiotoxic? For this particular case, is there a specific platelet count at which the antiplatelet needed to be discontinued? And from a hematologist's viewpoint, will doing further aggressive management for their cardiac problem benefit patients with hematologic malignancies given their risk and their prognosis?
So, good day. So, as my reaction for the first case, I start the following are my disclosure, and I'd like to give a brief overview of chronic lymphocytic leukemia. CLL is a heterogeneous disease that presents with malignant clonal B cells in the peripheral blood, bone marrow, spleen, and the lymph nodes, or a combination of these sites. Presence of malignant B cells in the lymph node without presentation in the peripheral blood and the bone marrow is sometimes called small lymphocytic lymphoma. But CLL and small lymphocytic lymphoma most of the time would have the same biology. CLL is the most common leukemia in adults. The diagnosis is straightforward using the flow cytometry. The following are the common markers which the malignant B cells would express when flow cytometry is done. The molecular pathogenesis of CLL can be complex. It is influenced by the microenvironment of the bone marrow and the lymph nodes. The B cell receptor and other signaling pathways are important in its proliferation and persistence. Genomic aberration, mutations, genetics, and cytogenetics affects its prognosis and clinical behavior. The presence of immunoglobulin mutation, P53, deletion 17, and deletion 13 are very important because it will also influence the ability of the patient to respond to certain treatment. The clinical course of CLL is highly variable. The survival time can be months to decades. It can transform to a more aggressive tumor like diffuse large B cell lymphoma. The treatment is wide range from watch and wait to hematopoietic stem cell transplant. CLL is a model system for other therapeutic developments or targeted treatment because of the expression of certain cell surface receptor, its dependence on BCL2, BTK, P13 pathway, and its response to the infusion of CAR T cells. So just a review or an introduction, the mechanism of ibrutinib. So what we do know about most of the B cell malignancy is that it depends on constitutive stimulation of the BCR receptor. And once it is stimulated, this results in signaling pathways that will affect gene expression that will eventually lead to the proliferation, persistence, and survival of malignant B cells. But what BTK does is that it inhibits what ibrutinib does is that it inhibits the BTK, which sort of acts as a bridge from the BCR into the nucleus. So if you inhibit the BTK, signal will not be propagated into the nucleus and it will not be able to increase gene expression, which will promote proliferation of the malignant clone. But we have to understand that ibrutinib can have off-target effects that can affect the cardiac muscle and the platelet. Bruton tyrosine kinase and TEC are both involved in collagen-induced platelet activation, and ibrutinib binding to both kinases have been associated with impaired coagulation. So ibrutinib can result to some bleeding. AF may be partially mediated by decreased inositol 3 kinase, AKT, signaling in cardiomyocytes due to BTK and TEC inhibition. It was also shown that blocking the ERBB2 HER2, which is another kinase with the potential for irreversible ibrutinib binding, results in cardiomyocyte dysfunction and reduced heart contractile efficiency. The median time for cardiac complication is usually 2 to 3 months once these medicines are started, and patients can develop hypertension in 4 to 6 months. But it can be earlier for patients who are heavily treated or who are already in the relapse refractory stage, who were given multiple chemotherapy or multiple chemoimmunotherapy. So the salient points of case number 2. So we were presented with an 86-year-old male diagnosed with hypertension and diabetes with history of coronary artery bypass graft in 2006. He was also diagnosed with CLL, which is usually staged using the Rye and Minay staging. It was stated that it was stage 4, so I think it's Rye stage 4 because of the presence of significant anemia and thrombocytopenia. But it did not say in the protocol if the CLL already involved into a more aggressive lymphoma. There was no note of history of previous treatment. CLL usually start as an indolent hematologic malignancy, so it doesn't occur over several months. Usually, it is present for several years. As I said, the treatment can be as wide as watch and wait to hematopoietic stem cell transplant. The patient presented with anemia, thrombocytopenia with significant lymphocytosis. Unfortunately, there was no information on the tumor burden like LDH, uric acid, electrolytes, etc., that will help us assess the risk for a tumor lysis syndrome when we start certain medications. FISH results or flow cytometry was not also given to tell us what is the biology of the disease or if it already evolved into a more aggressive lymphoma. Immunoglobulin level will also help us anticipate significant infection when we start chemoimmunotherapy or targeted treatment for this patient. The patient developed significant symptoms after 6 days of ibrutinib. But given the case that the patient had significant anemia, thrombocytopenia, and multiple presence of lymph node, it could be that the patient also had tumor lysis syndrome once the targeted treatment was started. There could have been a drug-induced platelet dysfunction leading to bleeding, leading to significant anemia that might have resulted to high cardiac output failure. So it might be multiple factors that resulted in the presentation and multiple factors that contributed to the presentation of the patient. So the first question is, since the patient exhibited toxicity to ibrutinib, what are the alternative treatment regimens for this patient that will be effective for his malignancy, but at the same time less cardiotoxic? There are certain principles that we need to remember for hematologic malignancy. First is in starting any treatment for hematologic malignancy, the biology and characteristic of the tumor should be well defined. Is it an indolent type? Is it an aggressive type? We need to anticipate in most of the hematologic malignancy the risk of a tumor lysis syndrome, especially for an aggressive or a bulky tumor. What are the ongoing medications that may interact with the chemoimmunotherapy or the targeted treatment? Most of this treatment are metabolized in the liver, so we need to take note what other medications the patient is taking. What is the degree of myelosuppression of the treatment that we are proposing? Because if we are going to induce significant neutropenia at a very short time, that can expose the patient to significant risk of infection and sepsis, and the age of the patient and the other comorbidities, he might not be able to tolerate a significant infection. We have to remember also that giving an inappropriate drug will expose patients to adverse event with no therapeutic benefit. But to answer the question, there are newer BTK inhibitors that are coming into the market that are less cardiotoxic. And this slide summarizes the difference between the tyrosine kinase that ibrutinib will inhibit compared to the newer generation of the BTK inhibitors. Example, acalabrutinib would have lesser stimulation of the TEC, which have an implication on atrial fibrillation and inefficiency of cardiac contractility. So the number two question is, for this patient, is there a specific platelet count at which the antiplatelet is needed to be discontinued? So again, we need to remember certain principles. Generally, we maintain hemostatic stability at a platelet count of 50,000 and above. So most of us, if there are no other compounding comorbidities and everything else is okay, most of us can undergo a major surgery without bleeding if our platelet count is above 50,000. We do know for certain that platelet transfusion is needed for a platelet count of less than 10,000, and the risk of bleeding when the platelet count is less than 10,000 is very significant. So patients undergoing chemotherapy in hematologic malignancy when the platelet count is less than 1,000 needs a platelet transfusion. Platelet function is affected by hematocrit because of the platelet vessel wall interaction. So the lower the hematocrit, the farther away the platelet is from the blood vessel. So the platelet would have a difficult time being activated and aggregating. Creatinine also affects platelet function and other medications of the patient. Hyperleukocytosis, which is seen in leukemic patients, can increase the risk of thrombosis. So even if the platelet count is very low, but the WBC count, or there's a lot of malignant tumor that is circulating, that can also result to thrombosis. So cellular component of the blood flow, circulating tumor, comorbidity that can affect our decision regarding anticoagulation or antiplatelet therapy. And this should be patient specific and should be in close coordination with the other attending physician or the cardiologist managing the patient. So there's no standard guideline that will tell us how to approach this patient, but we need to take into consideration all the factors, all the comorbidities, and the situation of the patient. So number three, will doing further aggressive management for their cardiac problem benefit patients with hematologic malignancy given the risk and their prognosis? Well, the general answer is yes. Aggressively managing cardiac problems will enable the patient to tolerate therapeutic intervention for his hematologic malignancy. You have to remember that CLL is a chronic disease, and it can have a very indolent behavior, but it can also become aggressive over time. CLL is also incurable. So the prognosis is defined by molecular, genetic, epigenetic characteristics of the tumor, as well as patient-specific comorbidity and condition. So again, there's no guideline or straightforward answer, but each patient should be assessed well and should be coordinated with the other attending physician and with the cardiologist as to which is the best treatment for this patient.
For this session, we have a case of a young woman with cancer who developed heart failure symptoms after receiving chemotherapy. We will discuss the management of heart failure caused by cancer therapy from the cardiovascular and oncology standpoint. Our patient is a 44-year-old woman, single, Filipino, with no known comorbidity, who came in due to profuse uterine bleeding. A year prior to admission, she developed abnormal uterine bleeding, and on workup, she was diagnosed with uterine leiomyosarcoma. Her baseline cardiac function was good, with 2D echo showing a normal left ventricular and right ventricular dimension, good systolic and diastolic functions, with an ejection fraction of 69% by Simpson's method. She underwent robotic hysterectomy, followed by bilateral oophorectomy. She started receiving chemotherapy with doxorubicin every 21 days. 2 months prior to admission, she received her last cycle of doxorubicin. 4 days prior to admission, however, she started experiencing heart failure symptoms such as esophatigability, dyspnea on minimal exertion, paroxysmal nocturnal dyspnea, and 2 pillow orthopnea. and on day of admission, her symptoms persisted, prompting her to consult at the emergency department. Her past medical history was unremarkable, with no known cardiovascular risk factors nor any other comorbidity. She has family history of colon, breast, and lung cancer, but no family history of premature CAD nor other cardiovascular diseases. She is a non-smoker, non-alcoholic beverage drinker, no history of illicit drug use nor OCP use. Pertinent on physical examination are highlighted in red. On survey, she speaks in sentences with occasional pauses. She was tachycardic at 104, tachypneic at 24, with distended neck veins and a JVP of 12. Chest and lung findings showed by basal crackles. Cardiovascular PE showed tachycardia and a grade 2 hollow systolic murmur, best heard at the apex. And extremity examination showed a grade 1 bipedal edema. The working impression at this time was chemotherapy-related cardiac dysfunction, doxorubicin-induced cardiomyopathy, HFrEF, with an NYHA functional class 3C, uterine leiomyosarcoma, post-robotic hysterectomy, post-bilateral oophorectomy, post 6 cycles of doxorubicin chemotherapy. Her chest x-ray showed a normal cardiac silhouette with no active infiltrates but with signs of venous congestion. Her ECG showed sinus tachycardia with non-specific ST wave changes. Pertinent on blood examination was an elevated NT-proBNP of 2,705. Her 2D echo at the parasternal long axis view showed a normal left ventricular and right ventricular dimensions, but with hypokinetic walls, minimal pericardial effusion, and a dilated left atrium. Color Doppler showed mild to moderate mitral regurgitation. Short axis view at the level of the great vessel showed normal aortic, pulmonic, and tricuspid valves, hypokinetic RV wall, and a dilated left atrium. Short axis view of the left ventricle showed global hypokinesia. Apical views showed hypokinetic LV walls and dilated left atrium. This was signed out as normal left ventricular size with global hypokinesia and severely reduced systolic function with an ejection fraction of 25%, moderate diastolic dysfunction, normal RV size with mildly reduced systolic function, dilated left atrium, mild to moderate mitral regurgitation, trivial pericardial effusion, and normal pulmonary pressure. Here are some questions for our cardiologists in the panel. Why do we need to provide a thorough cardiac assessment for cancer patients? And what are the factors associated with the risk of cardiotoxicity following chemotherapy? How will we proceed with cardiovascular risk assessment for this particular patient who has no comorbidity? When do we start cardioprotection? What are the recommended cardioprotective agents? And how often should we monitor this particular patient?
So good afternoon, everyone. Thank you for attending this afternoon's session. Again, we are presented with an interesting case of a 44-year-old female without known comorbidities who was diagnosed as a case of leiomyosarcoma given anthracycline-based therapy, who unfortunately developed heart failure. So why do we need to provide a thorough cardiac assessment for cancer patients? So we need to understand that cancer and heart failure are the two leading causes of death in different countries, so that would include the Philippines. And they are very much intertwined with each other, and they have this dovetailing phenomenon. So for the reason that cancer treatment increases the risk for heart disease in the broad fashion, so that would include your heart failure, ischemic heart diseases, hypertension, arrhythmias, or even thromboembolic events. Likewise, heart disease is actually a risk factor, or it increases the risk for developing cancer primarily because they might share the same pathophysiologic mechanism, and they even have the same risk factors. And lastly, patients with cardiovascular diseases are at higher risk to develop cardiotoxicity during their treatment. So because of the options for chemotherapies and immunotherapies are expanding, there is a need for us to understand their impact in the cardiovascular system and to be able to assess the risk of the patients prior to the start of treatment and during the treatment. So here is a landscape on how you would go about with the treatment of your patient. So our role in oncology should go beyond clearance and should rather focus on survival. So you can see here that we have a role in pre-treatment, during treatment, and post-treatment, modifying risk factors, giving appropriate treatment, and reduce interruption of cancer therapy, and to be able to discuss with your oncologist with regards to the risk benefit ratio on treatment strategies, and to be able to follow up this patient post chemotherapy. So in general, here are the risk factors for developing cardiotoxicity based on different factors, focusing on cardiovascular related factors, which includes heart failure, asymptomatic LV dysfunction, previous CADs, moderate to severe valvular heart diseases, presence of hypertensive cardiovascular disease, especially for those patients who already have left ventricular hypertrophy, presence of cardiomyopathies, and significant arrhythmias. Focusing on anthracycline, since our patient doesn't have any comorbidities, risk factors would include your cumulative dose. She's a female, predisposing her to develop cardiotoxicity. Those patients who are older and younger, presence of renal failure, use of radiotherapy, and concomitant use of chemotherapy that are notorious for causing cardiotoxicity. And as I mentioned, pre-existing cardiac conditions that were discussed a while ago. So the incidence of left ventricular dysfunction in doxorubicin is shown in this table. Therefore, it's important to always ask the medical oncologist regarding the dose of the agents that will be used, or if they're planning to combine it with other modality. So aside from high-risk patient profile, you should also consider high-risk treatment protocol. So that would include high doses of anthracycline in the form of doxorubicin of more than 250 milligrams, high doses of radiotherapy in the mediastinal field. Low-dose anthracycline may also occur in less than 250 milligram if you combine it with radiotherapy. Likewise, toxicity may occur in lower doses of anthracycline of less than 250 if the patient has multiple cardiovascular risk factors. So that will include hypertension, smoking history, dyslipidemia, diabetes, and obesity. Patients who are older, female, with compromised cardiac function, including ejection fraction of 50 to 55%, history of MI, moderate to severe valvular heart diseases that occur before or during treatment. Likewise, it may also develop if you are going to give the patient sequential treatment with your tyrosine kinase inhibitors. So as I mentioned, aside from identifying the risk factors, patients' demographics, and patients' treatment protocol, it's also important to get their baseline measurement of cardiac function. So with regards to screening, outlined here is the recent review published in 2019 on the role of cardiovascular imaging and biomarkers. So you can see here that MAGA, I think you can opt not to use it anymore, except in certain instances where you cannot do your echocardiography or your MRI. And transthoracic echocardiography certainly should be the standard. There are different societies who gave their recommendation, and we can see here that they all agreed to have transthoracic echo at baseline, but they would only differ on the frequency of monitoring. So the EAC recommends that transthoracic echo should be done at baseline and at the end of treatment, or if you hit the cumulative dose of 240 with addition dose of 50 milligrams per dose. Likewise, should be monitored 6 months after completion of chemotherapy. For the ESC, they recommended a repeat study again at 250 milligram of anthracycline with concomitant long-term surveillance, and the ASCO will only do it at baseline and after completion. So at this point, long-term surveillance is recommended with our patient at 1 to 5 years because she received high dose of anthracycline. Likewise, she developed LV systolic dysfunction during treatment. So the expert consensus on multimodality imaging actually recommended that echocardiography is the method of choice for the evaluation of patients before, during, and after cancer therapy, and accurate calculation of your left ventricular ejection fraction should be done. And ideally, if available, 3D echo is the best choice. But when you're using 2D echo, the modified by Simpson's method technique is the method of choice. So Here is a review of biomarker studies. You can see that the studies have modest sample sizes, with the exception of your troponin I in the study done by Cardinal with a sample size of 703. So troponin is probably the best marker that we can have for detecting chemo-related cardiotoxicity. BNP has been used and investigated, and we do use it to some extent. But the advantages of your biomarkers, like your troponin, is that it may detect early cardiac injury, and a rise in your troponin may indicate high risk for development of cardiotoxicity, favorable response with your ACE inhibitors as included in the evidences. And when you combine it with GLS, they may have higher sensitivity to predict future cardiotoxicity. So at this point, routine use is still not recommended, and it still need further investigation, but you should consider monitoring your markers in high risk group and for those patients who are supposed to undergo high risk treatment protocol, like in our case. So it has a very good negative predictive value. However, there are limitations and challenges with biomarkers as stated in this slide. So with regards to cardioprotection, the role of cardioprotective medication is somewhat controversial in the terms of putting patients on ACE inhibitors, beta blockers, or ARBs. So with regards to primary prevention, so the trials, as you can see here, have again modest sample sizes looking at your beta blockers and ACE inhibitors. So the ones that are positive here in the result is the Bosch study showing modest change in the drop of ejection fraction when compared to placebo when you give your enalapril and your carvedilol. So another promising agent here is the nebivolol, again showing benefit over placebo with regards to prevention in the reduction in ejection fraction. So as guidance, the ESC suggests that the use of cardioprotective medication in the form of your ACE inhibitors, beta blockers, and ARBs should be given among patients with pre-existing clinical heart failure or significant LV dysfunction at baseline, and the initiation of cardioprotection among patients should be considered for those patients whose troponin is increasing with high doses of anthracycline regimen. So here's a meta-analysis including 17 trials. You can see here that there is a tendency towards lowering adverse clinical events with neurohormonal therapies. However, it did not meet statistically significant values, and because the design is heterogeneous. However, you could still consider giving the medication because of its potential benefits. So other pharmacologic therapy that are promising would include your spironolactone and statin therapy, but for the interest of time, I'll be limiting the discussion with these neurohormonal agents. So here are the other non-pharmacologic therapies. So to re-emphasize reduction in cardiovascular risk, and another promising would be the use of your moderate aerobic exercises to prevent and treat chemotherapy-induced cardiotoxicity. So when do we start treatment or therapy? You have to consider giving the medication for high-risk patient that I've already laid out, for those patients who are supposed to undergo high-risk treatment protocol, and for those patients showing signs of LV dysfunction like ejection drop of more than 10% from baseline, GLS drop of more than 15%, or if there is an increasing trend in troponin. Likewise, if the ejection fraction falls below 50%. So presented here is the best practices for the prevention, monitoring, and treatment of chemo-related cardiac dysfunction. So for this patient, since she developed severe systolic dysfunction, it is prudent to discuss with the oncologist plan of treatment and discontinuation of anthracycline-based therapy since her ejection fraction fell below 45%. So if she'd be started on another treatment regimen, it is ideal that should be closely monitored with regards to her cardiac biomarkers, and it should be periodically repeated every 3 to 6 weeks or once she reach the high risk doses. So repeat echocardiography is also recommended after a month of initiation of therapy for cardioprotection, then after third month, or symptom driven if she developed other new symptoms related to cardiac dysfunction. And then repeat echo study should be done at 6 to 12 months after completion of chemotherapy, and you have to extend it up to 5 years since she developed left ventricular dysfunction. So if there is no improvement in her cardiac function despite management with cardioprotective agents, then you should follow the heart failure guideline accordingly. So the key point here is the paradigm has shifted towards early recognition and treatment of cardiotoxicity and even pre-cancer therapy and cardiovascular risk assessment and prevention. So the key practical steps in cardio-oncology approach is outlined here, and I hope you can use this as a guide when you are dealing with your cancer patient. So with that, I end this short discussion, and I'll be listening to our reactor after this, and hope to see you in the open forum.
Here are some questions for our oncologists in the panel. Apart from pre-existing cardiovascular risk factors or the presence of heart failure from other etiologies, what other factors may contribute to the development of cardiotoxicity? How do we balance the expected benefits of cancer therapy with its inherent risk of cardiotoxicity, particularly heart failure? And in this particular patient, are there safe options for treatment in case of a relapse or failure of remission?
Good afternoon, doctors. I am Dr. Herdy Gloria Luna. I'm a medical oncologist. Thank you for allowing me to share data and insights, this time on the case of anthracycline-induced cardiotoxicity. So the question is, aside from pre-existing risk factors for heart disease or the presence of heart failure from other etiologies, are there other factors that may lead to the development of cardiotoxicity from chemotherapy, such as dose, frequency of administration, weight of the patient, and pre-chemo functional status? So these are the risk factors for anthracycline cardiotoxicity. Most were discussed a while ago and include older age or very young age, female gender, pre-existing cardiovascular disorders such as LVEF of 50% and below, hypertension, smoking, hyperlipidemia, obesity, diabetes, radiation therapy involving the cardiac silhouette, the high cumulative anthracycline exposure, and the use of trastuzumab. Recognition of these factors and response to them by using non-anthracycline chemotherapy when appropriate has diminished the incidence of anthracycline-induced heart failure. So evidence suggests that obesity is associated with an increased likelihood of developing cardiac dysfunction after anthracyclines. For example, in a meta-analysis of 15 studies, including approximately 8,700 breast cancer patients treated with either anthracycline or sequential anthracycline and trastuzumab, the odds ratio for overweight patients or those with BMI of more than 25 for cardiac dysfunction was 1.38 relative to those with BMI of less than 25. A higher magnitude of risk was observed among those who were obese or with BMI more than or equal to 30. So cumulative anthracycline exposure is a constant risk factor. The risk for doxorubicin-related clinical heart failure ranges from 0.2 to 100% for cumulative doses ranging from 150 to 850 milligram per meter squared. We will also focus on the use of trastuzumab later on. So here are the anthracycline equivalency doses. Doxorubicin has a relative cardiotoxicity of 1, with epirubicin at 0.7, daunorubicin at 0.75, and idarubicin of 0.53. Incidence of heart failure rises to more than 5% at these doses. Doxorubicin at 400 milligram per meter squared, epirubicin at 900 milligram per meter squared, daunorubicin at 800 milligram per meter squared, idarubicin at 150 milligram per meter squared. When cardiotoxicity is defined to include development of asymptomatic LV dysfunction, rates of cardiotoxicity are higher. In one study, the rate of doxorubicin-induced cardiac dysfunction, either symptomatic or asymptomatic, but with a decline in the ejection fraction, was 6.5, 8.8, 17.9, and 32.4% at cumulative doses of 150 milligram per meter squared, 250 milligram per meter squared, 350 milligram per meter squared, and 400 milligram per meter squared. While limited data are available on the prognosis of an asymptomatic decline in the LVEF among patients treated with anthracyclines, studies of broad population of patients with asymptomatic systolic dysfunction have identified an increased risk of heart failure and cardiovascular death. The addition of trastuzumab to anthracycline or the concomitant use of two cardiotoxic agents demonstrated a higher incidence of cardiac dysfunction and a higher CHF and YHA class 3 to 4 compared when anthracycline was used alone and trastuzumab was used alone. But the cardiotoxicity profile and potentials of anthracycline and trastuzumab differ. Type 1 cardiotoxicity was demonstrated by doxorubicin, wherein cumulative doses of doxorubicin causes oxidative stress by the free reactive oxygen species, causing irreversible myocardial damage. Upon biopsy, you will see vacuoles, myofibril disarray, and necrosis. Type 2 cardiotoxicity was demonstrated by your trastuzumab, wherein non-cumulative doses of your trastuzumab causes reversible myocardial dysfunction. Biopsy findings do not show ultrastructural changes. The next question is, how do we balance the expected benefits of cancer therapy with its inherent risk of cardiotoxicity, particularly heart failure? So, the 5-year survival rate for women with non metastatic invasive breast cancer is high, around 90%. The average 10-year survival rate for women with non metastatic invasive breast cancer is around 84%. If cancer has spread to a distant part of the body, the 5-year survival rate goes down at 28%. So we need to improve survival outcomes by giving highly effective treatment early on in the disease. So how we do not want these cancer patients, early cancer patients, progressing or relapsing. That's why we need to give highly effective treatment upfront. So how do we weigh the benefits over the risks? Let me walk you through a journal on personalized decision making in early stage breast cancer patients. So applying clinical prediction models for anthracycline cardiotoxicity and breast cancer mortality. So first, they created a model for cardiotoxicity. In this model, they included pre-specified covariates. So that is age, BMI, hypertension, baseline LV ejection fraction, which were documented in other journals. So they found out that in this prediction model, the increasing age, higher BMI, and lower baseline LVEF were significantly associated with cardiotoxicity at 1 year. Hypertension was not significantly associated with the outcome in the multivariate analysis. So cardiotoxicity range varied from 2% in the lowest risk quartile to 11% in the highest risk quartile. So an extreme quartile risk of 5.5. Next in the study, they estimated the risk of cardiotoxicity stratified by the anthracycline benefit of breast cancer mortality at 5 and 10 years. Patients were divided into strata based on the expected reductions in breast cancer mortality, whether it's low at less than 2%, intermediate at 2 to 6%, or high at more than 6%. And the predicted cardiotoxicity is shown in each column. So these are the number of patients. So absolute breast cancer mortality benefit was calculated using the PREDICT model with a modification to compare anthracycline plus taxane versus non-anthracycline regimens. And the cardiotoxicity was estimated using the cardiotoxicity clinical prediction model that we've discussed a while ago. So green shading suggests situations of clear net benefit, while the red shading suggests situations wherein the risk of cardiotoxicity may outweigh the benefits. So gray shading denotes situations of uncertainty of risk benefit. So tumor aggressiveness factors are the main considerations for the prediction of breast cancer mortality. And based from the table in the previous slide, age, BMI, and baseline LV dysfunction can be predictors of cardiotoxicity or were the predictors of cardiotoxicity. Therefore, the balance of these tumor and patient risk factors determine our clinical judgment for overall benefit over risk considerations. Among patients with low breast cancer mortality, there are non-anthracycline options to offer to decrease the likelihood of getting cardiotoxicity. So in this particular patient, are there safe options for treatment in case of a relapse or failure or remission? Allow me to share with you the selected potential cardiac drugs in oncology, focusing on the incidence of heart failure and myocardial infarction. So our patient received doxorubicin and other anthracyclines like epirubicin and liposomal A also have cardiotoxic incidence or cardiotoxic effects, and these cannot be given to the patient anymore. So other options like ifosfamide, docetaxel, pazopanib can be given to the patient, but with caution on heart failure and myocardial infarction, since they have documented incidents. On the other hand, we also have medicines such as trabectedin, gemcitabine, and eribulin that can be given without known cardiotoxic side effects.
We're down to our third, which is a case of VTE in a female with newly diagnosed ovarian cancer. She's 56 years old, known hypertensive, who consulted due to left leg swelling. That started 4 days prior to admission, and this was associated with pain. 2 days prior to admission, she noted progression of the swelling and an increase in abdominal girth. She consulted as outpatient, and the following workup were done. The CBC showed leukocytosis but no anemia or thrombocytopenia. Malignancy was suspected by the physician, hence two more markers were done, and it showed elevated CA125. The CEA was normal. The transrectal ultrasound showed the following findings. There was enlarged retroverted uterus with thick endometrium, probably hyperplastic change, versus another endometrial pathology. Bilateral irregular complex structures with the following measurement, probably an ovarian new growth versus tubo-ovarian complexes were seen. There was also irregular anechoic cystic structure with the following measurements for which they consider an encysted fluid versus ovarian new growth. There was minimal posterior cul-de-sac fluid and moderate ascites. So she was admitted, and on admission, these were the pertinent findings on physical examination. She was tachycardic. The abdomen was globular and with a palpable mass at the hypogastric area. The extremities were warm with good peripheral pulses, but there was grade 2 pitting edema on the left leg. So a consideration was for venous thromboembolism was made, and hence the patient underwent venous duplex ultrasound and CT pulmonary angiography, which confirmed the presence of extensive DVT on the left lower extremity and pulmonary embolism respectively. Incidentally, during 2D echocardiography, the presence of IVC thrombus was also documented. A whole abdomen contrast CT was done for further evaluation of the findings from the transrectal ultrasound, and it showed an enhancing abdominopelvic complex mass that encased the uterus, distal ureters, and rectosigmoid colon with mass effect. So a malignant ovarian new growth was considered. There was also peritoneal carcinomatosis. The therapeutic dose of enoxaparin was then initiated, and she was referred to an interventional radiologist for ultrasound-guided biopsy of the abdominopelvic mass. Biopsy results showed metastatic papillary serous carcinoma with clear cell features. So all of this happened within the first 8 days of the patient's hospitalization. On day 9 of hospitalization, she was started on carboplatin and paclitaxel. On the 15th hospital day, which is 6 days from the initiation of chemo, she became neutropenic and thrombocytopenic. Fortunately, no major bleeding episodes were noted, and the platelet and absolute neutrophil counts slowly increased. The patient improved and was discharged on an oral anticoagulant. Post-discharge, she completed 3 more cycles of neoadjuvant chemotherapy prior to being scheduled for surgery. So the repeat scans showed decrease in the extent of the thrombus in the IVC and external iliac veins. There was resolution of the pulmonary embolism seen before, and there was decrease in the size of the abdominopelvic mass and an interval decrease in the peritoneal carcinomatosis. Eventually, she underwent radical dissection for tumor debulking of the ovarian cancer, Tabiso with infracolic omentectomy, and pelvic lymphadenectomy 3 months after the onset of her VTE. So we would like to hear first from our cardiologist, who is also a vascular medicine specialist. And these are the questions that we would like to ask. First, can VTE be the first manifestation of a malignancy? And in that case, should we routinely screen for malignancy in patients presenting with unexplained VTE? Since both low molecular weight heparin and DOACs have grade 1 recommendation for cancer-associated VTE, what are the factors that we need to consider in choosing anticoagulant for these patients? In this particular patient also, is placement of an IVC filter beneficial since she will eventually undergo cancer surgery and anticoagulation will be inevitably withheld for a time? And lastly, how do we adjust anticoagulation when thrombocytopenia occurs?
So for the first question, can VTE be the first manifestation of a malignancy? Should we routinely screen for malignancy in patients presenting with unexplained VTE? So in this study by Mark Carrier, published in 2015 New England Journal of Medicine, they randomized patients to limited screening and limited screening plus CT. So the primary outcome measure was confirmed cancer that was missed by the screening strategy and detected by the end of the 1 year follow-up period. So the 854 patients, 33, 3.9%, had a new diagnosis of occult cancer between randomization and the 1 year follow-up. So that's 14 of the 431 patients, 3.2% in the limited screening group, and 19 of the 423 patients, that's 4.5% in the limited screening plus CT group. So in the primary outcome analysis, four occult cancers, 29%, were missed by the limited screening strategy, whereas 5, 26%, were missed by the strategy of limited screening plus CT. So the prevalence of occult cancer was low among patients with the first unprovoked VTE, and routine screening with CT of the abdomen and pelvis did not provide a clinically significant benefit. And then a meta-analysis using 10 prospective studies with 2,316 patients evaluating cancer screening strategies in adults with unprovoked VTE with at least 12 months of follow-up. Mean age was 60 years. 58% of the patients received extensive screening. The 12-month period prevalence of cancer after VTE diagnosis was 5.2%, and the point prevalence of cancer was higher in patients who had extensive screening than in those who had more limited screening initially, but not at 12 months. And cancer prevalence increased linearly with age and was sevenfold higher in patients aged 50 years or older than in younger patients. The RETI score may be used to check for patients at high risk of having cancer after unprovoked VTE. So high risk would be a score of 3 or greater, low risk would be a score of 2 or less. So these are the factors involved: male gender, age more than 70 years, chronic lung disease, anemia, platelet count of 350 or greater, prior VTE. So in this study, external validation of the score, the RETI score seems to be able to identify a subgroup of high risk for cancer, that's 10%, in our specific data set of patients with unprovoked VTE. So another evaluation of the RETI score in predicting occult cancer in patients with VTE. So 472 patients, 31 or 6.6% received cancer diagnosis during follow-up. And the RETI score was evaluated in 467 of these patients. A high score was not significantly associated with cancer diagnosis during follow-up, which was mainly due to a poor performance in women. So up to 5 to 10% of unprovoked VTE receive a diagnosis of cancer after a VTE diagnosis. Available data do not support an extensive search for occult malignancy. It is important to pursue signs and symptoms which suggest an underlying malignancy and to ensure that age-appropriate screening tests be performed. Next question. Since both low molecular weight heparins and DOACs have a grade 1 recommendation for cancer-associated VTE, what are the factors we need to consider in choosing anticoagulant for these patients? So we have 4 studies of VTE in cancer. So Hokusai VTE using edoxaban, Select D with rivaroxaban, Adam VTE, and Caravaggio with apixaban. So we see that the risk of having the rates of recurrent VTE was lower, significantly lower among patients on DOACs compared to the patients on dalteparin. Major bleeding was similar between both groups, and clinically relevant non-major bleeding was higher in the DOAC groups compared to the dalteparin group, and this was more evident among patients with GI cancers. So if you have a patient with cancer with VTE, we assess the risk of bleeding, we ask for the patient's preference, and we check for drug-drug interaction. For patients at low risk of bleeding with no drug-drug interaction, a DOAC is preferred. For patients at high risk of bleeding, especially like luminal GI cancers, low molecular weight heparin is preferred. So for the ASCO guidelines, initial anticoagulation may include low molecular weight heparin preferred over unfractionated heparin if the renal function is normal, fondaparinux or rivaroxaban. Low molecular weight heparin, edoxaban, or rivaroxaban for at least 6 months is preferred for long-term anticoagulation over VKAs, and DOACs are associated with an increased risk of major bleeding, particularly for GI malignancies. In this particular patient, is placement of IVC filter beneficial since she will eventually undergo cancer surgery and anticoagulation will inevitably be withheld for a time. So from the ASCO guideline, the insertion of a vena cava filter should not be offered to patients with established or chronic thrombosis. So that's a VTE diagnosis more than 4 weeks ago, nor to patients with temporary contraindications to anticoagulant therapy like surgery. So this patient underwent surgery 2.5 months after the diagnosis of VTE. And there's also no role for filter insertion for primary prevention or prophylaxis of PE or DVT due to its long-term harm concerns. May be offered to patients with absolute contraindications to anticoagulant therapy in the acute treatment setting and in patients with progression of thrombosis despite optimal anticoagulant therapy, but these are based on expert opinion. The other question is, how do we adjust anticoagulation when thrombocytopenia occurs? So this is a common complication in patients with cancer, affecting a large majority of patients receiving certain chemotherapy regimens, especially those with hematologic malignancies. Despite the high bleeding risk, thrombocytopenia is not associated with a reduction of thromboembolic risk, and prolonged thrombocytopenia over 30 days is associated with a fourfold increased risk of recurrent VTE. The main challenge, therefore, is balancing the opposing risks of bleeding and VTE recurrence. So the aspects to be considered will be recurrent will include thrombosis burden like the size, location, time from event, history of VTE, and etiology. So according to the recent recommendations from the Scientific and Standardization Committee of the ISTH, because of the higher risk of VTE recurrence during the acute phase, that's less than 30 days from the event, full dose anticoagulation is recommended for patients with a platelet count of 50 or greater. For patients with symptomatic segmental PE and proximal PE, proximal DVT, or history of recurrence, full anticoagulation associated with platelet transfusion, the threshold is 40 or lower, may be indicated. For distal DVT, incidental subsegmental PE, and catheter-related thrombosis, a dose modification strategy using 50% or prophylactic dose low molecular weight heparin is a feasible option for platelet count between 25 and 50. Generally, with this strategy, anticoagulation is discontinued under 25, but it's best to refer to the hematologist.
Thank you, Dr. Pina. Next, we'd like to ask these following questions for our oncologist, Dr. Herdy Luna. For patients who present with VTE as the first manifestation of underlying malignancy, is it always reasonable to treat them with chemotherapy or radiotherapy alone and delay surgery to allow uninterrupted anticoagulation? And are there any specific chemotherapeutic agents which interact with the DOACs approved for use in cancer-associated VTE, such as edoxaban, rivaroxaban, and apixaban?
For patients who present with VTE as the first manifestation of underlying malignancy, is it always reasonable to treat them with chemotherapy or radiotherapy alone and delay surgery to allow uninterrupted anticoagulation? The principles of managing acute VTE in patients with cancer are the same for patients without cancer, with anticoagulant therapy as the cornerstone of treatment. However, treatment of VTE in cancer patients has higher than usual rates of both VTE recurrence despite anticoagulation and bleeding events. According to population-based case control studies, the 2-year cumulative incidence of VTE is between 0.8 and 8%. In a retrospective study, cancer patients were found to have a threefold higher risk for recurrent VTE than patients who had an initial VTE in the absence of malignancy. The probability of readmission for recurrent VTE within 183 days was 22% for cancer patients compared with 6.5% for those without malignancy. Patients with the highest 1-year incidence rate for VTE are those with advanced disease of the brain, lung, uterus, bladder, pancreas, stomach, and kidney. For these histotypes, the rate of VTE is 4 to 13 times higher among patients with metastatic disease as compared with those with localized disease. The poor prognosis of VTE may reflect both a combination of fatal complications and higher disease aggressiveness. Recent study report that the results of a retrospective analysis in 227 pancreatic cancer patients who had received gemcitabine-based chemotherapy for locally advanced or metastatic disease showed that clinical occurrence of symptomatic VTE confirmed a worse response rate and worse progression-free survival and worse overall survival. Since the authors did not retrieve from medical charts acute death due to pulmonary embolism, it seems unlikely that the complications of VTE can account entirely for the increased mortality among the patients evaluated in the retrospective analysis. Hence, these data suggest that in these patients, the development of VTE may reflect the presence of a biologically more aggressive cancer that in turn leads to a worse prognosis. So the question, is it always reasonable to treat them with chemotherapy or radiation therapy alone and delay surgery to allow uninterrupted anticoagulation? So there are factors and issues to be considered in the decision making. And here, stage of the patient, like in our case, an advanced ovarian cancer with peritoneal carcinomatosis, with intent for chemotherapy, as well as therapeutic goal like palliation of the symptoms related to VTE, planned oncologic intervention, immediate prognosis, hospice care, and other causes of hypercoagulability state such as immobility should be taken into consideration. So in our case, systemic treatment and anticoagulation is a sound choice. Therapy can be complicated by comorbidities, procedures, and medication interactions. In general, our recommendations are consistent with the evidence-based society guidelines by the ACCP, ASCO, NCCN, ISTH, the European Cardiology Society, European Respiratory Society, and ASH. So most of the recommendations for anticoagulation is in accordance with the patient's preference and also with regards to the goal of cancer care, cancer treatment, and life expectancy. Randomized trial and meta-analysis for patients with VTE and active cancer shows us that there is superior efficacy of low molecular weight heparin as compared with warfarin in patients with VTE in association with active cancer. There is also comparable efficacy between low molecular weight heparin and DOACs. Heparin and indirectly DOACs are preferred compared to vitamin K antagonists for continued anticoagulation in VTE. So here you have an algorithm. It's a cancer-associated thrombosis algorithm. It's a consensus guideline from the Canadian Society in which contraindication to coagulation and the risk of bleeding are assessed, as well as the type of cancer, drug-to-drug interactions, and also the cancer status. Now, for first episode of acute VTE in patients with active cancer, anticoagulation therapy should be administered for at least 3 to 6 months, provided the bleeding risk is low and no clinically relevant complications from anticoagulation have occurred, like bleeding or thrombocytopenia. In general, we suggest extending therapy beyond conventional period in the following states: patients with active cancer and patients who recur while on and off anticoagulation. Active cancer is defined by the International Society on Thrombosis and Hemostasis as cancer diagnosed within the previous 6 months, recurrent, regionally advanced, or metastatic cancer, and cancer for which treatment has been administered within 6 months, or hematologic cancer that is not in complete remission. In addition, we believe that select patients assessed as high risk for recurrence by their physician may also be considered for extended treatment. These include persistent clot despite therapy, additional risk factors, high clot burden, or hypotension at initial presentation. The assessment for risk in patients with cancer is an exact science, such as fluid clinical judgment is warranted. Discontinuation is appropriate when the cancer is considered cured, although the true risk of recurrence in this situation is unknown. So here are the key messages. Active malignancy is a risk factor for VTE with rates of recurrence estimated to be as high as 10 to 20% per year. However, the risk varies considerably, being highest in those with active cancer and lower in those with cancer that is cured. Importantly, rates of bleeding on anticoagulants are higher in patients with active cancer. Thus, follow-up with yearly re-evaluation of the risk-benefit ratio for anticoagulants is important. During the evaluation, the decision to extend therapy indefinitely in this population should carefully weigh the benefit of preventing VTE recurrence against the risk of bleeding, while also taking into the consideration the type of cancer, burden of disease, treatment received, patient preference, and life expectancy. The second question is, are there any specific chemotherapeutic agents which interact with DOACs approved for use in cancer-associated BTEs? So although DOACs have significantly fewer drug-to-drug interactions than BKAs, drugs that strongly affect the CYP3A4 enzyme and or P-glycoprotein can alter the plasma concentration of the DOACs and can lead to clinically significant alteration in their anticoagulant effects. CYP3A4 is a member of the hepatic cytochrome P450 enzyme and is responsible for oxidative metabolism of both apixaban and rivaroxaban. In contrast, the bigatran, texylate, the prodrug, is metabolized by esterases in the plasma and liver without significant involvement of the CYP3A4. A substrate of CYP3A4, rivaroxaban and apixaban, are vulnerable to both inducers and inhibitors of this enzyme when given concomitantly, leading to potentially increased toxicity or decreased efficacy. Many chemotherapy drugs induce or inhibit the activity of the CYP3A4, the P-glycoprotein transporter, or both. In the next few slides, I will present agents commonly used by oncologists and their effects on CYP3A4 and P-glycoprotein. This information was obtained from FDA-approved package inserts and large drug databases. The interactions in these following slides are theoretical, as data for combined use of any of the DOACs and specific chemotherapy agents are limited. So here we have the table. Here's the list for CYP3 interaction, and this one is for documenting P-glycoprotein interactions as against to the oncology drugs present. Triple positive means strong interaction, double positive means moderate interaction noted, and single positive means there's a weak interaction. Circle indicates that the interaction has been documented. So the bold fonts indicate that the drug is either a strong or a moderate inhibitor of the CYP3A with or without P-glycoprotein interaction. These drugs have increased for interactions with the new oral anticoagulants that are metabolized by the CYP3A4. So some classes of chemotherapy appear to nearly universally interact with the CYP3A4, P-glycoprotein, or both. So these include antimitotic microtubule inhibitors, such as vinca alkaloids. So notice all three of them have interaction with CYP3A4 and P-glycoprotein. This is also noted in neurotoxins. So strong and moderate modulators of the CYP3A4 enzyme, especially those that interact with the P-glycoprotein, carry the highest relative risk for significant drug interactions with the DOACs. Drugs that exert moderate induction of CYP3A4 activity without significant influence on the P-glycoprotein transporter include the paclitaxel. Use of these in combination with rivaroxaban or apixaban could lead to decreased plasma concentration of either drug, but would have no impact on the bigatran concentration. So there's no clear class effect noted among the topoisomerase inhibitor. Notice these are triple positive, and topotecan has no interaction with CYP3A4. So these includes also your anthracyclines and also your alkylating agents. No clear class effect was noted here. Therefore, significant heterogeneity in drug interaction potential is noted within each of these medication classes. There's also a nearly universal interaction with the CYP3A4, P-glycoprotein, or both among the tyrosine kinase inhibitors, with the exception of your erlotinib, gefitinib, and the sorafenib. So no strong inducers of your CYP3A4 were identified in your tyrosine kinase inhibitors. So two moderate inhibitors of both CYP3A4 and P-glycoprotein, which are highlighted here, imatinib and crizotinib, were identified. So use of imatinib and crizotinib in combination with any of the DOACs could result in increased plasma concentration of the DOACs. No clear class effect also was noted in the anti-cancer hormonal agents. There is significant heterogeneity in the drug interaction potential noted within these medication classes. Bicalutamide, moderately inhibits CYP3A4 and could potentially increase the plasma concentration of rivaroxaban or apixaban if used in combination. So there's also a nearly universal interaction with CYP3A4, glycoprotein, or both among your immune modulating agents, including glucocorticoids and your mammalian target of rapamycin mTOR inhibitors, with the exception of your everolimus. So the list here of supportive care agents represents some of the most common non-chemotherapy drugs used in cancer patients, notably aprepitant and fosaprepitant. They are used mainly in highly emetogenic chemotherapy regimens, and they may cause either moderate inhibition or moderate induction of your CYP3A4. So depending on the duration of their use. Since these two medications can both moderately induce and inhibit CYP3A4 activity, the effects of rivaroxaban apixaban plasma concentrations are not clear. Most other supportive agents have little drug interaction potential, like this one, single plus. And with the exception of some pain palliation agents like your fentanyl, methadone, and acetaminophen. So that's it for the drug-to-drug interactions of DOACs and chemotherapeutic medications.
And lastly, we'd like to ask this one important question for our hematologist. How do we determine whether this patient's thrombocytopenia is secondary to the effects of chemotherapy or due to a heparin-induced thrombocytopenia?
So the question that was posted for me was that how do we determine whether this patient's thrombocytopenia is secondary to effects of chemotherapy or due to heparin-induced thrombocytopenia? So just a review, we know that platelets act in the primary hemostasis. Platelets can be an immunologic target of both your B and your T cells. And targeted receptors can lead to activation of platelets, example in heparin-induced thrombocytopenia, or clearance as seen in ITP. Platelets also play an important role in our innate immune system. The general causes of thrombocytopenia are as follows: increased destruction, like in patients with immune thrombocytopenia purpura, decreased production from the bone marrow as seen in patients diagnosed with aplastic anemia, increased sequestration like in patients with massive spleen, and hemodilution or patients who underwent massive transfusion. So the question is, how do we determine whether this patient's thrombocytopenia is secondary to effects of chemotherapy or due to heparin-induced thrombocytopenia? So we need to take note of the history, timing, clinical presentation, and laboratory test. For the history, usually for HIT, there is exposure to your unfractionated heparin. It is usually more common in patients who are undergoing surgery, more prominent in orthopedic patients, patients with an ongoing bacterial infection. And in the history, we always need to take note of the baseline CBC. For chemotherapy-induced thrombocytopenia, we need to take note of the chemotherapy agent that was used. There are certain chemotherapy agents like paclitaxel or carboplatin that can result in significant myelosuppression. The tumor type and tumor load. The higher the tumor load and the more aggressive chemotherapy we use, the more propensity to develop myelosuppression. And the more aggressive tumor can also invade the bone marrow, and this would result to significant myelosuppression when chemotherapy agents are used. Also, for chemotherapy-induced thrombocytopenia, we also need to take note of the previous CBC that was done prior to treatment. For the timing, for HIT, usually the platelet count would fall 5 to 10 days after the initial exposure to heparin, but it can also occur immediately when the patient has a history of exposure to heparin in the last 90 days. Since the anti-PF4 antibody is very specific to the PF4 expressed in the surface of the platelet, a fall in the platelet count seen in HIT will not involve your red blood cell and WBC. Most patients will also experience a 50% fall in the platelet count, and nadir is approximately 60, but it rarely falls below 20,000. As opposed to your chemotherapy, the platelet count can fall very low, can even fall as low as below 10,000, needing transfusion. Of course, it would be dependent on the treatment regimen that is used and the other comorbidity of the patient. The nadir or the start of the fall in the platelet count can occur on day 5 of chemotherapy and generally would nadir on day 14. Chemotherapy-induced thrombocytopenia would also involve the red blood cell and the WBC. Hence, it can induce significant pancytopenia. The clinical presentation of HIT, because the anti-PF4 antibody can result to activation of your platelet, as well as monocytes. So this can result in significant thrombosis, and it is present in 50% of newly diagnosed cases of HIT. Spontaneous hemorrhage is rare in patients with HIT, as opposed to your patients who receive chemotherapy presenting with significant thrombocytopenia. Bleeding or spontaneous hemorrhage can occur. In diagnosing HIT, we need to rule out other causes of thrombocytopenia. The 40 scoring is a very useful tool in diagnosing patients with HIT. A low score would have a high negative predictive value of 99.8%. And this is based on the timing of the thrombocytopenia, the presence of thrombosis, and other explanation for the patient's decreased platelet count. There are 2 laboratory tests that are available for the detection of HIT, and this is the identification of the anti-PF4 heparin antibody and the functional assay demonstrating the ability of HIT antibodies to activate wash platelets such as serotonin release assay. And this is generally considered the gold standard for diagnosis or heparin-induced platelet activation. But unfortunately, this is not available. But the anti-PF4 qualitative antibody determination is available in one of the big hospitals in our country. In this algorithm, I just want to show you how we can diagnose HIT. So basically, if the patient has a low score and a negative antibody to PF4, that would generally already rule out the diagnosis of HIT. But a positive PF4 would result in the increase the probability of HIT in the low score group to about 15.4%. Thus, a low or intermediate 40 score plus a negative antibody would exclude HIT, whereas other combination of results justify the use of an alternative anticoagulant and the HIT could be excluded. So for this case, the salient points is that thrombocytopenia was accompanied by anemia and neutropenia after giving chemotherapy with a high risk for myelosuppression. There was no progression of thrombosis with thrombocytopenia. The 40 score was 1, hence a negative predictive value of 99.8%. Thus, heparin-induced thrombocytopenia is unlikely. Clinical presentation of anemia and neutropenia with induction chemotherapy likely explain the patient's pancytopenia.
So that concludes our 3 cases for this session. We are now opening the floor for questions from our audience.
Good day, everyone, and thank you for attending the cardiovascular oncology session. Together with our session chair, Dr. Apostol Alday, we would like to thank our experts for their wonderful and relevant discussion. In the interest of time, we will skip the live Q&A segment and proceed to the presentation of Certificate of Appreciation. The Philippine Heart Association presents this Certificate of Appreciation to Dr. Jonald Lucero in recognition and acknowledgement of his invaluable contribution as a panelist in the Philippine Heart Association 51st Annual Convention and Scientific Meeting given this 26th of May 2021, signed by Dr. Ronald Cuico, Chair of the Scientific Committee, Dr. Jude Eric Cinco, Overall Chair, and Dr. Rolando Bugarin, President. The Certificate of Appreciation is given to Dr. Herdy Glorian Luna in recognition and acknowledgement of her invaluable contribution as the panelist in the PHA 51st Annual Convention and Scientific Meeting given this day of 26th of May 2021, signed by Dr. Ronald Cuico, Chair of the Scientific Committee, Dr. Jude Eric Cinco, Overall Chair, and Dr. Orlando Bugarin, President. The PHA presents the Certificate of Appreciation to Dr. Alma Reyes Calavera in recognition and acknowledgement of her invaluable contribution as a panelist in the PHA 51st Annual Convention and Scientific Meeting given on 26th of May 2021, signed by Dr. Ronald Cuico, Chair of Scientific Committee, Dr. Jude Eric Cinco, Overall Chair, and Dr. Orlando Bugarin, President. The PHA presents this Certificate of Appreciation to Dr. Nathania Fajardo in recognition and acknowledgement of her invaluable contribution as a panelist in the PHA 51st Annual Convention and Scientific Meeting given this 26th of May 2021, signed by Dr. Ronald Cuico, Chair of the Scientific Committee, Dr. Jude Eric Cinco, Overall Chair, and Dr. Orlando Bugarin, President. And the PHA also presents the Certificate of Appreciation to Dr. Alex Hunia in recognition and acknowledgement of his invaluable contribution as the panelist in the PHA 51st Annual Convention and Scientific Meeting given this 26th of May 2021, signed by Dr. Ronald Cuico, Chair of the Scientific Committee, Dr. Jude Eric Cinco, Overall Chair, and Dr. Orlando Bugarin, President. Thank you, everyone.
We now move on to snippets from our partner Zulik with a lecture on LDLC reduction using PCSK9 inhibitors, translation into outcomes, presented by Dr. Lourdes Ella Santos, Associate Clinical Professor of the UP College of Medicine, UP Philippine General Hospital, Diplomat of the Philippine College of Physicians, the Philippine College of Cardiology, and the Philippine Heart Association, Vice President of the Philippine Lipid and Atherosclerosis Society. The lecture is moderated by Chairman Dr. Maria Margarita Balabagno, Training Officer of the Adult Cardiology Fellowship Training Program, University of Perpetual Help Delta Medical Center, Las Piñas City, Consultant at the University of Perpetual Help Delta Medical Center and the Asian Hospital and Medical Center, Fellow of the Philippine Heart Association, Philippine College of Cardiology, and Philippine College of Physicians.
Thank you for that kind introduction. So without further ado, let me go ahead and share my slides. So I will be discussing in the next hour LDL cholesterol reduction using PCSK9 inhibitors, translation into outcomes. So the outline of the talk is walking you through LDL cholesterol and the levels throughout the years. We will look at identifying an extremely high-risk population and the role of PCSK9 inhibitors in lowering LDL cholesterol. We will review some clinical trial evidence and the impact on guidelines and recommendations. So let's begin with looking at LDL cholesterol levels through the years. In the 4S trial, looking at over 4,000 patients with coronary heart disease and then elevated LDL cholesterol levels, there was a 30% reduction in all-cause mortality and a 34% in reduction of major coronary events when patients were randomized to simvastatin versus placebo. During that time, patients had baseline LDL cholesterol levels of 190 and simvastatin reduced the LDL cholesterol down to 122 milligrams per deciliter. So back then in 1994, LDL cholesterol that was elevated was considered around the range of about 190 milligrams per deciliter. And yet, when LDL was reduced to 122 milligrams per deciliter, they saw a reduction in events looking at the Kaplan-Meier curve. In 1996, the CARE trial came out looking at over 9,000 patients with history of myocardial infarction or those who had had hospitalization for unstable angina. And in those patients, they found that patients with average LDL cholesterol levels at that time, so average LDL cholesterol levels at that time was considered about 130 milligrams per deciliter. When pravastatin was administered to these patients with average LDL cholesterol levels, bringing LDL cholesterol down to 97 milligrams per deciliter, they found a significant reduction in outcomes, fatal coronary heart disease and non-fatal myocardial infarction. In 2003, the PROVE-TIMI 22 trial looked at 4,000 patients hospitalized within 10 days for acute coronary syndrome. Here, they did head-to-head comparison of two statins, pravastatin 40 milligrams and atorvastatin 80 milligrams, which we know based on latest evidence that we are dealing with a lower intensity statin therapy versus a very high intensity statin therapy of atorvastatin 80. And in those patients using high intensity statin therapy, the average LDL achieved with atorvastatin 80 was brought down to 62 milligrams per deciliter. And when you had patients with LDL cholesterol of 95, bringing it down to an LDL of 62, there was a significant translation into reduction of events, 16% relative risk reduction during the months followed. Very lately, fast forward to 2017, after several clinical trials on dyslipidemia, came the IMPROVE-IT trial, where in over 18,000 patients randomized to statin versus non-statin plus statin therapy, there was a significant reduction in major CV events with a very small number needed to treat of 50. In this particular trial, the average LDL cholesterol achieved at the end of the trial with simvastatin ezetimibe was 53.2 milligrams per deciliter, where patients who were just on simvastatin had an LDL goal achieved of 70 milligrams per deciliter. In 2017, the recommendation was to push LDL cholesterol to below 70 milligrams per deciliter in high-risk individuals. For the first time in a clinical trial, during that time, pushing LDL down to 55 milligrams per deciliter, below 55 milligrams per deciliter, had an additional reduction in events on top of statin therapy. So when we plot this course, this historical course of LDL cholesterol, we saw significant changes in the cutoffs for LDL cholesterol, mainly because as LDL cholesterol was pushed to lower levels, 100, 70, and now less than 55 milligrams per deciliter, there continued to be reducing outcomes with even lower LDL cholesterol levels, where when we take a look at the IMPROVE-IT trial in patients whose baseline LDL was brought down to about 55 milligrams per deciliter, we saw a significant reduction in estimated major event rates for 5 years. So this impacted changes in LDL cholesterol goals, where from 2016 to 2019, we saw significant reductions in now goals for classified patients, whether they were low-risk individuals, moderate risk individuals, or high and very high risk individuals, with very big changes in the very high risk individuals, where now the LDL cholesterol goal based on the ESC 2019 recommendations is an LDL goal below 55 milligrams per deciliter, with a caveat of pushing it down to below 50% from baseline LDL cholesterol. And when we take a look at the driving force for LDL cholesterol goals, we really do see that cardiovascular concomitant risk factors are what dictate classifying our patients into these risk groups, where low risk patients are those without concomitant risk factors. Moderate risk patients are those with type 1 or type 2 diabetes that are new onset or less than 10 years. Patients very high risk are those with significant ASCVD with additional risk factors on top of familial hypercholesterolemia, CKD, or diabetes with target organ damage. But when we talk about that LDL cholesterol goal of less than 55 milligrams per deciliter, I want you to appreciate that there are further clinical trials that are showing a signal for additional benefit for LDL cholesterol lowering in our studies looking at PCSK9 inhibitors and other non-statin therapies that are pushing LDL cholesterol down on top of maximally tolerated or maximum intensity statin therapy. So let's look at this population of patients where lowest is better seems to be prolific. In the Fourier trial, they looked at patients with more than 2 myocardial infarctions, those with multivessel disease, patients with peripheral arterial occlusive disease, and those with recent MI more than 2 years ago. Patients with high lipoprotein a were also included in those patients who would benefit from lower push of their LDL cholesterol goal. The Odyssey outcomes showed benefit in pushing LDL cholesterol further in those with LDL over 100 milligrams per deciliter and those with high lipoprotein a. And again, the IMPROVE trial that we discussed looked at patients very high risk with DEMI scores and patients with CABG. So much so that when we take a look at the 2019 ESC recommendations, for the first time in those patients with ASCVD who have a second vascular event within 2 years, not necessarily of the same type as the first event, on maximally tolerated statin-based therapy, an LDL cholesterol goal of less than 40 milligrams per deciliter may now be considered. So again, lower numbers, much lower numbers. This is the first time we're seeing less than 40 milligrams per deciliter as a recommendation in an international guideline. So without a doubt, the role of LDL cholesterol in atherogenesis is already established. We know that the release of bioactive lipids portends to cellular remodeling, extracellular pathology through lipoprotein retention and deposits of micro and macrocholesterol crystals, cause accelerated atherosclerosis. We know that autoimmunity with ApoB and innate immunity initiating localized inflammation, recruitment of macrophages, as well as intracellular cholesterol and accumulation, and necrosis really portend to this pathologic role of LDL in atherogenesis. So that when we talk about LDL cholesterol, we know that it plays an important role in the transport of cholesterol to cells. As one of the proatherogenic particles in all proatherogenic particles in the body outside of HDL cholesterol, we know that LDL is the most cholesterol rich. It is the main carrier of cholesterol in the blood, responsible for delivering cholesterol to tissues. Unfortunately, the liver and the intestines have the ability to synthesize cholesterol through the HMG-CoA reductase pathway, particularly when dietary cholesterol absorption is impaired. So we know pathologically this LDL predisposes to atherosclerosis. More than that, this is reflected in genetic studies showing that lifelong exposure to lower LDL cholesterol is actually associated with lower risk of CV events. In Dr. Ferentz's Mendelian randomization studies, where they looked at patients who genetically had lower LDL cholesterol and no exposure to high LDL cholesterol, that lower LDL cholesterol with lower systolic blood pressure lifelong actually translated into a 78% lower odds of coronary artery disease, showing really that it is this exposure to elevated LDL cholesterol that translates into events, particularly cardiovascular events. But what's interesting to note when we look at Dr. Ferentz's studies on genetic randomization is that regardless of the way by which to lower LDL cholesterol, we see very significant reductions in LDL cholesterol translating to reduction in risk. So whether we talk about statin trials, diet, CETP, ezetimibe, fibrates, ileal bypass, or PCSK9 inhibitor trials, we see that when LDL cholesterol is reduced, we have significant translation into reduction of events, regardless of the mechanism by which the LDL cholesterol is reduced. But when we talk particularly about reduction in LDL, and we're talking about more than 50% reduction in LDL, understand that the greatest reduction seen with a single agent for LDL cholesterol are these PCSK9 inhibitors, where we see about a more than 50 to 70% reduction from baseline LDL cholesterol. So when we talk about the sites of action of LDL lowering therapies, we have several therapies that are locally available, but we will concentrate on the one that gives the biggest reduction of LDL cholesterol in PCSK9 inhibitors. So PCSK9 is a protease predominantly secreted by the liver and a regulator of LDL metabolism. This serine proprotein convertase is expressed in hepatocytes, in the kidneys, in the ileum and colon, as well as the central nervous system. PCSK9 regulates hepatic LDL receptors, which bind and internalize LDL particles. PCSK9 binds to LDL receptors, causing a reduction in LDL receptor, eventually resulting in an increase in LDL cholesterol. So how does this particularly work? When we have LDL receptors, these LDL receptors are what LDL cholesterol bind to. Understand that these LDL receptors can actually be recycled in the body so that it doesn't just bind to one LDL cholesterol. PCSK9, when it binds to the LDL receptor complex, sends a message that this LDL receptor should be broken down in the liver. So in essence, in the presence of PCSK9, these LDL receptors are easily broken down and not allowed to go back to the surface to be recycled. so that LDL receptor cannot bind to more LDL particles. So when we talk about PCSK9 inhibitors that do not allow PCSK9 to bind to the LDL receptor LDL complex, then we remove that signal for LDL receptor to be broken down, allowing more LDL receptors to be recycled back to the surface, allowing more LDL cholesterol to bind to this LDL receptor so that the LDL cholesterol can be excreted and used up in the cholesterol pathway. So when we talk about PCSK9, loss of function variant, again, if there is lack of PCSK9, it gives a lifelong impact of 16% lower LDL, translating into 60% lower risk. So that patients with natural loss of function of PCSK9 or PCSK9 inhibitors naturally, they really have significant reduction in risk for events. So when we talk about PCSK9 inhibitors, the locally available PCSK9 inhibitor is evolocumab. It's a fully human monoclonal antibody that inhibits PCSK9 and blocks that PCSK9 LDL receptor interaction, allowing more and more LDL receptors to get recycled back to the surface. More PCSK9, more LDL cholesterol. So when we take a look at evolocumab pharmacokinetics and pharmacodynamics, we look at the dosages that have been tested for evolocumab and its effect over time. When we look at PCSK9 inhibition and LDL reduction with 21 milligrams every 2 weeks, 70 milligrams every 2 weeks, and 140 milligrams every 2 weeks, we see effective and stable LDL cholesterol reduction that is sustained over time. Another dosing that is offered with evolocumab is a 420 milligram once monthly that sustains the reduction in LDL cholesterol the entire month. So this 140 milligrams twice monthly and 420 milligrams once a month provided the most effective reductions in LDL cholesterol with flattening of the U shape until the next dose or the next injection to be given every 2 weeks or every month. But which particular populations of patients is there a benefit for use for PCSK9 inhibitors? So Proficio was a program to reduce LDL and cardiovascular outcomes following administration of PCSK9 in different populations. I do want you to understand that in this particular program, we see a whole range of populations of patients with which PCSK9 inhibitors can be given to, in combination with statin therapy, monotherapy, in those patients who cannot tolerate statin therapy, those with heterozygous familial hypercholesterolemia, those with homozygous familial hypercholesterolemia, and studies particularly looking at long-term safety and efficacy. So this is a summary of the evolocumab clinical trials, again showing us patient populations of various risk groups where patients have different levels of LDL cholesterol, particularly those in the higher range spectrum with a wide range of duration for follow-up in these particular patients with evolocumab, comparing them to other standard lipid-lowering therapies such as ezetimibe, statin therapy, and placebo in those who cannot tolerate statin therapy. What is significant about the LDL cholesterol reduction with evolocumab is that in these patients, whether they were on the every 2 weeks or every month injections, we see very significant lowering of their LDL cholesterol. Again, more than 50% reduction of their baseline LDL cholesterol, even in patients in the background of maximally tolerated statin therapy, those with genetic predisposition for very high LDL cholesterol, and those who are statin intolerant. The reduction in LDL cholesterol is consistent and is clinically equivalent when administered every 2 weeks in various populations of patients. In the Osler study, which was prolonged to over 2 years, evolocumab gave very significant reductions in LDL cholesterol that was sustained over the years of follow-up, showing that in these particular trials, the reduction in LDL cholesterol does not have a significant change as continuous administration is given over time. Regardless of the demographics, whether we're talking about younger or older individuals, gender, those who are Asian, Black, White, Hispanic, non-Hispanic, Caucasians, and even those with endocrine abnormalities, the LDL cholesterol was significant over time. Even in the background of statin therapy, and we're talking about very high intensity statin therapy, the reduction in LDL cholesterol was stable and significant over time. What's even more impressive about PCSK9 inhibitors is not only is there a reduction in LDL cholesterol, but other pro-atherogenic particles such as apolipoprotein B, lipoprotein a, VLDL cholesterol, as well as HDL cholesterol, showing us again that as we look to our guidelines moving away and going beyond LDL cholesterol, looking at other pro-atherogenic particles, we see the impact of PCSK9 inhibition, not just on LDL cholesterol, but other pro-atherogenic particles. In the latest clinical trial that was published in 2019, evolocumab significantly reduced lipoprotein a with coronary benefit from PCSK9 inhibitors in patients whose lipoprotein a was measured. Taking a look at the number needed to treat, those patients with higher lipoprotein a had significantly greater benefit when PCSK9 inhibitors were administered, not just for lowering of LDL cholesterol, but also impacting that lowering of additional pro-atherogenic particle, lipoprotein a. What about safety? So we've talked about significant reductions in LDL cholesterol, more than 50 to 70%, as well as other pro-atherogenic particles. When we take a look at adverse events, the adverse event rates were not significant in administering evolocumab. Having said that, we always tend to look at clinical trials to be able to determine the benefit of reduction. In the Fourier trial, looking at over 2,000 patients who were followed over time, they found that those patients with a baseline LDL that was already low at less than 70 milligrams per deciliter, they had significant 66% mean reduction in LDL cholesterol from a median of 66 to end up with about a 21 milligram per deciliter LDL cholesterol at the end of the study. As you can see, when PCSK9 evolucumab was initially started on these patients, the reduction in LDL cholesterol was sustained over time to the end of the trial. And the safety effects also really reflected the Proficio program, showing that there were no significant adverse effects in those patients who were given evolucumab compared to placebo. So knowing this significant LDL cholesterol reduction conferred by PCSK9 evolucumab, is it reflecting in the guidelines and current recommendations internationally as well as locally? When we take a look at lifetime cholesterol burden, we know that patients with LDL cholesterol of about 120 normally will have a threshold for developing coronary heart disease by about 55 to 60 years old. In patients with heterozygous familial hypercholesterolemia, and these are patients with genetic predisposition to elevated LDL cholesterol more than about 250 on average, we know that the threshold for developing coronary heart disease is much earlier in the second or third decade. In patients with extreme high risk, those who have genetic traits coming from both parents in homozygous familial hypercholesterolemia, where their LDL cholesterol on average can go up to above 500 milligrams per deciliter, these patients have a coronary heart disease threshold in the first decade of life. Counterintuitively, in patients with PCSK9 loss of function, even in heterozygotes, where their LDL cholesterols are at the other end of the spectrum, about 85 milligrams per deciliter, we see that that threshold for coronary heart disease is markedly pushed to the right, where these patients hardly suffer from cardiovascular events because of the protection conferred by that loss of function of PCSK9. So that when we treat patients normally with statin therapy, we can in effect push that threshold for coronary heart disease by a little bit. Similarly, those patients who have heterozygous familial hypercholesterolemia, by early starting them on statin therapy, we can delay progression of that coronary heart disease by a little to the right to prevent events that usually would happen early in the second or third decade of life. So when we talk about PCSK9 inhibition, understand that the benefit of this particular therapy is that by administering PCSK9 inhibitors to patients where their normal coronary threshold would be somewhere in the 50 to 60 age range, if given very early in the population of very high risk individuals, we can really push that threshold for developing coronary heart disease much further down the line. With every year that PCSK9 or that LDL cholesterol is continued to kept low, there is a significant push for reducing that threshold for coronary heart disease. So when we look to the impact on guidelines, knowing this ability to be able to move that threshold for coronary heart disease to the right, we see international as well as local guidelines adapting to this openness to reduce LDL cholesterol further. So as mentioned in the 2019 European guidelines, these trials of LDL lowering indicating relative risk reduction proportional to absolute reduction in LDL, where lower is better, whether with statins, ezetimibe, or PCSK9 inhibitors, it's safe and effective even down to 55 milligrams per deciliter. The intensity should be based on risk, irrespective of the cause, and that baseline LDL cholesterol, which will determine how much reduction in risk can be achieved. So again, looking at the efficacy for LDL cholesterol lowering therapies in clinical trial evidence, we have our PCSK9 trials, which are pushing LDL cholesterol significantly lower compared to earlier cutoffs for LDL cholesterol. So that in the ESC 2019 recommendations, if LDL cholesterol goal is not reached, after adding ezetimibe on top of maximally tolerated statin therapy, PCSK9 inhibitors are recommended, particularly for very high-risk individuals, those who have had events, recurrent events, and those with familial hypercholesterolemia. So that in very high risk without FH, on maximally tolerated statin and ezetimibe not achieving goal, PCSK9 inhibitors are recommended. In patients, very high risk FH, because we know the propensity for allowing significant reduction in their LDL cholesterol, combination of statin, ezetimibe, and PCSK9 inhibitors are recommended. Again, for those patients very high risk with ACS already on maximally tolerated statin dose and ezetimibe, PCSK9 inhibition early after the event should be considered prior to discharging our patients at the point of hospitalization. So very lately, the 2021 Canadian Cardiovascular Society guidelines also came out this March. And they actually identified those patients in secondary prevention with the largest benefit from intensification of statin therapy with the addition of a PCSK9 inhibitor. So very similarly to the 2019 ESC guidelines, they identified very high-risk groups, such as those with recent acute coronary event, those hospitalized index ACS to 52 weeks, and those with clinically evident ASCVD with diabetes or metabolic syndrome, those with vascular disease in more than 2 arterial beds, those with symptomatic peripheral arterial occlusive disease, recurrent MI, MI in the past 2 years, those with previous CABG, those with LDL more than 2.6 millimoles per liter or heterozygous FH, and those with elevated lipoprotein a. With now, again, for the first time, consideration of ezetimibe and PCSK9 inhibitors in these particular patients already on maximally tolerated statin dose. For the first time now, they are offering PCSK9 inhibitor with or without ezetimibe in those patients on maximally tolerated statin dose with very high LDL cholesterol levels, showing that they are now emphasizing the use of PCSK9 in patients with greater indication in those that need bigger reductions of LDL cholesterol in those already on maximally tolerated statin doses. So again, as part of the 2020 clinical practice guidelines for the management of dyslipidemia in the Philippines, we know that practicality is one of the things that have to be considered. So in our recommendations, including PCSK9, we follow the European recommendations where patients should first still be on maximally tolerated statin therapy with addition of ezetimibe to be able to reach LDL cholesterol goals, And in the event that patient still needs additional LDL cholesterol lowering, particularly in very high-risk individuals, PCSK9 inhibition may be added on top of maximally tolerated statin therapy and ezetimibe. PCSK9 inhibitors also came into play in our local guidelines in patients who are statin intolerant or in those who have developed adverse events to statin therapy as an option, knowing that this is now locally available. So if I may borrow Dr. Sabatin's slide set in learnings from treating LDL cholesterol, he beautifully showed a quarter of a century of treating LDL cholesterol, where LDL cholesterol initially looking at higher levels being bad, average not being good, lower LDL cholesterol is better as more and more clinical trials come out, and as PCSK9 trials start to emerge and additional therapies that are in the horizon, we're seeing that even lower LDL is even better, and with Mendelian randomization studies genetically showing that lowest for longest when talking about LDL cholesterol is definitely best. So in summary, lowering LDL cholesterol further impacts cardiovascular reduction. Population and genetic studies suggest that keeping LDL cholesterol at lower levels longer is associated with decreased risk of coronary artery disease. PCSK9 inhibition provides significant LDL cholesterol reduction in various populations of high-risk individuals. I showed you how aggressive additional LDL cholesterol lowering has been shown to translate into reduction of CV outcomes. So we'd like you to consider evolucumab as an ideal treatment option in high-risk individuals for additional lowering of LDL cholesterol, ApoB, and lipoprotein(a), as is shown in emerging trials for those extremely high-risk individuals that you need to get to LDL cholesterol goals lower. Thank you for listening.
Good afternoon, doctors, ladies and gentlemen. Welcome back. I'm Dr. May Balabagna, and I've been tasked to serve as moderator this afternoon for this afternoon session brought to us by Zwillig on LDL-C reduction using PCSK9 inhibitors translation into outcomes. So it is indeed my honor to call back into the virtual stage my mentor, our speaker for this afternoon, Dr. Luella Santos. Thank you so much for a very, very interesting lecture. Hi, ma'am.
Thank you, May. So I've worked with May for a very long time now. And again, she's one of our FH champions. So she has been one of the advocacies for LDL cholesterol lowering, particularly in screening and looking for our patients with familial hypercholesterolemia. So May has not been a stranger to treating dyslipidemia. And I know that she carries this forward in her private practice now as she continues to see her patients.
Yes, of course, ma'am. Okay, but you see, I've been working with ma'am a long time, but you always learn something new from her lectures, right? And so actually, this is the first time I've encountered patients you've mentioned about those with loss of function of the PCSK9, right? How often do we see these kinds of patients actually in clinical practice?
Great question. So again, now that we look to clinical trials, so because our practice is mostly evidence-based, we really are looking to trials so that we can support the therapies that we are giving. And these Mendelian or genetic trials that are coming out are really showing the value of loss of function or gain of function mutations, particularly to be able to support these therapies. So when we take a look at Mendelian randomization studies, again, it is the exposure to LDL cholesterol that time and again proves to be detrimental or the propulsion to progression of atherosclerosis. Unfortunately, locally, we don't have the evidence in terms of number for the prevalence of loss of function mutations or even gain of function mutations in the Philippines.
But so, in the Philippines, ma'am,
yes,
no? Wala
in
pa
the
kasi tayong
Philippines.
gene.
Wala pa talaga. So even of late, they're actually really looking into these studies so that we can see genetically. Again, as a preventive cardiologist, no, lately there are some rumors about looking particularly at the length of time of exposure to risk factors. So eventually they're trying to see if maybe they can include in the computation for ASCVD risk. Diba, we have now our calculators for 10-year ASCVD risk that the ACCHA has come up with. The Europeans have a score, but they're trying to see if maybe we can insinuate the length of time of exposure to a risk factor in that ASCVD calculator, where eventually we will be asked to compute for how many years we kept our patients' LDL cholesterol below 55 in high-risk individuals, below 70, below 100, or below 115, depending on the risk classification. Similarly, with blood pressure, how long we kept our patients at low blood pressure so that we can compute over time really this exposure to these risk factors. So genetically, we're still a little lacking as a country, hoping that eventually, as more and more studies will come out, we will also be able to look at loss or gain of function mutations in the Philippines so that this can be an added way to be able to screen for our patients with familial hypercholesterolemia. So in essence, prevalence-wise, wala pa tayo dito sa Philippines. So I'm hoping, May, you can be part.
But in your previous like in training in the US, have you encountered such patients with the?
Yes, absolutely. So again, in the US, we were able to detect these particular patients, knowing again that whether you're talking about gain or loss of function mutations, primarily the treatment is still going to center on statin therapy first, additional non-statin therapy on top, and then going into PCSK9 inhibitors, knowing that this is a third line agent when we talk about how to treat these particular patients. Having said that, as more and more clinical trials emerge where some patients do come out with statin intolerance, it is now insinuating its way, as I mentioned in the local guidelines. We're recommending the use of PCSK9 inhibitors in those that cannot tolerate statin therapy, so that it is not always left as the third line agent for how to treat dyslipidemia. So wala pa. But the prevalence rate is not so high with gain or loss of function mutations. So it's still LDL receptor dysfunction that is genetically the most common cause of familial hypercholesterolemia.
Yes, even with our local studies, right? Or
yes, absolutely.
So because we have to emphasize that this is on top of maximally tolerated statin therapy. So how has your experience been? Because this is a new drug and not a lot of people have been able to use it, no? So how's the experience been for you with the use of evolocumab? And in terms of the lowest LDL, because we're trying to push here the lower the better LDL cholesterol levels, right? So what's the lowest so far LDL cholesterol level that some of your patients have achieved using evolocumab? So I've been very fortunate in that I've had referrals for PCSK9 inhibitors. So I'm very comfortable with using it in patients with strong indication, especially those patients who have had several events, particularly 2 events within 2 years, where the LDL cholesterol goal is below now 40 milligrams per deciliter. I have given PCSK9 inhibitors and am maintaining about 32 patients now with PCSK9 inhibitors. The lowest I've ever gone down to, and again, I presented this at the Philippine Heart Association annual convention 2 years ago, was my experience with a doctor actually on PCSK9 inhibitors who had a stroke at an LDL cholesterol of 50 milligrams per deciliter. So because of that, we felt that this particular patient who had had a stent within 2 years of his stroke, who wanted to remain functional as a doctor, we felt that more aggressive ways to manage his LDL was ideal. So he's actually walking around now with an LDL cholesterol of 9 milligrams per deciliter. Again, the comfort level was really in the fact that this was a healthcare worker. So he knew what we were watching out for. He is very closely monitored. So he really does check his lipid profile prior to his next injection. And we've looked at some maybe adverse events that we need to find in patients with such low LDL cholesterol levels. So having said that, what are the things that we look for in patients where we push these LDL cholesterol levels down? So as with the local guidelines where we talk about statin adverse events, we know that with too low LDL cholesterol, there are some issues that some patients have come out with. So one of which is neurocognitive dysfunction. We do want you to understand that in the Fourier trial using evolucumab, there was a subset of patients with very low LDL cholesterol where they checked for neurocognitive dysfunction called the Ebbinghaus study. And in it, they looked at patients with such low LDL cholesterol, and they actually found that there was no significant impact on patients' neurocognitive function with LDL cholesterol that was very low, less than 20 milligrams per deciliter. So there is no correlation between the absolute reduction of LDL cholesterol or the LDL cholesterol achieved with neurocognitive dysfunction. More than that, when we took a look particularly at those patients who had, for example, Alzheimer's disease or patients who had neurocognitive dysfunction, we actually found that patients who were on statin therapy with significant LDL cholesterol lowering were actually protected in a way from dementia or other neurocognitive dysfunction. So we don't particularly fear low LDL cholesterol in these patients using PCSK9 inhibitors with a 70% reduction of their baseline LDL cholesterol in terms of their neurocognitive dysfunction. So again, very comfortable with its use. I know that the limitation for PCSK9 inhibitors really is the fact that it's an injectable. So mostly what I do to get my patients familiar with it, lalo na po ngayon with the onset of Zoom calls and teleconsults, I actually send them a video of how to inject the PCSK9 evolucumab. And then during our first teleconsult for their first injection, they show me how it's done so that we're doing it together so that they're confident moving forward every 2 weeks to be able to inject themselves with PCSK9 inhibitors. So we're hoping that we can pull together the data for these 32 patients we have who have been started on evolucumab because this is the only PCSK9 inhibitor that is locally available to date. Another limitation again for PCSK9 inhibitors is of course cost as an issue. So again, understanding that these particular patients, this high risk population that we're looking at, these are patients who have had recurrent strokes, recurrent bypass, angioplasties, and events. And so at this particular point, financially weighing the risk and benefit of being on this particular agent, these are patients who are so high risk that now they are looking at what particular way they can move forward with their atherosclerosis, in that they want to take control. Instead of waiting to see when that next event is going to happen, they're waiting to see if there's something else they can do to prevent that progression to atherosclerosis, which really is waiting to happen with these high risk individuals.
Yeah, I was gonna ask that how you were able to like explain to patients. So it's actually patient administer the evolocumab themselves.
Absolutely. It's a little difficult. Again, now, no, with the advent of lockdown and not being able to reach out to patients, I really don't think that this should be a hindrance to giving them their maximum therapy. We already know that with very high risk individuals, if they don't reach their LDL cholesterol goal below 55 milligrams per deciliter, these patients are going to have an event. And now more complicated when patients come in with an NSTEMI or a stroke because of their fear for getting COVID in the emergency room. So I always try to explain to them that this is for secondary prevention. Again, these are high-risk individuals. And because of that compulsion for them to be able to retard or slow down the progression of atherosclerosis, this is something that has to be explained to them. Again, not an easy drug to administer. It's not something that you take by mouth. So walking patients through it step by step with what your goal is, and that's an LDL that's below 55 milligrams per deciliter. What the side effects are that we look out for. So usually after the first injection, I ask patients to get a CBC just to make sure. In the Fourier trial and in the Odyssey trial, they do take a look to see if the platelet count starts to go down. So in particular with these patients, even my patient with LDL cholesterol below 10 milligrams per deciliter, there has been no hematologic consequence so far. Again, small n, 32 of these patients, but we haven't had any problems since. Before their second injection, I usually ask them to take their lipid profile again. So this is usually the time when we start to see the LDL cholesterol go up. So by virtue of that, I want to see how much reduction they have gotten. And again, the efficacy of this particular agent is that I get a 60 to 70% reduction of LDL cholesterol from their baseline LDL. So it has never disappointed in terms of being able to reduce LDL cholesterol. So these are just things that we watch out for. We work hand in hand so that these patients are comfortable with being on PCSK9 inhibitors.
So most of your patients right now are taking which preparation po, ma'am? The one
Great
for
question.
Yeah. Okay.
So
Which
most
is
of my
available?
patients, actually all of them, are taking the 140 injection. What's even great about it now is the company has actually been able to deliver straight to the patient. So again, the handling has been an issue where it has to be refrigerated. Prior to administering it, we bring it out for 30 minutes so that it's room temperature before it is injected. My preference for injection site is in the thigh. So I usually ask them to sit down and then administer with their pen on the thigh. Ease of injection can be done anywhere. If they're in the office or at home, they excuse themselves, sit on the chair, and then inject. So again, comfort, ease of use for these particular patients. So it's the 140 twice a week.
140 twice. Okay. There's a question here though, not quite and with but the question is, what can you say about the use of oxidized LDL?
Oh, great question.
Yeah. There's a question here. Yeah.
Again, is this as a measure for atherosclerosis? So again,
when you take a look at our guidelines and even international guidelines, we're trying to go beyond LDL cholesterol. And that's the reason why in our local guidelines in 2020, we included apolipoprotein B and non-HDL as additional measures going beyond LDL cholesterol. So we love the fact that people really are looking beyond LDL cholesterol, because we know that even though as a number, LDL cholesterol is translating into reduction of events the more we lower it. At a particular point, going by guidelines, having reached an LDL cholesterol of below 55, we want to see if there are other pro-atherogenic particles, as we both know, May, that aren't just reflective of LDL cholesterol. So oxidized LDL is great in the fact that we know that to be able to start that pathway to development of atherosclerotic plaques, where foam cells can engulf these oxidized LDL so that it can create atherosclerosis in the subendothelial lining, it needs that particular trigger. So we're trying to see if there are additional ways beyond LDL cholesterol. So unfortunately, we don't particularly know yet how to measure oxidized LDL cholesterol alone. Is it a blood test that allows us to be able to see that, or is there imaging? So there are benchworks now looking to see if we can go beyond LDL cholesterol. In the future, hoping that we can see which particular LDL particles are more predisposed to development of engulfment of foam cells so that they can go into that process of atherosclerosis. But that's a great question. We do want to go beyond LDL cholesterol, but thus far, there's no recommendation yet for oxidized LDL cholesterol as a routine blood test in the screening for patients with dyslipidemia.
So for those who would want for their patients to avail of the drug, how accessible is it actually for our physicians?
So again, because of lockdown where we've had difficulties,
Yeah.
so I've had physicians
Go to Mercury and buy.
Yes. So I've had physicians actually texting me, and what I usually do is I give them the contact number of the company, and then they're the ones who actually get in touch with each other so that the product is brought straight to the home of the patient. So this is how the networking has been so far, and it's worked again because of the limitations of having to go outside and buy. So unfortunately, this is not a stock product. You can, however, call to find out if there are available ones, but the ease of use is really just that when you call directly the company, they will deliver to homes. So we've actually had patients outside Manila who have been able to get PCSK9 inhibitors.
We do get a lot of calls and referrals from our friends from the provinces. No?
I think what's important really is knowing that there's an additional line. No?
Yes.
So I know that financially cost really has become an issue, mainly because patients here in the Philippines are self-pay. So to be able to sustain this particular injection every 2 weeks for a very long time is significantly pricey. Having said that, though, again, in the background of patients who have had angioplasties, who have been in the ICU for stroke, understand that this drug is for a very select high-risk population, where really the benefit of LDL cholesterol is significant in that it can prevent another event from happening.
Okay. So no more questions in our chat box. All right. So this has been a very wonderful afternoon. We've learned a lot again. And we would like to take this opportunity for all our listeners. If you are of like mind, if of like mind like us, and you would want to join us in our advocacy, no? For particularly for familial hypercholesterolemia, you are very much welcome to join us. And you can.
So we actually have a workshop.
Yes.
June 11 is coming June 11. So we will have some pioneers with familial hypercholesterolemia in the Philippines, particularly Dr. Rodi C. and Dr. Yubs Punsalan, who have come up with the only clinical trial looking at familial hypercholesterolemia, lecturing them so that we can get their insights on familial hypercholesterolemia. So on June 11, Zwilig Amgen has actually partnered with the Philippine Lipid Atherosclerosis Society to continue this advocacy for FH champions, of which May and I are a part of, so that we can enjoin you to help us out. And if you are interested to be an FH champion in your area, so that we can help you educate others too about familial hypercholesterolemia.
Right. Thank you so much, ma'am. Thank you.
Okay.
Zwilig, thank you so much for this opportunity. Please stay. There are still sessions up ahead. No? Thank you so much. Keep safe, everyone. Bye, ma'am.
Keep safe.
Thank you, Dr. Lourdes Ella Santos and Chairman Dr. Maria Margarita Balabagno. We now move on to the third part of the Cardio Fellows debate. Our debate topics are: first, immediate versus delayed cardioversion for new onset atrial fibrillation, immediate within 48 hours or delayed beyond 48 hours to 30 days. Second, to bridge or not to bridge, heparin bridging from warfarin in patients with mechanical heart valves undergoing non-cardiac surgical procedure. Third, complete revascularization after STEMI, single complete revascularization procedure versus within 72 hours prior to discharge or after discharge, due perfusion imaging, ischemia-driven PCI. Fourth, RVOT stenting versus modified BTS to TOF repair. And last, stenting versus surgery and coarctation of the aorta.
Good evening, everyone. Almost evening. Right now, we're at the last leg of our debate for Philippine Heart Association 2021. 5 more topics to go, 10 more contenders to go, and we're going to reach the finale of the debate of 2021. The 5 topics we're going to discuss this afternoon will be the immediate versus delayed cardioversion for new onset atrial fibrillation, to bridge or not to bridge, heparin in patients with mechanical heart valves undergoing non-cardiac surgical procedure. What is the mode that is best for revascularization after STEMI? What are the type of therapy that is best for TOF repair and coarctation of the aorta? The 10 contenders will try to convince you. The judges will try to see if you are convinced. Let the battle begin now.
Good afternoon, everyone. The expression time is muscle has long been used in the field of cardiology, specifically when pertaining to acute coronary syndrome. We dare say that it is likewise stands to reason that in the discipline of electrophysiology, and particularly in relation to acute atrial fibrillation, time is also muscle. In fact, it is more than just that. Time is muscle, time is current, and time is ultimately hard. By this, we pertain to the contractile, electrical, and structural changes the heart suffers as it remains in atrial fibrillation without early cardioversion. This house believes that immediate as opposed to delayed cardioversion is better and safer for our patients in new onset atrial fibrillation. The longer a patient is in atrial fibrillation, the higher the risk for stroke is. Duration of AF is predictive of stroke risk. In 2013, a pooled analysis involving over 10,000 patients with implanted electronic devices to enhance detection of AF found that for every additional hour increase in the daily maximum AF burden, the relative risk for stroke increases by 3%. A 6-hour daily AF burden implies increased risk of stroke by 17%, and a 12-hour Good afternoon, everyone. The expression time is muscle has long been used in the field of cardiology, specifically when pertaining to acute coronary syndrome. We dare say that it is likewise stands to reason that in the discipline of electrophysiology, and particularly in relation to acute atrial fibrillation, time is also muscle. In fact, it is more than just that. Time is muscle, time is current, and time is ultimately hard. By this, we pertain to the contractile, electrical, and structural changes the heart suffers as it remains in atrial fibrillation without early cardioversion. This house believes that immediate as opposed to delayed cardioversion is better and safer for our patients in new onset atrial fibrillation. The longer a patient is in atrial fibrillation, the higher the risk for stroke is. Duration of AF is predictive of stroke risk. In 2013, a pooled analysis involving over 10,000 patients with implanted electronic devices to enhance detection of AF found that for every additional hour increase in the daily maximum AF burden, the relative risk for stroke increases by 3%. A 6-hour daily AF burden implies increased risk of stroke by 17%, and a 12-hour burden a 37% increase in risk. Earlier cardioversion obviates the unnecessary additional per hour of AF burden increase in cerebrovascular events. But what of the adverse events associated with earlier versus later cardioversion? Several studies dating back to the 1969 have made it known that cardioversion of patients with AF of more than 48 hours had a 5 to 7% risk of thromboembolism without preceding anticoagulation. A study published in 1997 showed that the incidence of cardioversion-related clinical thromboembolism in those with AF lasting less than 48 hours was at only 0.8%. Several observational studies since then pegged the risk of stroke following cardioversion in AF of less than 48 hours duration at 0 to 0.9%. The more recent FINCIVI study involving over 3,000 patients with AF of less than 48 hours duration confirms the safety of cardioversion in this subset of patients. Whether by pharmacological or electrical cardioversion, the risk of stroke was negligible at 0.7 to 0.8%. This is much less than the 5 to 7% risk for stroke of our opponent stands to cardiovert at 48 hours to 38 days. The risk of early cardioversion of less than 48 hours are negligible. Those of doing so at beyond 48 hours are unacceptable. Even with oral anticoagulation, the cornerstone of treatment of patients with AF, the risk of residual stroke and systemic embolism remains. It seems that the presence of atrial fibrillation itself is one of the modifiable factors associated with death and cardiovascular morbidity in patients with AF. Once AF develops, it induces electrical, contractile, and structural remodeling on top of other mechanisms to increase susceptibility for recurrent and persistent AF. Hence the saying, AF begets AF. During the first 24 hours of atrial fibrillation, electrical remodeling already occurred. There is marked reduction in the L-type calcium current, causing dramatic shortening and loss of rate adaptation of the refractory period. There is a marked reduction in the refractory period taking place during first days of AF, and by the second to third day, it has reached a new steady state. Clinical observation in humans showed that this abnormality in the rate adaptation of the atrial refractory period has a propensity to atrial fibrillation. Studies in animals showed that with only after 12 hours of atrial fibrillation, changes in the atrial pressure diameter loop can already be seen, and by this time, it is reduced by approximately 50%. After 48 hours of AF, the atrial pressure diameter loop is almost completely closed, implying that the atrial contraction was completely, nearly abolished by this time. After restoration of sinus rhythm, reverse electrical remodeling occurs, and atrial refractoriness becomes normal again within only a few days of sinus rhythm. The atrial contractile dysfunction, on the other hand, correlated with the duration of AF. After 2 weeks of AF, recovery of atrial contractile function was complete within 24 hours of sinus rhythm, whereas it took more than a month to recover for AF lasting more than 6 weeks. Depressed and slow recovery after restoration of sinus rhythm may play a role in the occurrence of thromboembolic events, even if atrial thrombi was not present during the duration of the time of cardioversion. In summary, with shorter duration of atrial fibrillation, the remodeling processes associated with AF are presumably less advanced, providing greater opportunities for effective and successful cardioversion. With earlier restoration of sinus rhythm in the background of less advanced remodeling may become less progressive and may even recover within a shorter period of time compared to those with longer duration of AF. In theory, this may also lower the risk of complications associated with AF, including risk of stroke and heart failure. Hence, we believe that immediate as opposed to delayed cardioversion is better and safer for our patients with new onset atrial fibrillation in terms of successful restoration and maintenance of sinus rhythm and reduction of risk of complications such as stroke and heart failure. These are our references. Thank you.
Delayed cardioversion in new onset atrial fibrillation. We have nothing to disclose. Atrial fibrillation is the most common sustained arrhythmia encountered in primary care practice and represents a significant burden on healthcare system because of complications such as stroke with a higher expected hospitalization rate from the emergency department. AF shows up in a variety of forms: new onset or first diagnosed, paroxysmal, persistent, and permanent. We must first define what new onset atrial fibrillation is. It is a new or first detectable episode of a chaotic and irregular atrial arrhythmia. Its prevalence increases progressively with age. Which is better, early or delayed cardioversion for new onset AF? Primum non nocere, spontaneous conversion. Why cardiovert if there is spontaneous conversion to sinus rhythm within 24 hours? The likelihood of early spontaneous conversion of acute AF to sinus rhythm is reported to be as high as 70% within the first 24 hours based on systematic review as observed in this figure. Adverse events and embolic events. Overall, adverse events were higher in the cardioversion group compared to the rate control or placebo groups. Only 6 studies reported on thromboembolic or bleeding complications which rarely occur. So we now know that spontaneous conversion rate was 70% within 24 hours, and arrhythmia duration is less than 48 hours, was significantly more likely to convert. Now we proceed to determine the cost of effectiveness of waiting for spontaneous conversion versus cardioversion. Per patient hospital charges were significantly lower for patients with spontaneous conversion compared with non-converters. Hospital charges were particularly high for patients who underwent the recurrent cardioversion. Observation of a patient with recent onset AF in a dedicated unit within the emergency department reduces the median length of stay from 10 hours versus 25 hours for patients who received routine in-hospital care including electrical or pharmacological cardioversion. Due to the pandemic, there is shortage in the hospital bed capacity and medical staff. If we are able to reduce their length of stay in the emergency department, then we will be able to accommodate others that really warrants admission. Our stand, delayed cardioversion. The evidence is mainly backed up by RACE 7 Aquas trial. The goal of the trial was to evaluate delayed compared with early cardioversion among patients with recent onset atrial fibrillation. Patients with new onset atrial fibrillation were randomized to delayed cardioversion versus early cardioversion. The total number of enrollees is 437. Duration of follow-up is 4 weeks. Mean patient age is 65 years. And the inclusion criteria are the following: onset of atrial fibrillation of less than 36 hours, hemodynamically stable, symptomatic, recent in onset, without signs of myocardial ischemia, and no persistent AF. Patients randomized to delayed cardioversion received rate controlling agents and underwent cardioversion in 48 hours if needed. Transesophageal echocardiography was not performed in any patient, and long-term anticoagulation was recommended, according to the patient's estimated stroke risk. Primary efficacy endpoint is presence of normal sinus rhythm at 4 weeks, which occurred in 91% of the late cardioversion group versus 94% of the early cardioversion group. Ischemic stroke or transient ischemic attack happened in 1 patient in the delayed group versus 1 patient in the early group. Cardiovascular complications happened in 10 patients in the delayed group and 8 patients in the early group. In conclusion, among patients with recent onset atrial fibrillation, delayed cardioversion was non-inferior to early cardioversion at maintaining atrial fibrillation at 4 weeks. Spontaneous cardioversion occurred in the majority of patients randomized to a delayed strategy before electrical or pharmacological cardioversion was required. This is the summary of the article, which showed that delayed cardioversion was non-inferior to early cardioversion at the presence of normal sinus rhythm at 4 weeks. Summary: based on our presented evidence, new onset atrial fibrillation, a wait and see approach with administration of rate control medications and delayed cardioversion may avert hospitalization and hospital treatment. Wait and see approach is more cost-effective than early cardioversion. With that, we thank you.
They say patience is a virtue, time is gold. It's now up to you to decide, are you convinced when regards to new onset atrial fibrillation? May I now call on Dr. Harold Sungam that maybe you want to query our group who are pro immediate cardioversion.
Again, good afternoon. For the proponents, this was mentioned by the opponents. Administration of rate control medication, just control the rate, and delay the cardioversion is statistically significant to prevent the thromboembolic events.
Regarding this rate control strategy, while we delay the cardioversion in patients with acute atrial fibrillation, there are some limitations in the studies which argued for rate control and delayed cardioversion. And among that, most of these patients were already the included patients were already in the end stage, not end stage, sorry. Most of these patients were already with long-term atrial fibrillation, and the structural changes within the heart are already present. Also, in these studies, once sinus rhythm was already restored, they withheld, some of the studies already withheld anticoagulation in sinus rhythm. When we go back to our argument with regards to early cardioversion, once you restore sinus rhythm, the changes do not resolve at once. There are still electrical and structural and contractile remodeling that happen, which means that upon restoration of sinus rhythm, the anticoagulation that we give for this patient to prevent thromboembolism should be continued. But again, in the studies in rate versus rhythm control, some of them discontinued anticoagulation already when sinus rhythm was restored. Hence, it could be a confounder why even with the restoration of sinus rhythm, thromboembolic events are still present on this patient. As
Thank
opposed
you
to
very
patient
much. Thank you very much, Doctora. Your time is up. So we have already 2 minutes for you to answer. I would encourage all our debaters to take note of your time and really treasure it. Thank you very much, Doctora. Now let's go now to our opposition for who actually is actually waiting is worth the wait. So Dr. Mambulao, you have anything to say to our team who said delayed cardioversion is it?
Good afternoon, everyone. I have two questions to the opposition. The first question is, if the patient develops hypotension, would you still prefer early or delayed versus early cardioversion? And the second question, in either of the two modality, which do you think would result into a lower recurrence of atrial fibrillation?
Opposition, you might want to answer already. Debaters? For the delayed cardioversion, anyone
For
who
patients who are hemodynamically unstable, it is already an indication to do cardioversion. Hence, if the patient develop hypotension, it is guaranteed or warranted to urgent cardioversion. For the second question is the rate of recurrence.
For the second question,
So a study done by Niti et al. Show that conversion or spontaneous cardioversion of AF or allowing a delayed cardioversion has a 9.3% risk chance of returning to sinus rhythm with no complications noted in the study done. However, if the patient develop any is hemodynamically unstable during that time, so that is the time where if we manage the patient based on their hemodynamic status, and we can opt to give medications for rate control and anticoagulation.
Okay, thank you very much for that answer. Again, time is up. Thank you for those answers, debaters, and I'd like to say congratulations for a very comprehensive presentation. And now we're ready. We're ready for the next topic. A virtual clap for our debaters. Thank you very much. Let's go ahead then and talk about bridges. Bridges are not burned, but in this case, we have to find out, are we going to burn bridges? Let's talk about heparin bridging in patients with mechanical heart valves. Let us now have the first presenter.
Good day. Hemostasis is a finely balanced process of natural clotting to prevent excessive bleeding. Thrombosis, however, is abnormal. It occurs when there is an imbalance in endogenous anticoagulation and hemostasis through a complex pathophysiologic mechanism causing obstruction of blood flow. The Virchow's triad of stasis describes the pathophysiology behind thrombus formation in certain thrombogenic conditions, such as in the case of foreign bodies, and a mechanical heart valve is a very foreign body. To break the thrombogenic cycle, the solution is to do anticoagulation. But this is a double-edged sword, so there must be a balance between bleeding risk and thrombosis. However, there will come a time where anticoagulation has to be interrupted, such as in patients who will undergo invasive surgeries. Major surgical procedures require an INR of less than 1.5. In patients with a mechanical prosthesis, oral anticoagulant should be stopped before surgery. This is where bridging anticoagulation comes into play. Here lies our controversy. Bridging anticoagulation consists of the substitution of a long-acting anticoagulant such as warfarin for a short-acting anticoagulant like heparin because we want to limit the time of subtherapeutic anticoagulation levels and therefore minimize thromboembolic risk. Our data reports a 10 to 12% incidence rate of mechanical prosthetic valve thrombosis found in developing countries that carries with it a 20% mortality and 40% major disability rate. So why should we bridge? In the current ESC guidelines, bridging with heparin until therapeutic INR is reached is a Class 1 recommendation. In the 2020 AHA guidelines, bridging therapy with heparin has evolved empirically to reduce thromboembolic events in higher risk patients, such as those with a mechanical mitral valve replacement or aortic valve replacement and additional risk factors for thromboembolism. The 9th edition guidelines from the ACCP provided a stratification for patients with mechanical prosthetic valves and atrial fibrillation according to their thromboembolic risks. As with the ACC, mitral prosthetic valves and aortic prosthetic valves with additional risk factors are considered at moderate to high risk for thromboembolic events. Thus, bridging with either unfractionated or low molecular weight heparin in these populations is still recommended. The PROSPECT trial reported a major bleeding rate of only 0.5%, and bridging was considered safe. In fact, one study has pointed out that the bleeding was related to the kind of surgery and not the bridging itself. The BRAVE registry similarly reported a low incidence of major bleeding and reported the efficacy and safety of bridging in patients with mechanical heart valves. In another study by Hellstrom and Labaf, a similar bridging regimen was used regardless of the risk category of the procedure and still showed a low rate of major bleeding at 1.3% and no thromboembolic events. Just last year, a meta-analysis by Tao and colleagues has shown that bridging with low molecular weight heparin is effective in reducing the risk of thromboembolism and does not increase the risk of major bleeding. So why shouldn't we bridge? The change from higher levels of recommendation was largely based on the landmark BRIDGE trial, which observed an increase in bleeding rates with bridging with no significant difference in the thromboembolic events in those who were not bridged. However, the population represented mostly those with a CHAD score of 2, which belonged to the low-risk category. Furthermore, the trial involved patients solely with atrial fibrillation and stressed out the caveat that the study should not be applied to patients with mechanical valves. We recall that the REALIGN trial was terminated prematurely due to an excess risk of thromboembolism in patients with mechanical heart valves on the bigatron, despite its efficacy in patients with atrial fibrillation, and pointed out the difference in thrombogenic risks of prosthetic valves versus atrial fibrillation. The PERIOP-2 is an ongoing study which attempts to determine the safety and effectiveness of bridging with low molecular weight heparin versus placebo. But notice that the exclusion criteria involves those that are high risk for thrombosis. Does this mean that they still recognize the need for bridging in this particular population? I submit to you the evidence in favor of bridging and the evidence against bridging, and you can see the disparity. If we bridge, what's the worst that can happen? Bleeding? We can replace that with blood cells. If we don't bridge, the patient can have a stroke. We cannot replace brain tissue. Or worse, the patient can have an acute valve thrombosis. We cannot replace life. Therefore, we must bridge.
The practice of modern medicine entails the application of evidence-based medicine in clinical dilemma situations many physicians encounter. In such cases, a decision has to be made whether an intervention with its attendant risks can be safely administered and will ultimately benefit the patient. Good day to everyone, and I will be presenting the clash of the opposition side on the issue of perioperative bridging anticoagulation. Oral anticoagulation therapy is commonly used for long-term prevention of thromboembolism in patients with mechanical heart valves. Every year, an estimated 13% of patients with mechanical heart valves require non-cardiac surgery. The principal concern among these patients is whether to interrupt oral anticoagulation in the perioperative period, and if so, determine the need for bridging with parenteral heparin, taking into consideration the increased bleeding associated with such strategy. Common practice has come to terms with accepting the increased risk of bleeding associated with bridge therapy as a trade off for the increased protection provided against thromboembolic events. However, is the evidence really enough? In a meta analysis of 34 studies that assessed perioperative thromboembolic and bleeding events in more than 12,000 patients undergoing elective surgical procedures, heparin bridging conferred a more than five-fold increased risk for overall bleeding and a more than threefold increased risk for major bleeding, whereas the risk for thromboembolic events was not significantly different in bridged and not bridged patients. In a pooled data taken from the Bridge and Rely trials and studies by Clark et al., Cavalcanti et al., Steinberg et al., and Wysikowski et al., looking into the bleeding and thromboembolic risk of patients on oral anticoagulant therapy in the perioperative period, we can see a net effect that is unbalanced towards bleeding, with a very low and insignificant perioperative risk of thromboembolic events. Indeed, the risk of perioperative thromboembolism is approximately only 1%, such that even without bridging, there is already a threefold increased risk of bleeding for patients with mechanical heart valves. The initiation of bridging therapy further confers a more than tenfold excess risk of bleeding. On average, recent evidence showed a peri-procedural bleeding to thrombosis ratio of 13:1 with bridging and 5:1 without bridging, bringing into question the net benefit of bridging relative to an already higher predisposition to bleeding. The increased bleeding rates associated with bridging anticoagulation translates into increased morbidity and mortality that overwhelms the benefits derived from anticoagulation. From these studies, we can surmise that perhaps the practice of accepting the bleeding risk as a trade off for the thromboembolic protection is a careless overestimation of the perceived thromboembolic risk and a gross underestimation of the high bleeding risk that we subject our patient into. For most patients, bridging anticoagulation produces excessive bleeding, longer lengths of hospital stay, and other significant morbidities while providing no clear prevention of thromboembolism whatsoever, the risk of which is inherently low to begin with. However, despite the evidences presented, bridging anticoagulation remains a common and highly variable practice among clinicians. A study by Clark et al. Revealed that the threshold for bridging in current practice is too low, with moderate and even low risk patients being bridged, leading to a paradoxical increase in preventable adverse bleeding events. The European Society of Cardiology and European Association of Cardiothoracic Surgeons even routinely recommended bridging during interruption of anticoagulation therapy among patients with mechanical heart valves. However, the evidence for this recommendation is based on a non-randomized prospective cohort which showed benefit of bridging among patients considered to have a high thromboembolic risk. Majority of subjects included in this registry are patients considered to have high risk, which could have influenced the outcome, thus only giving a weak level of recommendation based solely on expert opinion and a small non-randomized study. In the American College of Cardiology and American Heart Association guidelines, the recommendation for bridging is more individualized, favoring those with high risk features for thromboembolism. Similarly, the evidence for this recommendation is weak, based only on a limited number of cohort studies with a poor or no comparator groups at all. The bulk of evidence used in the formulation of such recommendations are generally weak and inconsistent, such that the net clinical benefit of bridging patients at a high risk for thromboembolism still largely remains unknown and is not yet supported by clinical trial evidence. Consolidating all the evidence I have presented so far, the overall thromboembolic risk for patients in the perioperative period of warfarin interruption could at best be an overestimation of the true event risk, even among patients considered in the high risk category, making the routine application of bridging recommendations in all patients with mechanical heart valves highly detrimental in light of the excessive bleeding risk. The question now remains, do we bridge or do we not bridge? The practice of evidence based medicine prompts clinicians to integrate the best research evidence with clinical expertise to deliver the right care at the right time to the right patient. In the practice of our profession, we should always exercise sound judgment guided by the principles of giving the best for our patients and doing the least harm. To answer the clinical dilemma, the opposition firmly believes that the bridging anticoagulation in perioperative warfarin interruption lacks firm and solid supporting evidence to warrant routine recommendation into clinical practice. We believe that the thromboembolic risk among such patients are inherently low to derive a net clinical benefit and that the excessive bleeding risk is too prohibitive and unacceptable that it cannot simply justify whatever benefit, even if there is, that we derive from bridging anticoagulation. Thank you.
To letter B or not to be. Dr. Alati Uy, might you have any question for the ones who wants to bridge?
Yes, good afternoon. My question is ACC recommendation on heparin bridging is 2A only. So are you going to bridge all your patients with mechanical heart valves?
Good afternoon, doctor. So we will be following the recommendations, doc, wherein those who are recommended for bridging, doc, are those who are considered at moderate to high risk for thromboembolic events. So these patients include all patients who underwent mitral valve replacement, as well as those aortic valve replacement, plus an additional thromboembolic risk. So with regards to the level of evidence, doc, this is due to the paucity of randomized control trials, doc. So far we only have observational studies, doc, which is why the level of evidence and in all the recommendations, doc, are only level C, which is based on expert opinion and the general consensus, doc.
Any more questions, Dr. Raui?
That's all, doc.
Okay, thank you very much. And I like your outfit. Thank you very much. Makes me insecure. So thank you very much, debater. Now let's go ahead. Let's talk about the one who do not want to bridge, the one who's hesitant. Dr. Sunga, you think you want to ask them?
Yeah, good afternoon. Your proponents mentioned that heparin bridging is statistically significant in decreasing the thromboembolic events and have a 1.3% the risk of bleeding and no thromboembolic events among mechanical valve surgery. Are you still not recommending heparin bridging?
Sorry, can you repeat the question, sir?
Yeah, they mentioned that heparin bridging is statistically significant in increasing the thromboembolic events and have a 1.3% the risk of bleeding and no thromboembolic events among mechanical valve surgery. So can you comment on this, or you're still not recommending heparin bridging?
I think, sir, we have, at the present time, there is still no randomized control trial that tested the benefit of heparin bridging among patients specifically with mechanical heart valves. For atrial fibrillation, there was the bridge trial, but since we're dealing with the mechanical heart valves, no RCTs have yet been published. And in these studies they mentioned, I think these are just prospective cohort studies or small observational studies. And these studies are prone to biases because the patients included in these studies are those patients already with an increased risk of bleeding, of thromboembolism. These are patients who have mitral valves or aortic valve replacements who have additional risk factors. So perhaps there is a benefit for bridging among these patients because inherently they are already at an increased risk. But how about for those patients who are not at an increased risk for thromboembolism, but at an increased risk of bleeding? I think bridging in these groups of patients would be dangerous.
Okay, thank you very much. We have about 10 seconds left. Are we satisfied with the query already, Dr. Sunga?
Yes,
thank you. Thank you very much. Actually, that was a very interesting discussion. And right now, let's go ahead and to the thank you very much, debaters, for a very comprehensive discussion of bridges. And we will find out whether we will win among you, the bridge or not to bridge. Now let's go ahead and talk about the love triangle. The next topic we have at hand actually is a tripartite. So it's a first in the series tonight. We're going to talk about revascularization. 3 choices, 3 people involved, 3 people to convince, so let the battle continue.
Good day. Among STEMI patients with multivessel CAD who underwent culprit lesion PCI, which timing of complete revascularization is the most beneficial? We believe that single-stage complete revascularization is the best timing. ST elevation MI involves plaque disruption causing extensive thrombus in the infarculated artery. 50% have multivessel disease and risk for multiple plaque ruptures, hence the urgent need for revascularization. Complete revascularization for multivessel disease has been upgraded from Class 3 to 2B in the AHA guidelines. Current ESC guidelines recommend that complete revascularization should be considered in patients with cardiogenic shock. However, the optimal timing remains debatable, leading to our clinical question. Among STEMI patients with multivessel CAD who underwent culprit lesion PCI, how effective is single-stage complete revascularization versus staged PCI in reducing the following major clinical outcomes and safety endpoints? Based on the research question, it is not a question of which procedure is the best. The question is the best timing. We have searched and appraised RCTs, meta-analysis, and guidelines to provide evidence that single-stage complete revascularization is the best option. Outline of the discussion will be on effectiveness, safety, prognosis, and applicability issues. First, I'll be presenting the effectiveness of single-stage versus staged PCI within 72 hours. 3 trials reported on staged PCI within 72 hours. All were appraised with no validity issues. However, only the first 2 will be analyzed since Hamza's study did not segregate the interventions in terms of timing. Culprit trial showed no difference in MACE, but CompareAcute trial showed that single-stage complete revascularization versus staged PCI within 72 hours showed significant reduction in MACE by 65%. Now let's look at the evidence of single-stage versus staged PCI after discharge. 3 trials were searched. However, the study of Ghani was not included in the analysis since the control arm was conservative management. Even Prague trial showed no data on single-stage PCI, hence cannot be included in the analysis. Only Politi segregated complete revascularization into 2 different timings. No significant difference between single-stage and staged PCI in reducing the presented outcomes. 5 meta-analyses were reviewed and appraised. These 3 metas did not emphasize on the impacts of timing of complete revascularization, hence cannot answer a clinical question. These 2 did. The meta of Fatima showed a comparison between immediate versus a pool of delayed PCI as within 72 hours up to 56 days, and results showed that single-stage complete revascularization when compared to staged PCI did not significantly reduce all-cause mortality and repeat revascularization. It significantly reduced re-infarction. There is no increase in contrast-induced nephropathy and major bleeding across the interventions. Heterogeneity was evident in the timing of staged PCI, but after sensitivity analysis, excluding studies where staged PCI was done 2 weeks after index or post-discharge, results show that single-stage complete revascularization gave a 66% significant reduction in all-cause mortality and risk of reinfarction when compared with staged PCI within 72 hours. In the meta of El Gendi, there was no significant reduction in major clinical outcomes when complete index PCI was compared with staged in-hospital and after-discharge PCI. Data for major bleeding and contrast-induced nephropathy were not sufficient to perform an analysis comparing these strategies. No data on stroke was reported. This network meta-analysis by Vlaar showed that staged PCI was associated with lower short and long-term mortality. However, these RCTs excluded patients in cardiogenic shock. We have presented the effectiveness data. Now we go to the prognostic data. In an observational study by Milot, looking at the subgroup of STEMI patients in cardiogenic shock, showed an increased survival rate in those who underwent immediate multivessel PCI, which supports the current ESC recommendation. Now we go to the applicability issues. Cost effectiveness impacts decision making, assuming that the procedure cost is such. This does not include productivity losses when PCI is delayed within 72 hours or after discharge, along with miscellaneous costs. Single complete revascularization offers you a lower cost along with evidence-based clinical benefits. Early successful PCI also greatly decreases complications of STEMI that result from longer ischemic times, allowing earlier hospital discharge and resumption of daily activities with less productivity losses. In summary, In terms of safety data, there's no difference in rate of bleeding and contrast-induced nephropathy across all the 3 different timings of complete revascularization. In terms of clinical outcomes, there's no difference in rate of repeat revascularization and cardiovascular death based on Compare Acute trial. Single-stage PCI has lower MACE reduction compared to 72 hours, but no difference after discharge. But meta-analysis data showed that single-stage complete PCI offers a higher reduction in all-cause death and reinfarction, better survival in patients with cardiogenic shock, less costly, and provides less productivity losses. Now, which timing is most beneficial for STEMI patients with multivessel disease? The answer is single-stage complete revascularization. Thank you.
Good afternoon. I'm here to present our points in favor for our topic, the complete revascularization after ST segment elevation MI within 72 hours prior to discharge. My objectives for this afternoon are to give a background on why complete revascularization is better than culprit-only revascularization, and to present our current dilemma regarding the ideal timing of a complete revascularization strategy. A brief word on ST segment elevation MI. Despite advances in treatment, acute coronary syndrome such as ST segment elevation MI in particular still presents an enormous medical, social, and economic burden worldwide. Timely primary percutaneous coronary intervention of the infarct-related artery is the preferred therapy for STEMI as supported by recent guidelines. Debate regarding culprit-only PCI versus complete revascularization has been ongoing owing to the fact that 30 to 60% of STEMI patients have multivessel coronary artery disease. Recent studies have shown that complete revascularization has significantly lower incidence of major adverse cardiac events such as cardiac or non-cardiac death, in-hospital death, reinfarction, rehospitalization for acute coronary syndrome, and repeat coronary revascularization. The complete trial by Mehta et al., published in October 2019, is a multinational RCT that evaluated a strategy of complete as compared with a strategy of no further revascularization in patients with STEMI and multivessel coronary artery disease who have undergone successful culprit lesion PCI. The study enrolled 4,041 patients, half of which were randomized to complete revascularization after successful primary PCI. It showed a 26% and 47% lower risk in both co-primary outcomes of cardiovascular death, myocardial infarction, or ischemia-driven revascularization in the complete revascularization group. With this study, there is solid evidence that complete revascularization is superior to culprit-only revascularization. However, the timing of the procedure is yet to be established, which raises the question, what is the best timing for a complete revascularization strategy? The interventionist has the option to perform either a single complete revascularization or doing a staged procedure. The PRAMI trial by Wald et al., published in September 2013, enrolled 465 patients, a portion of whom were randomized to undergo immediate preventive PCI after successful infarct artery PCI. It showed a 65% reduction in the combined rate of cardiac death, non-fatal myocardial infarction, or refractory angina in the group who underwent immediate preventive PCI. Although with promising results based on the PRAMI trial, complete immediate revascularization has its disadvantages, such as accumulation of additional contrast load leading to contrast-induced nephropathy, AKI, an acute LV overload, as mentioned in the multi-stars trial, myocardial injury sustained from acute STEMI aggravated by a prothrombotic inflammatory state increases procedural risk and may jeopardize non-infarcted myocardium, as mentioned by Law et al. Finally, a multivessel PCI done during the index procedure resulted in higher mortality, as mentioned in the Horizons AMI trial. The next study aims to show the advantage of delaying complete revascularization after primary PCI. The DDAMI-3 Primulti trial, published in August 2015 by Engstrom et al., had a sample size of 627 patients enrolled in an open-label RCT. Patients randomized to the complete revascularization group underwent PCI procedures using an everolimus eluting stent 2 days after the initial PCI. The DDAMI-3 Primulti study showed that patients with STEMI and multivessel disease who have timely primary PCI benefit from complete revascularization of lesions in non-infarct-related arteries when the second procedure is done during the index admission. It also showed a 41% reduction in risk of primary endpoints in the complete revascularization group, such as all-cause mortality, reinfarction, ischemia-driven revascularization of lesions in non-infarct-related arteries. Performing a staged non-culprit vessel PCI has the advantage of mitigating the above-mentioned disadvantages. It also allows the cardiologist to perform a more physiological assessment of stenosis rather than relying solely on an angiographic judgment of lesion severity and identification of non-culprit lesions done in the acute setting of the primary PCI procedure. The DYNAMI 3 Primulti trial, however, did not state a definite time frame in which to perform the stage procedure. Hence, there are also disadvantages of performing a very delayed PCI. Patients who are discharged and scheduled for a later stage procedure may not return for various logistic and socioeconomic reasons and end up being incompletely revascularized, which predicts worse long-term mortality as shown in the complete trial. With all these supporting evidence-based studies, we therefore conclude that the best timing for stage complete revascularization is within 72 hours during the index hospitalization prior to discharge. Thank you.
Among patients with ST segment elevation MI, complete revascularization is superior over revascularization of the culprit artery only. But the question is, when is the best time to do it? I'm Christine Alcano, and I firmly believe that the best strategy is to do an ischemia-driven PCI after discharge with the aid of perfusion imaging. So do we really need to rush in doing the non-culprit lesion? They're obviously not the reason why the patient is on the table. And let me tell you this, rushing things could potentially lead to more harm than good. This is what could happen when you rush. First, it can lead to renal failure. Based on the culprit shock trial, doing a complete revascularization in the acute setting and on cardiogenic shock showed an increase in the incidence of renal failure. Secondly, doing PCI in the acute phase may lead to unnecessary revascularization. It is important to take note that in the acute phase, there is a high inflammatory state that results in vasoconstriction of the coronary vessels. And this explains why lesion severity by angiography may be overestimated in the acute phase of ACS, thus leading to unnecessary stenting. Even FFR, which is now a standard in assessing hemodynamic significance of a lesion, still its utility is not reliable in the acute setting. This is because of an increased release of your vasoconstrictor molecules. Therefore, maximal hyperemia cannot be achieved, making FFR less accurate in acute ST segment elevation MI. Clearly, both angiographic and physiologic assessment are not reliable in the acute phase of STEMI. Third, by attempting to revascularize the non-culprit lesion, there is an increased incidence of slow flow or no reflow phenomenon because of microembolization and vasospasm. As shown in this study by Arsan et al., there was a higher incidence of your no reflow phenomenon if you do complete revascularization in the acute setting, which further translates into a higher rate of death, non-fatal MI, and repeat revascularization. And lastly, doing complete revascularization during the acute phase of ST segment elevation, especially in patients with cardiogenic shock, will lead to a higher mortality. Thus, in the latest ESC guidelines, it is a class 3 indication to do primary PCI of the non-infarct-related lesion in patients with cardiogenic shock. This is supported by the culprit shock trial, wherein patients with acute myocardial infarction and cardiogenic shock, the risk of death is higher in multi-vessel PCI compared to culprit shock-only PCI. Therefore, we don't recommend that we do things in a rush, or else we will have to deal with renal failure, unnecessary revascularization, slow flow or no reflow phenomenon, and higher mortality. In a meta-analysis by Vlaar et al., stage PCI had lower short-term and long-term mortality, which was further confirmed by another meta-analysis in 2018. After showing you the drawbacks of rushing things, we recommend that we stabilize and discharge the patient, transition to a chronic coronary syndrome wherein we can risk stratify through non-invasive means such as MRI, nuclear MPI, PET, which has comparable sensitivities and specificities in determining myocardial ischemic burden. Supported by this meta-analysis wherein myocardial perfusion imaging with MRI, CT, or PET can accurately rule out the presence of hemodynamic significant coronary artery disease, hence an important gatekeeper for PCI. In this study, myocardial perfusion cardiovascular MRI was found to be as good as FFR in assessing ischemic burden, which resulted in lower revascularization than compared to FFR. By doing MPI, you can distinguish significant ischemia from non-viable myocardium. For non-viable myocardium, there is no difference in the outcome whether treated medically or with revascularization. For no inducible ischemia, there is no need to intervene. And if there is inducible ischemia, we proceed to ischemia-guided PCI. The basis for our recommendation is the study done by Pereira et al., which showed that in patients with STEMI, ischemia-guided PCI has the lowest incidence of major adverse cardiovascular events rather than multi-vessel PCI. Therefore, we strongly recommend to avoid rush and avoid complications. Instead, treat the culprit lesion, stabilize and discharge, do perfusion imaging, then do ischemia-driven PCI. Thank you.
Hard enough choosing between two. Now we have three choices. Three choices, three debaters, three judges. Who are they convincing most? Now let us start now with Dr. Mambula. Might you want to ask the one who is swift enough to do a single complete revascularization?
Good afternoon, everyone. My question has two contexts. The first is, what if the non-culprit vessel has a difficult anatomy? Let's say it has a left main involvement or it has a chronic total occlusion. And this would mean a longer procedural time, and you are putting at risk the staff or the operator to have fatigue. And of course, the patient into more stress since the patient is in a new onset is the elevation myocardial infarction. So if you do complete revascularization in a difficult anatomy of the non-culprit vessel, so you want to do a complete revascularization, would the benefit outweigh the risk?
Sir, according to studies that we have reviewed, even if patients are subjected to longer procedural time, there is no significant difference with regards to the primary outcomes or the major adverse cardiac events that were included or analyzed in the study. So even if there is anatomical differences or difficulty or prolonged procedural time, the outcome of these patients are not significantly different.
Dr. Mambulao, you still have any more questions?
I have no further question now.
Well, thank you, Dr. Ryan. Thank you very much. Now let's go on ahead for the one who's willing to wait a little bit, 72 hours prior to discharge. Dr. Alotti, will you have any clarification for this group?
Okay, what is your stand on patients with STEMI and in cardiogenic shock? Are you still going to recommend complete revascularization within 72 hours prior to discharge, and why?
Good evening, doctor. With regards to your question, patients who are in cardiogenic shock, especially after ST segment elevation MI, are a clear contraindication to doing a staged procedure. It is mentioned in both the Dynamic 3 Primulti study as well as the complete trial. The patients with cardiogenic shock are a exclusion criteria in performing a staged PCI. So in cases of patients with cardiogenic shock, it is still prudent to follow the present guidelines to do a complete revascularization during the index procedure without waiting to do a staged procedure. Thank you.
Thank you very much, Dr. Uy. Any more questions for the group?
No more, Doc.
Okay, thank you very much. We have very, very Short answer and short question. We appreciate that. Now we're getting to the point. I think we're getting it hotter. Now, for Dr. Suma, for the group that is not willing to rush, might you have a question for them or clarification?
Yeah. Good afternoon again. Among patients with complete revascularization in a single stage or after the 72 hours, they mentioned that it is more advantageous that they are on preventing reinfarction, reintervention, and even lower costs.
Based on our readings, is that the best strategy would be it should be ischemia driven, and we should not rush in doing the non-culprit lesion because it is not the reason why the patient is on the table. So after addressing the culprit lesion, so we convert the patient to chronic coronary syndrome and risk stratify the patient. When we do the perfusion imaging, if it's positive, then the patient is eligible to proceed for revascularization of the non-culprit lesion. So our goal is to do a reasonable, complete revascularization through perfusion imaging, and it should be ischemia-driven PCI. And that should be the best strategy in doing the non-culprit lesion.
Thank you very much, Dr. Harold. Any more questions for the group?
None, ma'am.
Okay, thank you very much. As I mentioned, direct to the point, and we're answering all the questions. Thank you very much, judges, for your very interesting questions, and thank you, debaters. The love triangle continues, and we'll find out who will win at the end. Thank you for a very good presentation of the topic on when do we intervene for our non-culprit lesions and when do we do complete revascularization. To follow, now we're going to talk about tetralogy of Fallot repair. Now, we are going to talk about whether we're going to do RVOT stenting or modified BTS. And I don't mean the Korean pop that is actually globally known now. Let us now hear what the debaters have to say.
Good afternoon. Tetralogy of Fallot is one of the most frequent congenital heart disease and is also one of the first cardiac conditions to be successfully palliated and or repaired. Surgical outcomes have constantly improved over the past 6 decades, such that more than 95% of children have survived into adulthood after the reparative surgery. The spectrum of anatomy within the condition leads to a variability in the degree of cyanosis, which influences the timing and technique of surgery. Hence, the management of cyanotic neonates with TUF remains a challenging condition. Initial management of patients with TUF depends on the severity of the anatomic defect. In patients with mild to moderate RVOT obstruction presenting with no or mild cyanosis, they may undergo single-stage repair between 3 to 9 months of age. If there is more severe obstruction or cyanosis, preoperative stabilization and maintenance of adequate pulmonary blood flow is necessary. In patients with good-sized PAs and weighing more than 4 kilograms, they may undergo neonatal repair, although they are considered as high risk. In patients with low birth weight neonates with small PAs, they can undergo palliation either by MBTS or RVOT stenting. In developing countries, modified Blalock-Taussig shunt is still an important palliative procedure for children with complex congenital heart disease. This is to help increase blood flow to the lungs and reduce the cyanosis. Unfortunately, the usual published mortality rates vary from 3.4% to 16%. In a study done in Thailand, the overall hospital mortality rate is 31%. Several outcomes of BTS lead to the patient's demise. Topping the list are overcirculation causing congestive heart failure, shunt occlusion with 20%, and severe sepsis. A study done by Quant et al. Evaluated differences in pulmonary arterial growth between the two methods of palliation in patients with Fallot type lesions prior to complete repair. Results showed a significant RPA and LPA growth in patients with RVOT stenting as compared with the other group. In comparison of differential PA growth or the RPA-LPA ratio showed better and more uniform growth in the RVOT stent group. Oxygen saturation post-RVOT stenting were significantly higher, and rise in oxygen saturation were significantly better in the RVOT stent group as compared with the other. During TOF repair, transannular patch and pulmonary arterioplasty is necessary for both groups, with PA-plasty being more frequent in MBTS. In a study by Bigdelian et al., they described and compared their surgical experiences with TOF repair following primary palliation by RBOT stenting versus MBTS, with emphasis on the outcome of subsequent surgery. Indications for two-stage repair and primary palliation are the following. Premature infants with severe RBOT stenosis and hypercyanotic spells below 70% O2 saturation underwent RBOT stenting, while infants with PA stenosis and appropriate baseline saturation were selected for BTS. The stents were selected based on the size of the infant's RBOT infundibular length and anticipated length of palliation. Results showed a remarkable increase in PA size Z-scores after palliation in both groups, but was slightly more desirable in stented infants. RBOT stenting increases the PA's blood flow, improves systemic saturation, and ameliorates hemodynamic conditions. RBOT stenting also enables symmetric growth of both PA branches, which may be asymmetric in MBTS. In another study done by Quant et al., comparing the morbidity, mortality, and the intervention rates after stenting of the RBOT versus MBTS for palliations in patients with TOF, they showed that admission rate to pediatric ICU was lower in RBOT stenting, and the total hospital length of stay and time to surgical repair was shorter for RBOT stent group. 30-day mortality in RBOT stent group was lower with 1.7% as compared with 4.9% in MBTS group. RBOT stenting is an effective and safe technique in the initial palliation of patients with TOF. It is considered as a good alternative option for BT shunt. According to published experiences, there is a high clinical effectiveness of RBOT stenting. It improves pulsatile forward flow of systemic venous blood to the pulmonary artery, maintaining the diastolic aortic pressure. It also promotes symmetric growth of both PA branches. It also promotes lower admission rate at PICU, shorter hospital stay, and shorter time to surgical repair. And studies have shown low procedural morbidities and death following RBOT stenting. Thank you.
Good afternoon. In the management of TOF, the Blalock-Taussig shunt was performed in the 1940s and has been since refined as a systemic pulmonary arterial shunt for augmenting pulmonary blood flow, allowing for growth of pulmonary arteries and maintenance of regulated blood flow to the lungs until a proper age and body weight suitable for definitive corrective repair is reached. In the 1960s, in a modification of the technique, a variety of synthetic materials were used to create direct end-to-side anastomosis of the subclavian and the pulmonary arteries. The main aim of the surgery is to increase pulmonary blood flow in a controlled manner to alleviate cyanosis and improve exercise tolerance in these patients. Since then, the principle and the technique of the surgery has improved as a result of the multiple studies and reviews of its short and long-term outcomes. Risk factors, complications, intraoperative difficulties, and nuances in postoperative care are all well documented for a diverse range of patient groups. Being an open procedure, its versatility is evident in being applicable in a variety of congenital heart defects aside from TOF. It has been shown to effectively perform its purpose in all but the sickest of patients. The increasing use of PTFE as a standard graft material used in surgery has made the results more reproducible. This material has been readily available at a reasonable cost. Less factors needed to be taken into account during the surgery, namely the diameter and the length of the graft to be implanted, has resulted in a less variability in technique. The performance of a modified Blalock-Taussig shunt would require minimal modification to the already available OR facilities existing in most hospitals. This is the situation most cases find themselves in. Poorly prepared, symptomatic patients who are in urgent need of an intervention. Although ideal, there is no need to set up an OR equipped to cater to the needs of a large multi-specialty team. During the eventual primary repair, taking down the shunt is easily done with minimal addition to the operative time. Studies have shown that ligating the shunt is possible in virtually all cases. There is no need in extensive dissection of the RV, resection of the infundibular tissues, involved tissues such as the VSD ridge and conducting system, as you would expect during the removal of an intracardiac stent. This translates to a decrease in aortic cross-clamp time and bypass time. The surgeon would therefore be more focused on creating the best repair of all TOFF lesions. Also, the preservation of the pulmonary valve is possible in Blalock-Taussig shunt, and in some cases, transannular patching can be avoided. Lastly, any intra-procedural complication, though inevitable and foreseeable, can be identified and managed by the operator himself, the surgeon, while the patient is inside the OR, with the entire team ready even to go on bypass if deemed necessary. Even graft thrombosis or stenosis can be identified intraoperatively and managed at the table or immediately recognized at the PACU. Our team recognizes the limitations and pitfalls of the modified Blalock-Taussig shunt, which are all well characterized in the multitude of studies done. Despite the promising results in the field of interventional cardiology, modified Blalock-Taussig shunt is still presently a safe and reliable option as a bridge for TOF repair. Thank you.
Quite an interesting topic that we just heard, and I'm sure a lot of you are very interested what the answer would be. Are they convincing us? Should we operate or not? Dr. Ryan Mambulao, do you have any questions for the one who preferred to do the RVOT stenting?
So the question is coming from an adult cardio to a pediatrician cardio. So my question is, would you recommend RVOT stenting among all age groups? And the second question is, which do you think has a better outcome among neonates? Would it be RVOT stenting or BPS?
Yes, good afternoon to Doctor. As for the older age group, yes, we are still recommending RBOT stenting since the stent is still enables still forward flow across the pulmonary arteries, which enables equal growth or asymmetric growth of the pulmonary arteries as compared with the BPS. Since in BPS, the growth can have a preferential flow across the pulmonary arteries wherein the BPS is connected. And as for the second question, RVOT stenting is still a better option as compared with BPS.
Thank you very much, Dr. Ryan. Any more questions from an adult to a pediatrician?
That's all, ma'am.
Thank you very much, Napapamam. Oh my God, nahalata age ko. Let's go now to modified Blalock-Taussig shunt. So I clarified, it's not the BTS we know. Dr. Alotti, do you have any doubt about their discourse about modified BTS?
Okay, my question is, although you mentioned that in modified BTS, the pulmonary valve is undisturbed, but the disadvantages of MBTS is unequal growth or distortion of PAs. So do you think it is a better bridge to TOF repair than RVOT stenting, and why?
Good afternoon. Although we have modified Blalock-Taussig shunt has been shown in multiple studies to be effective, although RVOT has been shown to be symmetrical in its growth of the pulmonary arteries. In all these studies quoted by Quant, by Big Delian, is what matters more is the eventual elective repair of the TOF, the total repair. So it has been shown in these studies that even though RVOT stents do make a symmetrical growth for both pulmonary arteries, the outcomes of BTS and RVOT are still equivalent. However, the advantage of the modified Blay-Lactau-Sig shunt would be we would still recommend it due to its versatility. It would cater to a lot of patients of all age groups, be it at neonatal or during infancy or symptomatic patients. So it would cater to all types of anatomy due to its versatility, its easy access, and the minimal facilities required to perform the procedure. Thank you.
Thank you very much, Dr. Raoui. Any more inquiry?
That's all. Thank you.
Thank you very much, debaters. You have actually educated us a lot, and actually, good luck to all, and congratulations on a very good presentation. Thank you very much, debaters. And of course, we're in the last leg. And from bridge to TOF repair, now let's talk about coarctation of the aorta. Same debate. Are we going to intervene with stenting? Are we going to do surgery? So, as in any way that what happened a while ago, let us now hear if they are going to convince us whether surgery or intervention is the right way on the last leg of debate 2021 that the battle reached its final phase.
Coarctation of the aorta is a congenital heart disease that presents with the constriction of discrete or long segments of the aorta. It can occur in isolation or in association with other cardiac abnormalities and accounts for 4 to 7% of all congenital heart diseases. Historically, repair is done surgically. However, the advent of stenting for these cases offered relief of obstruction through a less invasive non-surgical technique. It utilizes implantation of a stent that is delivered by a transcatheter technique through a percutaneous vascular access. Implanting the stent improves the caliber of the narrowed segment in an instant. Transcatheter stenting can be a primary treatment for majority of these patients or a bridge to surgical operation for the others. Conventionally, stenting is recommended in adolescents and young adults with a minimum body weight of 30 kilos. It is preferred for patients beyond infancy as these are less invasive and result in less procedure-related morbidity. It spares the patient of a surgical scar and the psychological impact that accompanies it. In the subset of patients, the primary indication for intervening is resting hypertension, defined as upper to lower extremity systolic gradient of more than 20 millimeters mercury, and or the presence of symptoms like headaches and claudication. Results are seen immediately after stenting. The procedural success, defined as a gradient of less than 20 millimeters mercury across the narrowed segment, and coarctation descending aorta ratio of more than 0.8 is reported at 97.9%. Based on the study done by Doshi and Rao in 2012, peak systolic gradient decreased from 43 to 2 millimeters mercury with an improved coarc descending aortic ratio of 0.65 to 1. In the same study, it was reported that 81% of the patients were sent home with a gradient of less than 15 millimeters mercury. Average length of stay for these patients was only 2.4 days, which is 3 times less than those of patients who underwent surgical repair. The use of this technique in younger children and neonates has been established. A study by Mohan et al. Compared the outcomes of stent implantation in two groups, patients weighing less than 30 kilos and those weighing more than 30 kilos. Both groups had significant increases in coarctation diameters, but only the latter group had significant greater diameter increase. However, there was no difference between the two groups in terms of the other parameters, indicating the efficacy of this technique even in smaller children. Limited data is available regarding its use in small infants, but it is used commonly in failed or recurrent coarctation post-surgery. Krasman and colleagues present 4 case reports using transcatheter stenting of the coarctation of the aorta in infants under 3 months of age. The indications for the procedure were the following. The symptoms of the patients in these case reports resolved after the procedure, optimizing them for reoperation later on. The use of coarctation stenting in these cases is mainly as intervention for recoarctation, which is a commonly reported complication of surgical repair of native coarctation. Another report by Victor Gretsch in 2016 describes a patient who presents with symptoms of low cardiac output secondary to severe coarctation of the aorta. The dramatic improvement in cardiac output vis-a-vis perfusion in this patient was reflected in the reversal of symptoms, allowing the patient's freedom from mechanical ventilation, just hours after the procedure. In both papers that were mentioned, stenting was done as a bridging procedure to stabilize patients as they prepare for further interventions or operations that are unavoidable. Now that we have established that coarctation stenting can be done in all age groups, we would like to emphasize and compare its safety against surgical repair. No observed earlier procedural deaths were reported in the different studies mentioned. This is a compelling result against the mortality rate of surgery, which was reported at 0.5%. In the subgroup analysis of children between 6 and 12 years of age who underwent surgery and stenting, it was concluded that stent strategy was superior to surgery in terms of complication rate. Furthermore, immediate complication rates were only 1.8% in the stent arm, while it was 13% in the surgical arm. The most common immediate complications during stenting is acute wall injury, though its occurrence post-stenting is less frequent compared to the surgical group. Despite these complications, it is still important to note that stenting is spared from additional risks that come with surgery, such as major bleeding, paraplegia, phrenic nerve injury, and surgical site infections. In the long term, possible complications of coarctation repair, either by stenting or surgery, that the patients are monitored for are aneurysm formation, hypertension, and recoarctation. Based on the study of Doshi and Rao, complication rate on 5-year follow-up for patients that underwent stenting was at 12.5% versus 25% of those that underwent surgical repair. There is paucity of data regarding the specific cost of stenting and surgical repair in the Philippines. However, based on published foreign literature, transcatheter procedure costs less than going through cardiac surgery. The study by George and colleagues compared the cost of doing stenting as the first procedure for coarctation of the aorta against doing surgery as the initial repair strategy. In the surgery first group, the estimated cost was at $11,000. This is a far cry from the stenting first group, which even after adjustment for failure and reintervention costs around $8,000. The same findings were reported by Satcher et al. In UK, where the cost of coarctation surgery is almost double that of coarctation stenting, not including the cost of reintervention should complications arise. The cost markedly increases with the need for reintervention. In a study by Willems et al., reintervention after cardiac surgery increases the cost by 38.7%. Since surgical repair of coarctation of the aorta has a risk of needing post-op reintervention, its cost is actually greater than the reported estimate. Lastly, the cost of cosmetic beauty from the absence of thoracotomy scar is invaluable. Having presented all the advantages of coarctation stenting, we reiterate our stand that it is superior to surgical repair because it is equally effective with good long-term outcome and safety as compared to surgery, with the advantage of being less invasive, faster recovery time, less psychological trauma in
Good afternoon. Open primary repair for coarctation of the aorta is the ideal and safe treatment of choice for coarctation. I have no disclosures. Let's begin by defining what coarctation of the aorta is. It is a congenital narrowing of the upper descending thoracic aorta adjacent to the site of attachment of the ductus arteriosus. The aortic lumen may be atretic, the most severe form of this defect, but aortic walls above and below the atresia are in continuity, as distinguished from aortic arch interruption, in which a short distance separates the aortic ends. Clinical features in neonates and infant, they would show signs of heart failure, which includes edema, congestion. They would also present with apnea, breathing problems, sweating. The blood pressure is higher in the arms than in the legs by more than 20 millimeters mercury. The adults and adolescents, femoral pulses are noted to be absent or reduced and delayed in the presence of a cardiac murmur, hypertension, or an abnormal chest radiograph. Hypertension is common and more severe than in younger patients, and heart failure may occur after about the age of 30. They would also present with heart failure that is preceded by effort dyspnea, cardiomegaly, important left ventricular hypertrophy, which is noted on ECG. The treatment of choice is surgery, which was started in October of 1944, credited to Drs. Crawford and Eileen. Another milestone was that of Clagett in Mayo Clinic in 1948 when he operated on 21 patients. These operations involved resection and reanastomosis with end-to-end or end-to-side anastomosis. These are indicated or isolated coarctation. Results after surgery are favorable. Early hospital death were minimal, and hospital mortality over the last 20 years showed 2 to 10% neonates undergoing the operation with or without persisting patency of the ductus arteriosus. However, in recent years, this mortality rate has dropped to only 0 to 2% due to the progress in cardioplegia management and surgical techniques. Other studies showed a time-related survival in a heterogeneous group of neonates reported by the Congenital Heart Surgeon Society, and the 12 and 24-month survival rates were both at 95%. Patients report a quality of life that is no different than the healthy population. Patients with simple or isolated coarctation had a survival rate of 100%. Other studies, which includes 251 patients, show a median follow-up of 5 years, no operative mortality was reported. Freedom from reintervention at 5 years was at 98.7%, 10 years at 97.4%, 15 years at 87.6%. Freedom from mortality at 2 years was 99.4%, 5 years at 98.5%, and 10 years at 96.4%. This study was published back in 2019. In the recent study published last year, no mortality and no reoperation, no reintervention were noted in adolescent patients and adults. So in summary, resection of the coarctation and reconstruction of the aorta is still considered the standard method of repairing coarctation. On long-term follow-up, the low morbidity and low mortality rates make it an ideal and safe treatment of choice. Thank you and good day.
We have heard them all. Now it's about time to listen to the last two groups who's going to convince us which is better, stenting or surgery. Dr. Harold Suna, are you convinced that stenting should be for coarctation of the aorta? Any clarification for our group?
Good evening. On the surgery of the coarctation of the aorta, the success rate is 97% regarding the reintervention, and there were no reported regarding the reintervention among adult and adolescents. How about in stenting with a coarctation of the aorta?
Good evening, doctors. Thank you for that question. So in the stenting studies that we have reviewed, we actually saw some reported intervention needing reintervention after the procedure. But as compared still to the surgical arm, the reintervention rates in the stenting procedure is still much less compared to the surgery arm. In fact, that is one of our points in our argument for stenting, that it can be used actually to salvage any complications that may arise, even if the first procedure is surgery. So that is one point that we want to argue for stenting of coarctation. Thank you.
Thank you very much, Dr. Harold. Any more questions for our group? They still have 1 minute. Thank you very much. Now let's go to the next group. Should we continue to do surgery for patients with coarctation of the aorta? Dr. Mambula, Dr. Ryan, you want to clarify that with our group?
Good afternoon. According to the affirmative side, stenting has less cost, less hospital stay, and was less invasive. What do you think is the upper hand of surgery over stenting?
With the stenting, sir, you have to treat this patient like your patient, since you have a graft there, which does not grow with the patient. So you will have a long-term follow-up, which is costly for this patient, since you will have to do CT scan basically annually. Although there are still less studies about that, since there are studies about stenting. So. And secondly, there could be more exposure to radiation involved with that follow-up. There's also a risk of We need to be vigilant with the complications of the stent, which involves endo leaks also, sir, compared to surgery, sir.
Thank you very much. Ryan, are we okay with that answer?
I'm good, ma'am. Thank you.
Okay, you're good. So everything has been laid out. The cards have been given. The debaters have given their messages. So thank you, debaters, for a very comprehensive discourse on the virtue of stenting and surgery. That actually is the last topic for tonight. And I think we have but to actually finalize the event for tonight. Dr. Jimenez?
Thank you very much, everyone. Thank you again for listening to our discourse tonight, from morning up to evening. So let me read the virtual certificate of appreciation for the judges and the moderator. The PHA presents the certificate of to Dr. Ryan Mambula, to Dr. Harold Sunga, Dr. Lottie O, and Dr. Helen Ong Garcia in recognition and acknowledgement of his being the judges and moderators respectively, invaluable contribution as judge in the PHA 51st Annual Convention and Scientific Meeting, given this May 26, 2021, signed by Dr. Ronald Cuico, Chair of the Scientific Committee, Eric Cinco, Overall Chair, and Dr. Orlando Bugarin, President. Again, thank you very much to the debaters, and thank you very much to the judges, most especially, and to our dynamic moderator, Dr. Helen Ong Garcia.
You forgot the word beautiful, Rodney. I'll just add it.
Yeah.
Anyway, thank you very much, judges, for a very, very interesting discourse. Thank you very much, debaters. But the final result will come and be announced at the closing ceremonies, for which then the one who will win as the overall team, the one who will win as the winner per topic, and the ones who will win as the top 3 debaters will be announced. So, abangan, because money is involved, prestige is involved, face value is involved. And those are the 3 things that are important during this COVID pandemic. So right now, allow me now to close this session with a reminder for all. Voting is ongoing and the booths will soon close. Practice your privilege and your right to choose the leaders who will you see in the next coming years of the long history of the Philippine Heart Association. With that, I'd like to thank everyone who have attended, and I hope you've enjoyed the whole day. This is a battle of the mind, the brain, and also our exercise quota. With that, thank you very much, and we had a productive day. Maraming salamat po, and thank you, Philippine Heart Association. Maraming salamat.
Thank you, participants, and thank you, Dr. Ryan Mambulao, Dr. Harold C. Sunga, Dr. Lottie A. Uy, and Chairman Dr. Helen Ong Garcia. Ladies and gentlemen, we now move on to our dinner symposium with a lecture on revisiting the mechanisms and therapeutic applications of sulodexide, presented by 3 speakers: Dr. George Sison, Fellow of the Philippine College of Physicians, the Philippine College of Cardiology, the American College of Cardiology, and the ASEAN Federation of Cardiology. Past Head of the Cardiology Section of the Medical Center Manila. Past Chairman of the Department of Medicine of Medical Center Manila. Past President of the Philippine Heart Association. Member of the Specialty Board of Adult Cardiology. Consultant in Adult Cardiology at Makati Medical Center and Medical Center Manila. Dr. Maria Teresa B. Abola, Department Manager of the Clinical Research Department of the Philippine Heart Center, Clinical Associate Professor of Medicine of the College of Medicine of UP Manila, member of the Editorial Board for Vascular Medicine Journal, past Chair of the Specialty Board of Adult Cardiology of the Philippine Heart Association, past President of the Philippine Society of Vascular Medicine and the Philippine Heart Association, Fellow of the Philippine College of Physicians, the Philippine College of Cardiology, the Philippine Society of Vascular Medicine, and the American College of Cardiology, and Fellow and Master of the Society for Vascular Medicine. Dr. Eugenio B. Reyes, Chief of the Division of Cardiovascular Medicine of UP-PGH, Associate Professor of Medicine at the UP College of Medicine, Philippine General Hospital, Scientific Advisory Board Member of the APSC, past Zone 2 Vice President of the Asian Pacific Society of Cardiology, past Governor of the American College of Cardiology Chapter Philippines, and past President of the Philippine Heart Association. This symposium is brought to you by Corbridge and is moderated by Dr. Elaine B. Alahar, Head of the Vascular Unit, Heart Care Services of the Manila Doctors Hospital, Member Training Committee, Fellowship in Cardiology, the Division of Cardiology of the UP-PGH, Board Member of the Philippine Society of Vascular Medicine, affiliated with Manila Doctors Hospital, University of Perpetual Help Dalta Medical Center, the University of the Philippines Philippine General Hospital, and Premier Medical Center, Sucat, Parañaque. Fellow of the Philippine Society of Vascular Medicine, the Philippine College of Physicians, the Philippine College of Cardiology, member of the Philippine Medical Association.
Corbridge Group Philippines, a national company highly driven and committed to bridge quality healthcare to people. Known for its flagship brand, Vessels UF, a unique molecule that provides endothelial protection and antithrombotic properties, clinically approved for various vascular diseases. Brings you Revisiting the therapeutic applications of sulodexide. Welcome, everyone. To moderate this discussion is the Head Vascular Unit, Heart Care Services, Manila Doctors Hospital. Let us all welcome Dr. Elaine B. Alahar.
By now, we all know that any perturbation and subsequent dysfunction in the endothelium is responsible for diseases in the cardiovascular continuum. In theory, we also know that replacing an important structure in the endothelium, that's the glycocalyx, together with risk factor control and utilization of medications for primary and secondary prevention of cardiovascular disease, can mitigate major adverse cardiovascular events. And throughout the years, the theory of glycocalyx replenishment has been tested in several studies. So for tonight's session, three giants, all past presidents of the Philippine Heart Association, will be presenting meta-analysis and discussing the evidence on the efficacy and safety of a glycosaminoglycan, that's sulodexide, in different cardiovascular disorders. I'm deeply honored to introduce to you our three distinguished speakers. First off, to discuss the role of sulodexide in the management of vascular disorders is Dr. Maria Teresa Abola, who is currently the Department Manager of the Clinical Research Department, Education, Training, and Research Services at the Philippine Heart Center. She's also Clinical Associate Professor of the College of Medicine, University of the Philippines, the chair of the Subcommittee on Subspecialty Societies, Specialty Board of Adult Cardiology of the Philippine Heart Association, a member of the Executive Council of the Asian Pacific Society on Atherosclerosis and Vascular Diseases, also a member of the Membership and Credentials Committee of the Society of Vascular Medicine, and finally, a member of the editorial board of the Vascular Medicine Journal. Next off, to present a systematic review on sulodexide in cardiovascular disease is Dr. Eugenio Reyes. He's currently the chief of the Division of Cardiovascular Medicine of the UP-PGH, an associate professor of the same institution, the current head of the Heart Care Services of Manila Doctors Hospital, a scientific advisory board member of the Asia Pacific Society of Cardiology, and as mentioned, a past president of the Philippine Heart Association. And last but not the least, to walk us through the evidence of the safety of sulodexide is Dr. George Sison, a fellow of the Philippine College of Physicians, Philippine College of Cardiology, and American College of Cardiology. He's also a fellow of the ASEAN Federation of Cardiology. He was a past head of the cardiology section of the Medical Center Manila, a past chair of the Department of Medicine of the Medical Center Manila, a member of the Specialty Board of Adult Cardiology, and currently an active consultant in Makati Medical Center and Medical Center Manila. So to start off, let me now present Dr. Teresa Abola.
Good evening. Tonight, we shall be revisiting the role of sulodexide in the management of vascular disorders. Now, first things first, disclosure of my potential conflicts of interest. For tonight's lecture, I will be presenting the results of a meta-analysis of studies comparing sulodexide and other antithrombotic drugs as extended antithrombotic therapy to determine their efficacy and safety in patients who had venous thromboembolism or VTE for the prevention of recurrent VTE. I will also be presenting the results of a meta-analysis of studies using sulodexide for the treatment of patients with peripheral artery disease or PAD and intermittent claudication. Now, VTE first. PTE is a spectrum of thrombotic disorders that spans from a deep vein thrombosis to pulmonary embolism. Now, this table lays out for you the current management options, which include direct oral anticoagulants, the heparins, low molecular weight heparin, also other forms of antithrombotic therapy like aspirin and sulodexide. Now, we shall be focusing on secondary prevention of venous thromboembolism, which is beyond 3 to 6 months of the primary treatment for the acute VTE event. It is important to consider the extension of anticoagulation beyond the primary treatment. For this reason, there exists an increasing trend of venous thromboembolism recurrence in patients who've had their deep vein thrombosis or their pulmonary embolism event. And this goes on and on, even down to about 10 years in the course of their disease. Likewise, their survival rates after their index event also keeps decreasing. This would probably indicate then that prolonging anticoagulation will be a very important decision to make. And it has been shown that this could protect patients from the recurrence of VTE by as high as 70 to 90%, but at an additional risk. That is an increased risk of unpredictable bleeding, which may range anywhere from 0.8% per year in patients with no bleeding risk factors to as high as 6.5% per year in patients who have at least 2 or more bleeding risk factors. This also shows to you some of the landmark trials that have investigated the role of extended anticoagulation for patients with venous thromboembolism. And these include the direct oral anticoagulants, the dabigatran, rivaroxaban, and apixaban, and also other antithrombotic therapy like aspirin and sulodexide. And the risk reduction for recurrent VTE may range anywhere from 80 to 92% for patients on direct oral anticoagulants, while aspirin has been shown in the ASPIRE or WARFASA trial to have a 32% risk reduction for recurrent VTE, while sulodexide in the SERVET trial had been shown to have a 51% risk reduction for recurrent VTE. Now, all these direct oral anticoagulants and aspirin have an increased risk for clinically relevant bleeding compared to placebo, while sulodexide has a risk of less than 1, hardly any. So in the presence of all of these options for possible extended anticoagulation in these patients, it is important to understand the benefits and risks incurred while using anticoagulant or antithrombotic extended treatments to prevent recurrent VTE. Now, there is a network meta-analysis that was done by authors Pompilio and colleagues, And this was entitled The Comparative Efficacy and Safety of Sulodexide and Other Extended Anticoagulation Treatments for the Prevention of Recurrent VTE. This was performed according to the recommendations of PRISMA. Now, the choice of a network meta-analysis or an NMA is really appropriate because multiple interventions are being compared against each other. Now, to first appraise the meta-analysis or directness. As far as these aspects are concerned, population, intervention, the control or comparison drug or treatment, and the outcomes, the meta-analysis indeed directly addresses the research question that we had posed earlier. They enrolled adult patients treated with anticoagulant or antithrombotic drugs after the first 3 to 6 months from an acute thrombotic event, which includes proximal deep vein thrombosis and or pulmonary embolism, to prevent VTE recurrence. And the interventions considered were sulodexide or DOACs, vitamin K antagonists, aspirin, any of this given for another 3 months after the initial anticoagulant treatment. And this would have to be compared to placebo or one of these drugs. The outcomes investigated in these studies were clinical efficacy, which is recurrent DVT and PE, and secondary efficacy outcomes such as distal and superficial vein thrombosis, non-fatal or fatal myocardial infarction, stroke, acute lower limb ischemia, fatal or non-fatal symptomatic recurrent VT. While the safety outcome being investigated is the primary outcome of major or clinically relevant non-major bleeding, and only randomized controlled trials and some observational studies were included in the meta-analysis. As far as validity is concerned, the only negative here is that there probably is not an exhaustive search for eligible studies because there was no mention of a search of reference lists or contact of experts or search for unpublished studies. Now, there were 25 studies that were included, 18 randomized controlled trials, and 7 observational studies. Now, the quality assessment of the RCTs was done using the Cochrane Risk of Bias tool, which shows this result. All the green boxes prove to us that these are high quality trials, whereas 5 of these trials, as indicated by the red boxes, are of low quality because of the bias that had been introduced by lack of blinding of participants and outcome assessors, or performance bias, or problems in the allocation concealment, selection bias. Now, for the observational studies, the Newcastle-Ottawa scale was used. And unfortunately, 6 out of the 7 were not able to fulfill the comparability criterion. Now, for the main results, this bar graph shows the probability to be better for each therapeutic approach shown here for the main efficacy and safety outcomes. Now, it is shown here that the DOACs appear to have the highest probability of being the best drug in the reduction of VTE recurrence, whereas the green boxes, which represent sulodexide, appear to show that the effect of sulodexide on the reduction of pulmonary embolism is very similar to that of the DOACs as far as effect size is concerned, and even better than BK8. And the other outcomes, safety outcomes, and secondary efficacy outcomes are shown here to be better addressed or improved by sulodexide. Therefore, the author's conclusions include the following. Sulodexide is more effective for reducing risk of major bleeding and clinically relevant non-major bleeding when compared to DOACs, vitamin K antagonists, and aspirin. It has also been shown to be more effective for preventing death from any cause and from BPE, PE, MI, or stroke when compared to the other interventions. It is also more effective in reducing the risk of DVT and PE when compared to aspirin. On the other hand, the direct oral anticoagulants were shown to be the best treatment for reducing recurrent DVT and PE, primary efficacy outcome, but sulodexide reduced PE to a similar extent, if not better, as the vitamin K antagonists. Because of this result, the authors commented that these are aligned with the 2019 ESC guidelines for the management of acute PE. On this basis, they had included sulodexide and aspirin for the extended treatment of VTE to prevent recurrent VTE. So in patients who refuse to take or are unable to tolerate any form of oral anticoagulants, aspirin or sulodexide may be considered for extended VTE prophylaxis. This was given class of recommendation 2B based on the level of evidence B. And now for peripheral artery disease. PAD patients may present with any of these syndromes. Some, or about 50% of them, may be asymptomatic. About 1 to 2% of them may present already with critical limb ischemia, while almost 50% also will complain of some form of exertional leg pain, 15% with typical intermittent claudication, and about 33% with atypical leg pain. Now, the Asia Pacific Consensus Statement on the Management of PAD was recently released. And among its recommendations are medical therapy, like antiplatelet therapy for the reduction of cardiovascular events in the form of aspirin or clopidogrel, or oral anticoagulation with the use of low-dose aspirin and rivaroxaban, which may be considered to reduce the risk of systemic adverse events and limb-related events. Also included are measures that may address the complaint of intermittent claudication of PAD patients. Among the medical therapies, xylostazol was given a grade 1A as an effective therapy to improve symptoms and to increase walking distance in patients with claudication. On the other hand, pentoxifylline was deemed not effective as a treatment for claudication. Now, in this portrait registry, the adherence to PAD management, as guidelines have recommended, had been evaluated. And these are all from specialty vascular clinics. And we can see that these specialists are quite efficient with complying with medical therapy for severe risk prevention, smoking cessation, not really so much for intermittent claudication measures like supervised exercise therapy, and no mention of drugs that could alleviate intermittent claudication. Now, some of these options include xylostazol, as I had earlier alluded to, but there are many reported side effects, plus a contraindication in any type of heart failure included in their label. Naftidrafuril is not locally available, while pentoxifylline, as I mentioned, has not been recommended in recent guidelines. Thus, a research question could be, what is the effect of sulodexide on intermittent claudication in adult patients with PAD? Now, this is another meta-analysis that looks at sulodexide and its effect on pain-free walking distance in patients with PAD and mild to moderate intermittent claudication. This had also been done in accordance with the recommendations of the PRISMA standards. Now, to first appraise the directness of the meta-analysis based on the population, intervention, control, and comparison selected outcomes studied? Indeed, this meta-analysis directly addressed the question that was posed. The studies included enrolled adult patients with PAD with intermittent claudication, given either sudodexide 60 to 100 milligrams per day for 90 days, or placebo, or other drugs like pentoxifylline. And the outcome investigated was improvement in initial claudication distance, or ICD, and only randomized controlled trials were included. As far as validity is concerned, all the criteria except one had been complied with. Again, as in the earlier network meta-analysis, the search for reference lists from relevant studies, contact with experts, particularly to inquire about unpublished studies or negative studies, were not mentioned and probably not done. As far as an assessment of the validity of the studies that were included, the authors used the Cochrane collaboration tool, risk of bias, and the JDAD score, which was evaluated with the use of Oxford quality scoring system, or the QSS. And this table shows, for these different criteria, that almost all of these trials had low bias or good quality, high quality trials, except for the Boryani trial, which had a high degree of heterogeneity and publication bias, actually, as the funnel plot had shown. Now, the other two trials, that of Bodula and Shustov, that compared sulodexide against pentoxifylline, had JDAD score of 2. And these were supposed to have not been included because they had stipulated in their criteria for inclusion of studies that they would not include those with a JDAD score less than 2. And indeed, these were the studies that had very poor quality, as shown in this assessment. Moreover, the analysis had shown that there was no difference in the effect size of sulodexide and pentoxifylline. However, the methodology was in question. As far as assessments of the studies being reproducible, this was ensured by having two authors who independently assessed studies for selection and who independently extracted data. Any disagreement was resolved by discussion. Now, what are the overall results of the review? The analysis considerably favored sulodexide when compared with placebo. Now, the effect of pentoxifylline is not comparable to that described in previous studies. Now, were the results similar from study to study? Yes. And this was, of course, after the Boryani study was excluded from the analysis due to the high extent of heterogeneity among data. How precise was the results? Now, this forest plot of ICD mean difference based on raw data with ICD calculated in meters in the sulodexide treated patients shows to us that for these studies, the confidence intervals were mostly wide for most, but the pooled estimate is narrower and favors sulodexide treatment. There was an interesting analysis that was done by the authors, and it's called Leave One Out analysis of ICD improvement measured in meters in the sulodexide group. And this meant that analysis would be done excluding one of these trials and repeated for each one, being excluded for every turn. And as you can see, the results have been really stable, indicating that the influence and weight of each study were very light. Thus, after 3 months of sulodexide treatment, the effect size was 70 to 90 meters, an increase of about 45%, much more significantly higher than placebo, which still had some increase, 3% at that, of ICD. Now, according to some European guidelines, any change or increase in the effect of more than 30% would be reason enough to accept the results of such an intervention. Therefore, the author's conclusions are as follows. Sodexide given 6,200 milligrams per day for 90 days can significantly increase the initial claudication distance in patients with mild to moderate intermittent claudication when compared to placebo. ICD increase was about 70 to 90 meters in the intragroup analysis, or about 45% increase, and 60 to 80 meters when compared with placebo. There was also no conclusive difference between sodexide and pentoxifylline from the studies that were analyzed. One last note, as far as funding is concerned, the network meta-analysis on venous thromboembolism was provided an unconditional grant by Alpha Sigma, makers of sodexide. While the meta-analysis on PAD had no external sources of funding and was guaranteed by the main author, Professor Gadi. So in summary, as far as the role of sodexide in the management of vascular disorders is concerned, specifically venous thromboembolism, the network meta-analysis demonstrated that the DOACs were more effective than vitamin K antagonists, sodexide, and aspirin in the prevention of VTE recurrence. Sodexide appears to be more effective than aspirin in reducing the risk of DVT and PE recurrence, and was shown to have very similar values to those of vitamin K antagonists for the reduction of pulmonary embolism risk. Sodexide also appears to be more effective for reducing major bleeding and clinically relevant non-major bleeding risk, also for preventing deaths from any cause, and deaths from VTE, PE, MI, or stroke, when compared to direct oral anticoagulants, vitamin K antagonists, and aspirin. And as for peripheral artery disease patients, the meta-analysis presented demonstrated that sodexide was shown to significantly increase the initial claudication distance of patients who received 90 days of treatment with 60 to 100 milligrams per day compared to placebo. Because these are not head-to-head clinical trials comparing sodexide with other drugs for intermittent claudication or for prevention of recurrent VTE, caution must be exercised in interpreting or applying the results of the network meta-analysis on VTE or the meta-analysis on PAD and intermittent claudication. Thank you for your time and attention. I will turn you over now to Dr. Eugene Reyes.
Let me share my screen so I can present to you the systematic review on the use of sudodexide in people with cardiovascular disease. But before that, I'd like to disclose the following. And this is the title of the paper, Sudodexide versus Control and the Risk of Thrombotic and Hemorrhagic Events, Meta-Analysis of Randomized Trials, published online last year, October 2020. If you remember, in 2018, I presented similar meta-analysis which was not published because I was trying to retrieve more data. But this time, this meta-analysis included more patients, and but limited also to 6 randomized controlled trials. So the clinical trials that were included were the SURVET study, which were patients with first unprovoked VTE who had completed 3 to 12 months of oral anticoagulation, given sudodexide 250 LSU, 2 cups BID for a period of 2 years observation. The second was the Sun Micro or Macro, which included the type 2 diabetes patients with renal impairment and significant proteinuria, and given sudodexide 200 milligrams per day or placebo for an observed days or months of 11 or 12 months. The third was the Sun Micro, which included type 2 diabetes with elevated urine protein to creatinine ratio given also sulodexide 200 milligrams per day for an observation period of 6 months. Then the Sanval, which included people with deep vein thrombosis, completed 6 months of anticoagulation and given 250 milligram or 250 LSU BID versus placebo for 24 months. Then we have the Suavis study, people with PAD, given also intramuscular, followed by 2 cups BID for 6 months of sulodexide. And last but not the least was the IPOB2, which were included patients with acute myocardial infarction and given intramuscular injection of sulodexide for 30 days, followed by 2 cups BID for 11 months, a total observation of 12 months. Now, this trial, the focus question was on the effect of sulodexide on people with various vascular disorders on cardiovascular death, total mortality, MI, and stroke, and also VTE. But I will not discuss that because that was discussed already by Dr. Abola. Now, there is a validity criteria for these studies, and as you can see, they were all graded green, which means there is low risk of bias, but there are yellow shades, and these are questionable, but some receive red marks. That means there's no blinding, there's no blinding of personnel, but importantly, they do not know if the outcome assessment was blinded. And that is very important in the manuscript writing to really state if the outcome assessment was blinded. But these clinical trials were not so old, and they were considered well valid by the main author of this clinical meta-analysis. So let's talk about the effect of sulodexide on all-cause death and cardiovascular death. On all-cause death, the odds ratio was 0.67, which means that sulodexide can lower the risk of death from any cause by as much as 33%. And the one that drove the significant effect was that of IPOB2 and perhaps the Sun macro. On all-cause mortality, again, it was statistically significant. The odds ratio can be reduced by as much as 56%, and it was driven again by IPOB2. Now, on myocardial infarction, it was also statistically reduced by as much as 30%, and again, driven by one big clinical trial, and that's the IPOB2. And then on stroke, it was not statistically significant, and the confidence interval was wide. But if you look at on the context of pulling all of these patients with vascular disorders and finding out whether you can reduce all-cause mortality by giving sulodexide or not giving it, on this perspective, you can see that all-cause mortality can be reduced by sulodexide. CV death can be reduced, MI, but not stroke, and venous thromboembolism. And sulodexide is not causing an increased bleeding risk. So in conclusion, the authors stated that this systematic review suggests promising results with reduced odds of venous and arterial thrombosis and a potential for reduced cardiovascular and all-cause mortality without a counterbalancing increase in bleeding risk, which we see in modern anticoagulants and antithrombotic therapy. Nevertheless, given noted limitations, additional studies are required to test this agent in contemporary practice.
Thank you very much. I hope you've learned a lot from the previous speakers, and they have talked about the meta-analysis, mortality, and of course, the outcomes of sulodexide trials on recurrent VTEs and PAD. Now, it's very important for us to now listen to the safety profile of sulodexide. So if I may share my slide, and here are some very important data that I will share with you about the safety profile of sulodexide based on the various studies. First is the safety of individual studies, and they are, of course, on label indications. So on your screen, you see 4 studies. This is a study on diabetic retinopathy, and then the IPO-V2 by Condorelli. This is about stroke prevention in post-MI. And then STROS by Rivera. This is a local study that was published in the Philippine Journal of Neurology, all about acute ischemic stroke and the role of sulodexide. And finally, the 4th study was my article about sulodexide in acute coronary syndrome. And you can see in all of these 4 studies, the safety profile of sulodexide was proven versus control in the DRESS study, 11.11% versus 17.19 in the control. The IPO sulodexide only showed 2 patients with hematoma on the injection site, and the rest were minor adverse events. On the STROS, there was no drug-related adverse event, and in my study, SUPREME, there were only mild to moderate adverse events that occurred in 7.7 patients. There was no bleeding. Another series of studies on on-label indications, SWAVIS, dealing with intermittent claudication by Kosheri, showed sulodexide versus placebo was safe. There were only minor side effects like diarrhea, epigastric pain, skin rash, and all minor adverse effects. And then, of course, Servet by Andriozzi on the prevention of recurrent VTE. Again, sulodexide showed lesser adverse event, like 48.7% versus 52.4% on control group. And only 12.9% in sulodexide had possible treatment-related adverse event versus 16.6% in the control. No? And 11% versus 8.1% at least had one serious event, but this was very minor in sulodexide. Also leading to discontinuation, 13.6% with sulodexide versus 9.1% versus control. And finally, 1.3% versus 0.3% had fatal adverse event in sulodexide. The safety of sulodexide was also seen in the VTE recurrence prevention. This was a meta-analysis looking at the bleeding events, again, involving 3 studies by Andriozzi, Siruheda, Erici, and Luzzi. So these are 4 studies. Looking at the bleeding events, so you can see, sulodexide was only reported with minor bleeding in 2 cases, while in the control group, there were more bleeding, total of 12, no? 2 for major, and then 9 for minor bleeding in the control group. In the non-bleeding events reported in this meta-analysis, again, sulodexide only was reported to have 11 minor events, such as abdominal pain and allergy, whereas in the control group, there was abdominal pain in 5 cases, and there were a lot of adverse events with allergy. Regarding the safety of sulodexide in chronic venous disease, this is a forest plot presentation of the adverse effects of sulodexide versus control. So as you can see, there was no significant difference between sulodexide versus control, again showing the safety of sulodexide when used in chronic venous disease. How about venous ulcer treatment? This forest plot of adverse effects of sulodexide versus local treatment again showed no significant difference between sulodexide and control group, meaning the safety profile of sulodexide was again reinforced in this study. This is a very interesting presentation on the comparison between sulodexide and DOACs on bleeding events. On the left-hand panel, you can see that the major bleeding events in the sulodexide trials, there were 4 of them, showed only one study with reported bleeding event, and that was with Adriozzi in sorbet trial, only showing 0.65%. But you can see on the right-hand panel on the DOAC studies, there were numerous bleeding events in the rivaroxaban studies, the Einstein DVT and the Einstein PE at 7.6% and 10.2% respectively. The Hokusai VTE representing edoxaban again showed 8.2%. So in these comparative studies, you can see sulodexide is very much safe in terms of less bleeding events. Regarding chronic venous disease, we see here 4 studies showing decrease of total symptom score with sulodexide in this forest plot graph, and also in the decrease of pain score, again in a forest plot graph, showing sulodexide's favorable effect on reducing pain scores in chronic venous disease. Regarding VTE recurrence, in the unadjusted score here, we can see that sulodexide was much favorable or a lot superior than placebo in reducing VTE recurrence. And the p-value was very significant. And when the factors were adjusted, again, sulodexide maintained a very significant benefit in reducing recurrent VTE versus placebo. Here is a meta-analysis in the prevention of VTE recurrence involving several trials. And looking at this, you can see that all of this meta-analysis data favored sulodexide versus control group in the prevention of VTE recurrence. SWAVIS is another very important study on chronic venous ulcers, which showed the higher rate of healing of chronic venous ulcers with sulodexide on day 60 versus placebo, and it was significant. After day 90, you can see here a much greater improvement in the healing rate of chronic venous ulcers with sulodexide versus placebo. Again, much more significant difference. Also in SWABIS, they looked at the intermittent claudication improvement, and as you can see, based on the intention to treat population, sulodexide was much superior than the control group in the pain-free walking distance, and likewise in the maximum walking distance. When per protocol population was analyzed, again, sulodexide, ulit tayo dyan. Nag-i-slur ulit ako. Counting, 3, 2, 1. Again, in the SWABIS involving intermittent claudication assessment, you can see here that based on intention to treat population, sulodexide was much superior than placebo or control in the improvement of pain-free walking, as well as the maximal walking distance. When they used the per protocol population analysis, again, sulodexide showed very superior improvement in the pain-free walking distance and also in the maximal walking distance than control. Looking at the peripheral arterial disease meta-analysis with the several studies, you can see here that the sulodexide promoted additional 68.9 meters improvement in the initial walking distance versus control, showing to the efficacy of sulodexide in peripheral arterial disease. Strauss, I mentioned about this earlier, is a local study on acute ischemic stroke authored by Reyes, and it showed that sulodexide was much superior than control or standard of care in the improvement of the modified Rankin scale responders or symptomatology, though the p-values were not significant, but you can see numerically sulodexide showed much better profile than standard of care all throughout the study. DRESS is the study on diabetic retinopathy. This is a Korean study and showed that the intention to treat protocol, the success rate of sulodexide was much greater, 39% versus control, which is only 19.3%. And it was statistically significant. When looking at the per protocol analysis, again, sulodexide was much superior than control at 38.9% versus 17.6%, which is again significantly much different. So let me conclude, ladies and gentlemen, colleagues. It was explained that the sulodexide is a combination of fast-moving heparin, dermatan, and it has unique formulation characteristics that may affect the endothelial glycocalyx and the coagulation properties and also the inflammatory pathways. It is oral and parenterally bioavailable with long half-life. And I presented to you some safety profiles of sulodexide showing that it is generally tolerable with very low risk of bleeding complications. And lastly, sulodexide has been proven to be effective across a wide variety of conditions within its approved indications or on-label indications. With that, I'd like to thank you for your attention.
Thank you, Dr. Sison, Dr. Reyes, and Dr. Abola for that excellent discussion. We will now be moving on to the panel discussion. For all our viewers out there, you may type in any of your questions in the chat box provided in the Zoom webinar platform, and we will get through them as we go on through the panel discussion. Thank you.
Thank you, Dr. George Sison, Dr. Maria Teresa B. Abola, and Dr. Eugenio B. Reyes. Doctors, the floor is now open for your questions. For those who have not sent in their questions, please do so now using the chat box. Our speakers and moderators will now field the questions already sent. Thank you.
Good evening, everyone, and welcome to our open panel discussion. Thank you again, Dr. Abola, Dr. Reyes, and Dr. Season for walking us through the evidence surrounding sulodexide in terms of its efficacy and its safety in major cardiovascular and vascular disorders. I'll give a recap of what you have discussed before we move on to the question. So Dr. Abola has highlighted that within a 10-year period of time, a patient who has had a prior venous thromboembolism will have a recurrence rate as high as 10% within a 10-year period, such that if we give extended anticoagulation, we get a 90% protection from that extended anticoagulation. But at the same time, we have a 6.5% increased risk of bleeding depending on the anticoagulant or antiplatelet that we give to our patients. In patients with peripheral arterial disease presenting with intermittent claudication, sulodexide has been shown to increase claudication distance and has improved quality of life in these particular patients who were given sulodexide. For patients who were given sulodexide for VTE, treatment as extension therapy, it was found to be better in terms of reducing major bleeding, clinically relevant non-major bleeding. It is better than aspirin in preventing VTE recurrence. It is almost equal to vitamin K antagonists in terms of preventing VTE recurrence, but direct oral anticoagulants have been proven to be better at reducing VTE recurrence compared to your vitamin K antagonists, aspirin, and even sulodexide. Now, Dr. Reyes has highlighted that with the meta-analysis or the systematic review that was shown, sulodexide can reduce cardiovascular mortality, all-cause mortality, myocardial infarction, venous thromboembolism, without increase in bleeding, but there was no significant reduction in the risk for stroke. And in terms of safety, Dr. Season has highlighted that sulodexide is definitely safe with few adverse events, particularly more mild to moderate at that, with the intramuscular injections of sulodexide rather than the oral preparation. Now, you've given us a lot of evidence. And before we go to the clinical application of the evidence that you have provided, let us just go to the nitty-gritty of the meta-analysis that you provided or shown to us. First off, with Dr. Abola, I'd like to ask that you mentioned that in terms of the search for the database of the trials that were included, it was kind of incomplete because some experts were not actually called upon to provide some remaining evidence. Do you think that if this evidence were actually provided and included in the meta-analysis, would this have greatly affected the results of the network meta-analysis?
Oh, well, thank you for that question. Well, first of all, they didn't mention in their methodology as far as the search strategy was concerned about looking for all of these negative trials or unpublished trials. Now, it could have an effect because just looking at one meta-analysis for VTE recurrence prevention, very also recently published, but not an NMA, just a meta-analysis on sulodexide. There were 3 studies, 2 RCTs, and one observational study that were included in that meta-analysis by Zhang, but not included in this study. So I took a look at them, and the methodology for this network meta-analysis
stipulated at the very start that they need to include only placebo-controlled trials. So those RCTs that were included in the previous didn't have really a placebo group, no placebo arm. It was just really no sulodexide, period. Whatever the patient was receiving, as long as it wasn't an active intervention, then that would be the other arm. So probably that was the reason why they did not include that. The other one, I wasn't sure why they didn't include it because it was compared against vitamin K antagonist, but not warfarin, acinocumarol. Um, I was looking for a possible reason, but I couldn't really explain why they didn't include that. And in the Jang meta-analysis, it contributed to the favorable effect on of surdexide.
Just as a follow-up question with regards to the studies included, do you think because in terms of the studies on the direct oral anticoagulants, there were at least 5 because there was 2 for Einstein, for rivaroxaban, 2 for apixaban, and just 1 for sulodexide, even 2, I think, for aspirin, combining it with vitamin K antagonist in one other trial. You think that if we could have added more trials using sulodexide, perhaps it would really lean more towards a robust effect in favor of the drug rather than it just being equal to a vitamin K antagonist and it being sort of inferior to your direct oral anticoagulants?
Well, the magnitude of effect in these other trials wasn't really as large as those of the DOACs. So I wouldn't probably extend that much. The projection that including them could make sodexide an equal or surpass as far as BTE recurrence is concerned.
Okay. We'll get back to the PAD study, Dr. Abola. Let me just move on to Dr. Reyes. I do remember, sir, when you presented the meta-analysis a few years back, I think I saw the same diamond shape. I saw the same results. And it was mostly driven by really just one trial, the IPOV2. But looking at the table you presented in terms of low, moderate, and high risks of bias, a lot of the trials actually had high risk of bias. Even IPOV2 actually had non-blinding of the participants, non-blinding of the assessors, question marks for the outcome assessors. So given the fact that this particular study drove the effect of the meta-analysis, how can you now drive the point of it having a significant and sort of an evidence that is acceptable to us, considering that there is a high risk for bias for this particular study?
Yeah. For me, the best way to answer that is, of course, there's no perfect study. You will be able to identify bias. When you say bias, it's deviation from the truth. And whenever you are assessing bias for a particular clinical trial, there is always a direction. And this direction is usually towards the drugs under investigation. These biases will most likely overestimate the treatment effect. So you must accept that fact, that possible risk that the treatment effect has been overestimated, but you cannot invalidate the study right away or totally invalidate the study because it's a big trial. So what you can do is perhaps wait for more clinical trials because as the data accumulates, these biases are neutralized eventually. They get neutralized, and you will see if, especially if you see similar direction of effects, then most probably these biases are maybe true, but not against or not totally um, invalidate the study or towards a different scenario. I mean, you cannot say that sulodexide is not effective in MI when in fact it is telling us it is effective, but only that you are saying that there is an overestimate of this effect, and that for us to be able to find out if in myocardial infarction the real effect, the true effect of sulodexide, we must conduct another clinical trial, perhaps in the modern therapy that we have. In, I mean, repeating it will perhaps increase the precision. It's something like that, and we can confidently say that this is the true effect of the drug, and it's not an overestimated.
Would it be possible to actually do a subgroup analysis for these particular trials? Because if you look at the population studied, it's actually just the IPOVO2 who presented with coronary artery disease. The others are patients with risk factors for CAD. Perhaps we can extrapolate some data from the patients with peripheral arterial disease in the SUAVIS trial. But could the effect have been different if subgroup analysis for these particular trials, just looking at CAD patients?
Yeah, it's doable, but you need to go back to individual patient data. What they did was a meta-analysis of clinical trials that reported, right, that reported this event rate, which means if the clinical trial did not report the MI stroke, they will exclude it. But I think there are many clinical trials that this data can be extrapolated, or you can communicate with the authors themselves. That is doable, but of course, it's extensive work, kind of extensive.
Okay. Thank you, Dr. Reyes.
Dr. Alahar,
yes,
can I say
Dr.
something?
Abola. Yes, ma'am.
Yeah. As far as mortality is concerned, the network meta-analysis, which just really looked at the VTE trials, did mention that among the many methods that they used, it was really very challenging to understand that for all-cause mortality, actually, they put sulodexide as the one having the highest probability of reducing it. And as far as cardiovascular death is concerned, alone, they put aspirin and apixaban, followed by DOAX and sulodexide. And as far as the cluster of VTE, stroke, PE, and the other non-MI events, sulodexide was aspirin and sulodexide were also there. So there seems to be a trend or a signal. Maybe, as Dr. Reyes had said, if there were more trials, direct trials, that we could pin it down.
Agree. I think because you had more robust data in terms of the network meta-analysis, you had, I think, 25 RCTs that were looked into, which provided that particular data, ma'am.
More clinical studies with Dr. Test's analysis. Mine only 6. It's because they did not extract. I think the one presented by Dr. Test, they extracted individually. So that's the difference in most of the clinical trial meta-analysis that we are seeing. It depends on the methodology of how they got the data. I mean, if you reported mortality based on your publication, then I will get this. If you did not, then I will not. But if you look into the study itself, so it is reported down the line. It is reported somewhere. So you can get it. So it's something like that.
Okay. Just before we move on to the questions, just a comment from Dr. Chua. His is not a question, but rather a comment. He wants to thank the speakers for increasing his confidence with using sulodexide. He thinks that evidence abounds of its efficacy, but for a clinician like him, its safety profile is most assuring, which directs me to my question for Dr. Season. Yes, sir. So you mentioned actually the safety profile really is unbelievable with in terms of sulodexide. With oral therapy, it's almost less than 1%, but with the IM injections, you actually get more reactions. Can you again go through these particular adverse events and why is it a little bit higher than placebo and what causes this particular reactions in these patients?
Well, talking about the oral administration, the adverse events with pseudodexide or side effects is just very minimally greater than placebo, simply because of its mechanism of action, no? On the coagulation pathway, as well as the vascular mechanisms. So you may have some form of bruising. The only reported minimal side effect was a 0.69% reported with andiopsy, in this study. In the parenteral administration, it's just pain or hematoma in the injection site, but bleeding wise, there was not any reported major bleeding. It was consistent in almost all of the studies, the safety profile of sulodexide.
Okay. Yes, Dr. Reyes.
I have not used
The
IM or IV pseudodexide, but I think Dr. George used it already in your study. That's an ACS study, right, Dr.
Yeah.
George? Did you see any bruising or bleeding? I know you reported zero bleeding, but what about bruising, especially on the injection site? Did you notice? I have no experience with IV or IM with sulodexide. My experiences are all on oral preparation.
Yeah, when we did that trial on safety and tolerability of sulodexide in acute coronary syndrome many years ago, we followed the protocol of in the IPO that we give injection for at least 7 to 10 days, once a day, up to 650 SLU IM, and then switching to the oral to capsules BID for the next 21 days for a short-term observation of 30 days. And there was nil reporting on bleeding, not even hematoma. The only reported side effect was pain on the injection site. So that really increased the confidence of the investigators on the safety and tolerability of sulodexide. Even in my practice, when I'm using it in my clinical practice, intravenous or intramuscular, I have yet to see anyone bleeding from it. It's just the pain on the injection site.
And how do you manage these particular injection site hematomas, Dr. Season? Do you reduce the dose? Do you just apply cold compress? Do you shift to oral medication or just continue it as is?
Yes. For the intramuscular, obviously, I had to put some ice compress on it. But in the in-hospital patients, since they are on IV line, we do it intravenous while they are confined. So I had no problem with regards pain on injection because it was IV injection. So that's the advantage of this drug. When you have an IV line, you can do it IV. If there's no IV line, you can do it intramuscularly. Even as outpatient upon discharge, I continue giving it intramuscularly. And I've yet to see anyone bleeding from the parenteral administration of sodexide.
Okay. So Dr. Timbresa is asking if we used injectable sulodexide preparations in the treatment for patients with venous thromboembolism and peripheral arterial disease in the randomized controlled trials, and for patients with myocardial infarction too. I guess for the VTE, Dr. Abola can answer. And then for the MI, I think Dr. George already said that he did use both IM and IV preparations. Yes, Dr. Abola?
Yes. So it was only the survey trial that was included in the NMA, and they used only the oral preparation, the oral regimen of 2 cups twice a day. 2 cups twice a day for 2 years.
Medyo mahal yun ah. Joke.
No major bleeding. No major bleeding. And one clinically relevant non-major bleeding on each arm, I think.
2 cups is it's like a moderate dose or high dose. Is that high dose?
It's like maybe a moderate dose, because the high dose would be the IV regimen. Like if we can give it for very advanced stages of chronic venous insufficiency, the very severe venous ulcer, very large weeping venous ulcers. That's an option to start them on this parenteral regimen, even for a month, and afterwards continue on with the 2 cups twice a day, and later on the 1 cup twice a day.
I'm not sure if medication persistence and compliance would be an issue for the three of you when you prescribe sulodexide to these patients. Like for VTE extension treatment, it's 2 cups twice a day. How do your patients manage that in their daily intake of other medications and the intake of sulodexide? I even saw Dr. Reyes presenting one trial on diabetic nephropathy, which used a dose of 200 milligrams per day. So that's around 2,000 liposemic units. So that's around 1 to 4 capsules a day. So how do you manage medication persistence and compliance for your patients who need to take so many capsules of sulodexide a day?
Sino ba sasagot niyan?
I was going to. Ladies first.
Yes.
I really make it a point to discuss the benefits, potential benefits, and the risks. And when I do that, you can really appreciate the patients who really think about it, the balancing act. And they will tell you their preference. They will tell you, I will continue with this because, so on and so forth. Or I give them many options too. I give them as much as possible all the other options, and then I individualize it to their situation. And I do that every 3 months.
Ellen, may I add to that? In my practice, I really see the adherence and compliance of my patients when they see benefits from the treatment. They would not stop it. No, they would not stop it as long as I tell them to maintain it. And besides, even if they have to take 4 capsules a day, the sulodexide capsule is so tiny, so it's very friendly to the patient, so they can easily swallow it, unlike the bigger tablets that we give to our patients. So once they feel the benefit, they are confident to continue it because they are afraid they will lose the benefit if they are not compliant with it. That's my observation in my own practice.
Elaine, I think adherence is very important here. No, it's a nice question that you injected into this, because aside from the price and the frequency of giving it and the number of capsules, it will definitely affect adherence and compliance. In fact, there are some patients asking me if one capsule is okay already. Why do I need to take so many capsules? But then I agree with Dr. Rates, explaining it is one of the more important aspect of the adherence. But aside from that is behavioral approach. Um, the dose that you saw in one of the clinical trial, that's the Sun Micro and Sun Macro, was a different preparation of pseudodexide. It was created in the USA, and in fact, there was no BAB study. They only tested the heparin component of that. There was no testing for the dermatan component. And in fact, it was not even a fast-moving heparin. It was a tablet, so you can see already the difference between the bioavailability of the two agents. Now, it was a negative trial. No, for me, it wasn't negative because at least you saw already that this kind of preparation is not effective, that you have to go back to the original preparation, which is a purified glycosaminoglycan in a liquid form, because it should be a liquid form and not a dried powdered form, diba? So, but they're trying to resolve the issue on adherence to make it once a day. I think in Europe, they're trying to come up with a once a day dosing to improve compliance, but it didn't materialize because I think it's something that it's a glycosaminoglycans. It's something that you need to ingest continuously. It's natural. It's part of our body. You need to replenish the glycocalyx for it to work. So I think it's something. It's important for doctors to be able to explain this to the patients and perhaps do behavioral approach, because there's no choice, right? You have to give it really frequently. And yung 2 cups nga, medyo 4 cups yun a day, ano? Hindi yun libre, no? Bibilin mo pa yun. Tapos, iinumin mo pa ng madalas. Kaya, I agree with Dr. Ates that you need to explain.
Thank you for sharing your own clinical experiences. Maybe I can throw this question to Dr. Reyes first because he has been in touch with the author of this particular study. And then our 2 other speakers can chime in if they want to. This is from Dr. Reynaldo Neri. Any experience on sulodexide in managing mild to moderate COVID as anti-inflammatory and its pleiotropic effects on endothelial dysfunction? And any latest evidence on its use to improve conditions of patients with COVID?
Well, there was one clinical trial, a randomized trial in Mexico, and I think he was able to lecture it here early this year, and it's in 200 more than 200 patients with early COVID. It's not really mild to moderate; it's early COVID, And the premise was um, the author thinks that if you have endothelial dysfunction and you acquire COVID, you will have more endothelial dysfunction. And so protecting the endothelium with an antithrombotic agent will prevent progression because he thinks there are three aspects of COVID. One is infection, two is inflammation, and the third is thrombotic complication. So he is addressing one, thrombotic complication. And you have to give it early, and not to all patients. He clearly stated that this is only for patients with cardiovascular risk. And I think in terms of application, this is not for everyone. This is not for mild. This is for early COVID. And you need to identify who will progress to severe. Or kasi the outcome was hospitalization. Eh. It prevented hospitalization. So you need to predict who will get hospitalized. And who will get hospitalized? These are people with cardiovascular risk factors, obese, hypertensive, diabetic, any one of those, and age, 40 years and above. And if you give it early, first 3 days, you have to catch the patient early. Otherwise, it's not applicable if you don't catch the patient early. With cardiovascular risk factors, then I think that's the point that he is saying. You can prevent hospitalization and use of oxygen. It's not for everybody. Remember, 95 to 98% of people with COVID will recover even if you don't treat them. So it's a challenge for us to identify this 2 to 5%. And I think those are the people who you need to give this kind of endothelium protecting agent. And perhaps you can sway the outcome or hospitalization, somehow prevent hospitalization. It's not for everybody. It's for high risk people and with damaged glycocalyx to begin with. But he is again doing another study post-COVID, this time post-COVID. But of course, he is inviting us to join him. It's something like that. But the test is thrombomodulin. That's the reason why I asked you about thrombomodulin post-COVID, because we don't have thrombomodulin here to test. And that's our limitation.
Any additional comments from Dr. Season or Dr. Abola?
Well, gentlemen first. Dr. Reyes highlighted already its effect on the coagulation and endothelium. I would say there's also some substantial anti-inflammatory effect of sulodexide. There were studies reported already that it has anti-inflammatory, so it can add up to the benefit if you give it in early COVID. No, it may arrest the progress of the inflammation, particularly those who are at high risk or with endothelial dysfunction. Yeah, that's my point.
Okay. Okay, I think I'm just allowed just one more question, which I will address to all three, maybe one or two liners in your clinical experience or your daily clinical practice. Who are the patients in whom you will give sulodexide when assessing both clinical efficacy and safety? For Dr. Abola, who are the vascular patients in whom you will prescribe it to? For Dr. Reyes, who are the cardiovascular patients in whom you will prescribe it to? And for Dr. Season, who are the high-risk bleeding patients or high-risk patients who you will be prescribing it to? Yes, Dr. Abola, ladies first.
Okay. Because of the effect size of the reduction of VTE by sulodexide, I would position it or choose it for patients who are at moderate risk for thrombotic events and at high risk for bleeding events because of the profile and the safety profile um, and the degree or extent of reduction of VTE. So that would be my choice. And again, if safety or bleeding risk is a concern, that would be my choice. More so compared to aspirin. And for PAD, um, I believe that there still needs to be a lot more studies done to take a look at its effect. But what is most interesting to me really is that there was a trend towards reduction in mortality in the PAD meta-analysis, and not just this meta-analysis, but another meta-analysis, an earlier meta-analysis of Professor Gadi. And I think that should be pursued because of the many uh, pleiotropic effects of sulodexide uh, to the endothelium and the overall cardiovascular system. I think that should be pursued because it keeps coming up as far as reduction or decrease in mortality is concerned.
Nice.
Dr. Reyes?
Remarkable. um, I was writing on my ano kasi, my notebook, all the patients whom I'm using Solidexide. I think it's basically the strength is on vascular disease. So I use it in CBI patient with venous ulcers, PAD sometimes. In diabetic kidney disease, those whom I have maximized ACE or ARB with proteinuria, because there are some people with macroalbuminuria. I use them in people with diabetic retinopathy, and I also use them. You know, these people are also high risk of cardiovascular disease. Once they develop MI, for example, or stroke, you shift now to a more high class 1A indicated drugs. But there are niche in people with CAD, those who cannot tolerate aspirin, those who cannot tolerate other antiplatelet agents. I use them, but of course, we need clinical trials. But sometimes the clinical trial is not yet there, and yet you need to decide. And that's the reason why sometimes there is a niche. And atrial fibrillation, for example, there are people who bled with warfarin, bled with DOACs, and sometimes you cannot use them anymore. And this is, you know, uh, uh, diseases where we need clinical trials. And I hope we can, of course, uh, do clinical trials on this type of population. And that's nice. That's nice.
Dr. Season?
Well, I think Dr. Eugene already touched already on the benefit of using sulodexide for people with high risk for bleeding. No, I would still emphasize on this type of population whom you need to anticoagulate or give antithrombotics because they have vasculopathies with high risk of thrombosis, but they are elderly, like septuagenarian. They have risk of upper GI bleed. They have past history of hemorrhagic stroke, and all of this profile of high risk bleeding status. Then I'm so afraid to give them potent antithrombotics, no, like DOACs, like aspirin, clopidogrel. So the best option is to give them sodexide, giving them protection while you um, maintain, the safety and preserve the benefit of this drug to this particular patient. I just would like to share also something like what Dr. Eugene shared about the diabetic nephropathy. I have very numerous observations in many of my nephropathic patients, so diabetic, hypertensive. Of course, the study was proven already on the microalbuminuria reduction. But what I also noticed, the creatinines, they are improving. No, this is off label. It's not reported in any of the studies, but in my practice, I see them improving in my patients with nephropathy. So those are just sharing my experience on Sudodexide. Thank you.
Thank you very, very much to our dear, excellent speakers. You've already heard the evidence, the translation of the evidence into data and clinical practice. And this was a no holds barred answering of the questions that you have posed with their clinical experience as background. I wish we had more time to entertain more questions. But I hope that in a few years' time or in a few months' time, we get more evidence that will impact our additional armamentarium for the treatment of our patients with vascular disease, cardiovascular disease, and those with risk factors, including our patients with early COVID-19. So have a good night, everyone. And I hope that you learned a lot in tonight's session. And see you in the subsequent days. Thank you.
Thank you, Dr. George Sison, Dr. Maria Teresa B. Abola, Dr. Eugenio B. Reyes, and Chairman Dr. Elaine B. Alahar. That concludes Day 1 of the PHA 51st Annual Convention and Scientific Meeting, Next Level Strategies. Thank you for participating and see you all again tomorrow. Good evening.